2025 to all the delegates with the theme of challenges, complications, and solutions. It's a pleasure to introduce the moderators for today morning session. Dr. Sahil Sanghvi, he is a joint replacement surgeon at Sancheti Hospital, and Dr. Vinayak Ghanate, who is also a joint replacement surgeon with Manipal Hospital, Baner. So this year for the Rising Star, we have 3 sessions, with each session having a Best Presentation Award winner. So it will be a 5-minute presentation that will be timed, followed by 1 minute of discussion, and then we will move on to the next presenter. We'll have 10 presentations in this morning's session at 8 a.m.
Yeah, and the awards will be given at the valedictory. So I think it's a competitive session. All the sessions we have kept some award, and this Shining Star we have 3 sessions in POSAC. So the best presenter who delivers at the right time, who delivers best presentation, will be decided by the moderators straight away, and the name will come to the committee. So I think we can start with the proceeding, Dr. Sahil. Yeah.
Yes, thank you.
I'll hand over to you, sir.
Yeah. Very good morning. We have 10 presentations and 5 minutes will stick to the time. If there is any question from the audience, please do ask at the same point. If it is exceeding the time, then we'll move ahead. May I call upon Dr. Abhishek Nagarajan.
Also, we invite Dr. Kiran Kharat to be on the dais.
So may I request the chair's permission to start?
Yeah, you can start. Can we also have the timer?
Good morning, everyone. I'll be presenting a paper on our minimally invasive approach for fixation for PCL avulsion fractures of tibia, experienced at our center. I'd like to just give a background. Isolated injuries of PCL are relatively rare. As a rule, ruptures of this ligament are associated with medial or lateral compartment disruptions, especially the latter. Clinically, however, isolated injuries can be caused by a fall on flex knee with the foot plantar flex. However, the most common mechanism still remains a motor vehicle accident where the knee's flex is like a dashboard injury. The treatment of these injuries are controversial, primarily because the natural history of avulsed PCL is unknown. A review of literature was done, first going through standard textbooks, Campbell, Turek, and then through published literature online as flashed. The summary of the ROL: surgery is recommended for displaced avulsion fractures with a defunct PCL. The limit described is 3 to 5 mm of displacement. Surgery achieves a higher rate of union, and surgery restores the AP laxity. There is no difference in union whether you do it through arthroscopic or open as per the present literature. The inference drawn, we have to fix the displaced avulsion fractures. There are several open and arthroscopic techniques described by surgeons worldwide. Now, which is the best approach? It should be fast, it should be easy to do, it should have good functional outcomes, and should be reproducible by everybody. Our experience, we have done a mini open incision technique for PCL avulsion fractures, and with our approach was through the medial head of the gastrocnemius. These structures to watch out for were the sural artery and nerve. The surgery was done with the patient on a prone position on a radiolucent table. Tourniquet was applied. Approximate time was 30 minutes, and anesthesia was spinal. These steps of the surgery as flashed. I'll be going through each of them through images. The skin and subcutaneous tissue was raised with longitudinal incision over the fibers of the medial head of gastrocnemius. The fibers of the gastrocnemius were divided by blunt dissection, keeping clear of the neurovascular bundles which are visible in the surgical field. The separated edges are held by Langenbach or a self-retaining, and the posterior capsule was visualized. At this point, the longitudinal capsulotomy is done, and the avulsed fragment is visualized in its entirety. It is marked in yellow. It can be palpated with fingers or with an artery forceps. A bite is taken through the substance of the PCL, which can be traced from the avulsed fragment with a heavy non-absorbable sutures. We used Ethibond. This assists in the reduction of the fragment when we pull this suture. The fragment is held with guide wires, and the position of the wire is checked under the image intensifier into the AP and the lateral view. The fragment is then fixed with a fully threaded 4 mm CCS with a washer. The capsule is closed with an absorbable suture, that is Vicryl, and the skin was closed with Prolene subcuticular. You can see the pre-op and the post-op radiograph. The post-op rehab, the patient was placed in a knee immobilizer for 2 weeks and then allowed weight-bearing ambulation with support. At 2 weeks, post-suture removal, the patient was allowed ROM of 0 to 90 degrees with an ROM brace and allowed to ambulate with the ROM brace. This is at 2 weeks, just after suture removal. Patient profiles are as shown. I want to bring attention to the mode of injury, where everyone had an RTA, that is fall from two-wheeler, except one who twisted his knee while skiing. All of them had at least a grade 2 posterior sag, which was an indication for surgical management, and few of them also were able to demonstrate quadriceps active test positive. The 8 patients operated by this aforementioned technique were operated after an evaluation with NCCT and MRI. NCCT was used to calculate the fragment size, and MRI was used to rule out any other intra-articular injuries. A signal within meniscus was noted in a few patients, however, ACL was intact in all of them. They were then followed up at regular intervals. At follow-ups, the patient showed good functional outcome and were able to ambulate and perform activities of daily living from post-op day 1. At suture removal, the patient showed a pain-free ROM of 90 degrees, which improved thereafter. All the patients were also examined and had no posterior sag by 3 months post-op. As you can see, the pain-free ROM was up to 90 at 4 weeks. Post-op CT scan was done for a few patients at 3 months, which showed signs of union. Coming to the results, the patient showed a gradual improvement in ROM up to 130 degrees by 3 months, and all the patients had no residual functional limitation. The same was corroborated by an improvement in the knee society score, which shows good functional scores by 6 months. Among the complications, there were no major complications that we encountered, no infection, no loss of fixation. There was only one patient who could not achieve a full RM of knee and still complains of some mild pain. However, he does not have any functional limitation. He is a waiter and is able to continue his work. He is presently being evaluated and planned for diagnostic arthroscopy as clinical features of meniscal injuries present at this time. Coming to the end, our limited incision approach for PCL fracture shows good short-term outcomes and improvement in pain and functional status. Advantage that we propose is a short procedure, minimal incision and exposure, good rates of union, good functional outcome, very short learning curve, may also be done by residents. And the limitation is we cannot address any intra-articular pathology, and it in the literature does describe an implant impingement for this type of fixation. Thank you.
Right. Thank you. In interest of time, I think we'll avoid questions here. Yeah, because it's already 5 minutes. Thank you. Thank you, Dr. Abhishek. May I call upon the next presenter, Dr. Sumedh Shirish.
Good morning, sir. Good morning, everyone. Presenting study of arthroscopic fixation of tibial eminence avulsion fracture with cannulated cancellous screw, result of 50 cases. ACL avulsion fractures are very common. Incidence is as high as 3 in 1 lakh of general population. In adults, it usually results due to high energy trauma, road traffic accidents, and sports injuries. Mayers and McKeever classified it into 4 categories. Type 1 was undisplaced fracture, Type 2 was partial displaced or hinge fractures, Type 3 was subdivided into 3A and 3B. 3A involved complete displacement involving only the ACL footprint, and 3B involving the entire tibial eminence, and Type 4 was complete displacement with fragmentation. Aims of the study were to evaluate the clinical and functional outcomes of the patients with ACL avulsion fracture treated by arthroscopic fixation with cannulated cancellous screw. This was a retrospective study with a sample size of 50 patients, with mean age of our patients being 29 years. All skeletally mature patients with closed acute displaced avulsion fractures were included. Any knee dislocations or ipsilateral concomitant fracture were excluded in the study. There were 39 males and 11 females enrolled. Standard arthroscopic surgery was followed with anteromedial and anterolateral ports. Anterolateral ports used for the video and anteromedial as working port. ACL avulsion fragment was identified. The crater was freshened. Reduction was achieved using a hook probe or ACL guide. Then the reduction was held temporarily by using guide wires, and confirmation was done under image intensifier. Final reduction and fixation was done with 4 mm CCS screw. A second screw was inserted if the fragment was large. Post-op protocol, we started immediate hinge knee, mobilization and range of motion exercises with using hinge knee braces. 8-week post-operatively hinge knee brace was discarded. Intra-op and post-operative assessment were done by using IKDC scoring scale, Lishom knee scoring scale, and KT1000 scoring. The observations of the study were Type 3 was the most common type in our study. Post-operative hospital stay was 4 days. Average time from injury to surgery was 2 days, and mean follow-up of the patient was 33.6 months. We observed in the study that Lishom knee score demonstrated a trend of improvement from poor or fair at 1 month to good or excellent in 85% of patients by 1 year. The IKDC grading at 1 year revealed that no patients were classified in grade C, with 62% of patients in grade A and 38% patients in grade B. Range of motion showed improvements from the 1 month to 1 year, starting at 75 degrees at 1 month and 136 degrees at the 1 year. There was no statistical significance difference between the mean KT score. 2 patients developed stiffness in form of flexion deficit. Due to intraoperative fragmentation of the avulsed fragment, ACL reconstruction was done for 3 patients. 4 patients opted for implant removal, although they were asymptomatic. All patients returned to their pre-injury activity level. No patients had surgical site infection, implant failure, non-union. There was no notch impingement or terminal restriction in the range of motion immediate to post-fixation. This is a case of 30-year-old male with right knee ACL avulsion. We can see the full range of motion. This is another case of 40-year-old male with left knee ACL avulsion. We can see the range of motion. To discuss, Yahan et al. In 2015 used arthroscopic suture fixation for ACL avulsion fractures and obtained a LKSS of 96 and mean IKDC score of 94. Sudarsarajan SR in 2011 used arthroscopic staple fixation for ACL avulsion fractures and obtained an IKDC score of 91.1 and Lysholm knee score system of 95.4. We were able to replicate similar results with arthroscopic fixation in anterograde CCS, demonstrating a mean LKSS of 97.3 and IKDC of 93.5. Furthermore, to discuss, Sukoda in 2005 compared initial fixation strength among 3 fixation techniques of ACL avulsion fracture and concluded that anterograde screw fixation is most effective. And Senkovic in 2003 showed that only anterograde fixation with cannulated screw is considered to have enough stability for initiating immediate mobilization and weight bearing. Screw fixation also seems to have the most equivocal outcomes when all previous methods are compared. This was the conclusion of the study. The limitation of our study were lack of long-term follow-up in a retrospective study, single method of fixation. All the surgeries were performed by single senior surgeon at a single tertiary center. Thus, to conclude, our study showed that arthroscopic reduction and fixation with cannulated cancellous screw is an effective method to manage tibial eminence avulsion fracture. We achieved clinical and functional outcomes compared to other studies reporting using various methods of fixation. Thank you, sir. Any questions?
Thank you. Thank you, Dr. Sumed. Any questions for Dr. Sumed? Right. Thank you.
Thank you, sir. Thank you so much.
Shailesh, have we got time for questions or we'll take it at the end? In the audience, anyone? Kunal?
Sir, yes, sir, please. No, sir, please.
So what was your difference in the extension lag with a suture disc and a C-screw screw, number 1?
Sorry, sir, I didn't get the last part.
So the 2 comparisons that you showed with the previous study, you did a CC screw, right? An antegrade CC screw. Was there any incidence of extension lag in any of those patients post-op?
No,
so
sir.
that has not been mentioned. So
No,
that
sir.
is one fallacy of your paper. Second thing is, did you use any criteria as per the fragment size? Because again, the indications for both are slightly different. So you've not mentioned that as well.
So it was a retrospective study, so
Okay.
the criteria that was used by the previous were not available for us.
Okay.
So we just compared the functional and clinical outcomes.
Justified.
Yes, sir. Thank you, sir. Any other questions?
Yeah, next speaker, and that was an important point, Kunal, because the fragment size and the screw, can be an issue.
In one case, you have used 2 screws. What was the reason for that?
Sir, if the fragment is big enough, that is more than the 3 times the diameter of the screw head, then we use another screw.
And when there is a fragmented 2 pieces, then what do you do?
So we use a CCS screw with a washer. If there is a multi-fragmented, then
No,
we...
CCS screw will washer with work for only 1 piece, not for 2 pieces. 2 individual pieces require
Yes, sir.
different method of modality of treatment.
So then in our center we used a suture fixation instead of a CCS screw, where there was no possibility of CCS screw.
Thank you. Thank you.
Thank you, sir.
Let's get the next presenter, Dr. Surya. His paper is on functional and radiological outcomes in non-union distal and femur fracture operated with bicondylar plating.
Good morning, sir. Today
Today I'll be presenting a paper on evaluating the functional radiological outcomes in distal femur fracture non-union treated with dual fixation. So distal femur non-unions are difficult to manage due to they are prone to non-union due to high mechanical stress, poor vascularity of the fragment, short distal fragment. In cases where lateral plating alone is done, usually, especially in cases of metaphyseal comminution, there leads to varus collapse and fixation failure. So dual plate fixation provides a better stability by providing the support to the medial cortex. The primary aim of this study was to evaluate the functional radiological outcomes of dual plate fixation in distal femur fracture non-unions, with secondary aims to assess complication rates, measure improvements in knee function score using SF36 and Lysholm scores, and determining the time to radiological union postoperatively. This was a retrospective study done at a tertiary care center with a sample size of 25. The inclusion criteria was diagnosed non-infected non-unions. Cases which had infection, pathological fractures, or other associated limb fractures were excluded from this study. Surgery was done in the form of implant removal and refixation with dual locking plate. Iliac crest grafting was used when the medial void was less than 2 cm, and allograft was done when there was a medial void more than 2 cm. Alignment was confirmed via the biomechanical axis alignment was confirmed via CM and cable method. Knee RM was started on day 2 of surgery, with partial weight bearing started at 4 to 6 weeks. Full weight bearing was started at around 3 months when there was evidence of radiological union. Assessment tools used were for functional outcomes SF36 score, Lysholm knee score, and RM were used. For radiological time, radiological testing time to union results. So all patients achieved radiological union. The average time for union was 5.22 months. Knee range of motion improved from 20 to 40 degree post-operatively to 130 degrees at 12 months. SF36 score improved from 48.6 to 96.06. Lysholm score improved from 34.48 to 98.2. All improvements were statistically significant with a p greater than 0.05. 3 patients had 10-degree flexion deformity, 1 patient had implant irritation, and 1 patient had knee stiffness requiring adhesiolysis. No infection cases were reported. So this was a case of a 40-year-old sustaining grade 3B distal femur fracture. So this is his knee RM at the end of 12 months. A case of a 64-year-old sustaining a closed distal femur fracture with non-union. And this was a case of a 54-year-old with fixation done elsewhere, retrograde nail, and RM at the end of 12 months. So we can conclude that treating distal femur is difficult due to poor bone quality, difficulty in providing stable fixation. All 25 patients achieved union at the end of 5.22 months. This is similar to other studies like Mukhopadhyay et al. And Kanakeshwar et al. Knee flexion improved from 30 degrees to 130 degrees. So we can conclude that dual plate fixation with bone grafting is effective for managing distal femur non-union. It ensures rigid fixation, neutralization of deforming forces, and solid osseous union due to stability, bone grafting, and osteoperiosteal flaps. Significant improvements in knee mobility and function can be seen. Thank you, sir.
Thank you. Thank you. Can you keep the screen on one of the case X-rays? Any questions, please? In the index surgery.
Yes, sir.
And the metaphyseal, diaphyseal fixation was left, not done by the primary team.
Yes, sir, it was not.
Okay. And how was it treated, this case?
Sir, it was treated later with dual plate fixation.
Oh, no, not you, by the primary team.
Sir, X-fix. External fixator was used.
External fixator.
Yeah.
Okay, okay.
It was a compound fracture, sir.
Right. Any questions?
So this was a retrospective study.
Yes, sir.
So when you did this study, did you compare this with any other modalities of fixation, like a hybrid fixation, using an intramedullary device with an extramedullary device?
No, sir.
So no such comparison.
No comparison.
When you did your literature backup, did you find any studies? Because that would be a more relevant topic to compare between the two modalities rather than an isolated modality. Yes, bipillar plating is a recommended modality, but probably next time you can also compare intramedullary hybrid fixation with a complete internal fixation.
Yes, correct, sir.
Yeah, that's absolutely right, because the evidence says that the nail plate interlinked combination has the 100% union rate compared to the bicondylar plating. Right. So that evidence would have been helpful here. Thank you.
Thank you, sir.
I call upon the next speaker, Dr. Sukrut. He is going to speak on giant cell tumor of flexor tendon sheath of fingers, a case series.
Good morning, everyone. I'll be speaking about a case series on giant cell tumor of tendon sheath. Introduction. Giant cell tumor of the tendon sheath are benign nodular tumors that develop on the tendon sheath of the hand and the feet. Second most common hand tumor, presenting in the 3rd to 4th decade of life, and also known as localized nodular tenosynovitis, is distinguished by the presence of multinucleated giant cells throughout the body and the proliferation of synovial-like cells. It is commonly associated with tissue swelling, bone erosion, has been reported in advanced cases. This entity was previously thought to be a reactive process, an inflammatory process caused by chronic antigenic stimulation or reactive proliferation of tendon sheath and joint synovial lining. It is now classified as neoplastic pathology. Local excision with preservation of the underlying tissues, digital arteries, and the nerves is the accepted treatment. The tumor is usually surrounded by a pseudocapsule. There is a high incidence of satellite lesion which require a thorough examination. Curettage to remove the cortical shell is recommended if the underlying bone shows erosion. Local recurrence is nearly 14%. These are the case reports. Case 1, a 43-year-old female patient presented to the orthopedic department with a history of swelling over the volar aspect of distal phalanx of left thumb since 7 months. Examination shows painless swelling, which is 5 to 2 cm in size, hard in consistency, mobile in horizontal direction, was not adherent to bone and the skin. Patient had no restriction of movement of thumb. So, ultrasound shows solid hypoechogenic lesion around the tendon of volar aspect of left thumb. There is no evidence of vascularity or calcification. X-ray shows X-ray of the left hand shows erosion of distal phalanx of left thumb. So fine needle aspiration cytology yielded smears which were cellular and numerous scattered stromal cells with interspersed multinucleated giant cells. MRI of left hand yielded a lobulated T1, T2 weighted hypo-intensity mass arising from the flexor pollicis longus tendon at the proximal part of the distal phalanx of the thumb with erosion. So the procedure done was excision and the biopsy under wrist block and digital tourniquet. Culvarinear incision was made over the proximal phalanx of left thumb. Blunt dissection was done under microscope and a pseudocapsule was found to cover the tumor. The tumor was isolated from the underlying tendon and the tendon integrity was found to be intact. The wound was closed, the mass isolated was globular and gray-white in color, measuring 12 mm in diameter. So this is the entropic and the size of the tumor. So histopathology showed well-circumcised tumor containing clusters of osteoclastic giant cells surrounded by round 2 spindle with mild pleomorphism containing moderate amount of eosinophil cytoplasm and vesicular nucleus. Scattered mitosis was noted. Stroma showed hemosiderin-laden macrophages, areas of hemorrhage, and lymphoplasmacytic infiltration. Case 2, a male, 44-year-old male, presented to orthopedic department with swelling over the volar aspect of middle phalanx of left little finger since 1 month, which was painless. The examination showed firm swelling 1 by 1 centimeter present over the volar aspect of middle phalanx of little finger of left hand, which was horizontal which is mobile in horizontal direction. So investigations, ultrasound showed hypoechoic lesion, and then FNSC yielded multinucleated giant cells with interspersed with mononuclear cells with round nuclei and hemorrhagic background. X-ray didn't show any bony erosions on the underlying bone. So MRI showed iso-intense in T1 hypo-intense and T2 and short T1 inversion recovery hypo-intense. So procedure was excision and biopsy under wrist block and digital tourniquet. The sample obtained was grey white in color and spherical in shape with diameter of 11 mm. These are the intraop and the size of the tumor. So histopathology also showed numerous spindle cells with interspersed giant cells. Case number 3, a male patient, 29-year-old, presented with the history of swelling over the lateral aspect of proximal phalanx of right hand, little finger, for 2 months, which was painless. So the swelling was 3 by 2 centimeter, mobile in horizontal direction, and was hard in consistency. No restriction of movement as complained by the patient. The investigations, ultrasound showed heteroechoic lesions, and the lesion was extending to.
Dr. We will hold because the time is up. Anybody
Sorry.
has any questions? Please.
Do you do FNAC in all the cases? Like you mentioned, what is your sequence of diagnosing them, and what do you do?
So first FNAC was done to rule out any neoplastic changes of the tumor, sir. And then we.
So in how many cases did you see is
Sir,
any new? How many? You have 15 cases.
So 3 cases, sir.
This
Total
is a 3 cases series.
Yes, sir.
Okay. Because usually they are encapsulated and benign tumors. So excisional biopsy is the standard of care. You do an MRI and then you can directly do an excisional biopsy then rather than subjecting to FNAC. Where do you do the FNAC? In the operating room or in the how is that procedure?
So usually we want to maintain a sterile field, so we taken up in OT itself, sir. So it was done in the OT, yes, sir.
Okay.
As rightly said, FNAC is indicated when the lesion is soft.
Yes.
Here the matrix is firm, cellular matrix. So you need a core of the tissue. Second point, what I felt was, is there any chemical method added to this to prevent the local spread? Because when you do excision, the surrounding tissue
Yes,
needs to have some treatment either with phenol or some chemical modality, or use argon laser.
So as such, no chemical modality was used. There was local exploration to rule out any satellite lesions was done, sir.
The third case you did not complete, but
Yes.
was there any use of high-speed bursts done for the cortical saucerization?
No, sir. No, sir.
No. Okay. Right. Thank you.
Thank you, sir.
May I call upon the next speaker, Dr. Karthikeyan. He is going to speak on comparison of posterior tibial slope and metaphyseal-diaphyseal angle in osteoarthritis patients and normal adult population.
Good morning. Myself, Dr. Karthikeyan from Rajarajeshwari Medical College, Bangalore. My topic is going to be comparison of posterior tibial slope and metaphysio-diaphyseal angle in osteoarthritic and normal adult population. Osteoarthritis is a chronic degenerative disorder which has become increasingly prevalent in the modern era. It is a leading cause of pain, disability and loss of quality of life. The biomechanical analysis of the knee, in that posterior tibial slope and metaphysio-diaphyseal angle play an important role. The aim of the study is to compare PTS and MDA and find its relation between osteoarthritis and its progression. The need for the study, many studies have been done on the coronal alignment of the knee, but there are very limited on the sagittal alignment. So in this study, both posterior tibial slope and MDA will be taken in the lateral aspect as in sagittal plane. Materials, this was a cross-sectional study done in the patients of OPD in our college, in orthopedic OPD, and the study design is cross-sectional. The measurement of PTS has been performed using lateral knee radiographs where a perpendicular line has been drawn to the axis of the tibial shaft and the tibial slope has been measured according to that perpendicular. The normal PTS is varying from 6 to 12 degrees. The metaphysio-diaphyseal angle is measured as an angle between the axis of the tibia in the lateral aspect and the axis of metaphysis. The inclusion criteria is patient over 40 years of age with radiological degenerative changes and a patient with over 40 years of age without radiological changes as normal population. Exclusion criteria is any history of acute trauma is excluded from the study and history of prior surgeries in the knee is excluded. Observation, we have taken 128 patients in this study, out of which 64 was with OA and 64 was normal population. The sex distribution was 41% male and 59% female, and the age distribution is given as such. This is an example of the study which has been done. This is the posterior tibial slope. The first image shows the posterior tibial slope in an osteoarthritic knee, and the second one shows the posterior tibial slope in a normal knee without osteoarthritic changes. And this one shows the metaphysio-diaphyseal angle in the osteoarthritic knee versus the normal knee. Similar examples have been given in other patients also, where we can see an increasing trend in the posterior tibial slope and the metaphysio-diaphyseal angle in osteoarthritic knee as a gradual progression. The results of the study: the metaphysio-diaphyseal angle and posterior tibial slope both has been found to be higher in osteoarthritic patients than in normal population. Here up to 25.02 was the average in osteoarthritic patient for metaphysio-diaphyseal angle, and 19.36 was the normal metaphysio-diaphyseal angle average, and posterior tibial slope was up to 13.89 as an average and 9.97 in the normal population. This is the interpretation for sensitivity and specificity. And in posterior tibial slope, it is 98.4% sensitive and 96.9% specific in this study, and metaphysio-diaphyseal angle is 98.4% sensitive with 89.1% specificity. The p-value of both the variables was less than 0.05, indicating positive correlation between the said factors and osteoarthritic progression. This is a comparative study. This is compared to another study done by Arun in Kilpauk Medical College, Chennai, of a similar study of comparing these two angles with osteoarthritic knees, and we were able to produce similar results and similar results of the study. In conclusion, our study finds that the posterior tibial slope and the metaphysio-diaphyseal angle increases with arthritis and has a moderate correlation between them. This also serves as a marker in detecting early arthritis with good specificity and sensitivity. Thank you.
Dr. Karthikeyan, why do you think you had higher posterior tibial slope in arthritic patients?
I didn't get your question, sir.
You said you had higher posterior tibial slope in the arthritic population.
Yeah, sir.
Why do you think that was there?
Because of the joint biomechanics, which will be altered, and which will cause progression into osteoarthritis, sir. Our study is comparing the posterior tibial slope, which is progressing in osteoarthritic patient.
Correct. So the medial and lateral tibial slope are both different.
Yeah.
If you see, the medial plateau and tibial plateau are both different. And when you have osteoarthritis, you will have wear on the medial
medial
plateau.
slope, because the medial condyle will be bigger and there will be more rollover.
There is more wear on the medial side. Rollover happens on the lateral side. So the fallacy is that both slopes are going to be different. So your X-ray is not going to be very accurate as compared to a CT scan in diagnosing that.
Okay.
Adding upon to that, thank you for bringing this topic, because this is generating a lot of interest in arthroplasty community, especially after CPAC classification. But X-ray would not be a sufficient investigation, because if you go on your X-ray images, was there any method used to ensure the lateral exposure of the knee is matched between every patient? Because some of your X-rays are showing the condyles are not...
Yeah, the condyles are not aligned in some of the X-rays, but in most of the studies, it was aligned and the X-ray was taken properly.
Yeah, so that needs to be ensured for every patient, otherwise the calculations are going to be wrong. And as Dr. Sahil said, that the slope is going to be different for both the plateaus. So CT would be a better investigation to comment upon the slope. Right, thank you.
While the next speaker comes on the stage, are you aware of there are different slopes medially and laterally as well?
No, sir. This study was done only as a general study.
Normally?
No,
sir.
So
the medial tibial plateau and the lateral tibial plateau have different slopes as well.
Okay.
So, yes, next speaker can come on stage.
Dr. G. Pawan is going to speak on a prospective study of functional outcome of distal radius articular fractures treated with volar locking plate.
Good morning, everyone. Myself presenting about the prospective study of functional outcome of distal radius articular fractures treated with volar locking plate. Introduction: distal and radius fractures continue to difficult to treat. Intra-articular and extra-articular malalignment can cause variety of complications such as post-traumatic arthritis, reduced grip strength, restricted motion, and carpal instability. It is recommended to do an internal fixation to treat unstable and intra-articular fractures of distal radius that cannot be reduced by closed methods or that cannot be maintained by ligamentotaxis. Our aim of the study is to assess both clinical and functional outcome of distal radius articular fractures treated by open reduction and internal fixation using volar locking plate. Methods. Here we use 20 patients we did study with intra-articular fractures of distal end radius were treated with volar locking plate, satisfying inclusion criteria admitted in Rajarajeshwari Medical College Hospital, Bangalore. So follow-up period we took 24 months and functional outcome assessed by Gartland-Verley demerit scoring system. So inclusion criteria, we took a patient age of more than 18 years and patients of either gender, closed fractures, open fractures type 1 Geisler-Anderson classification and AO classification of type B or C. And exclusion criteria was undisplaced fractures and open fractures of type 2 or 3 Geisler-Anderson classifications, pathological fractures, neglected fractures more than 4 weeks, and history of previous wrist pathology or malunited distal radius fractures. So we did case studies in a follow-up period of immediate post 6 weeks, 3 months and 6 months. So at the 3 months and at the 6 months we found there is improvement, significant improvement in palm of flexion and supination. So the age group, most common age group is 41 to 50 years in between. So around 40% of patients. So this is the results we found, and this is the side involved, most of them right side, and mode of injury is majority of them from road traffic accidents. And by the 8 to 12 weeks, there is a 80% of union occurs. So this is the table of showing the percentage of the functional outcome using in 17 or 85% patient had dorsiflexion radial deviation within normal range of motion, and 90% of patients having palm of flexion and pronation within normal range. 95% has normal range of supination and ulnar deviation. 10% of patient has a complaint of wrist pain at the end of the follow-up. So these are the graphs showing the result according to Gartland and Verley scoring system. Of that 35%, 70% of the patients had good results, and only 20% will have the fair results, 10% will having poor results. So the discussion, the most common upper extremity fracture is the distal end radius. Maintenance of anatomical relation and functionality is the fundamental goal for treatment. It is difficult to maintain the articular integrity by closed techniques in unstable intra-articular fractures. Various surgical procedures and materials for fixation can be employed in circumstances where an open technique is necessary. Distal radius fractures of the type B and C types are treated surgically as they are intra-articular and unstable. Open reduction and plate fixation is most extensively used as surgical techniques today. So anatomically counter plates with screw plate interlocking characteristics has better strength against stress applied to fracture surfaces. The volar method has grown popularity in recent years. So the conclusion is locked plates which are commonly utilized has proven effective. Because of its fixation strength, this approach allow for the early joint mobilization, and volar method allows for both axis and fixation with less surgical stress to distal radius, better adaptability to the surrounding tissues. So the use of locking compression plates in the maintenance of distal radius anatomy is favorable and provide good to outstanding results in distal radius fractures. Joint movements and daily functioning are regained in less time when these plates were used. Thank you.
Thank you. I think Dr. Vijay has a question.
You have mentioned fair 20% and
poor results
10%.
10%.
What are the causes? One question. Second question, I have not defined Snook's criteria. So, do you face the tendon rupture because the plate is a little bit proud?
Sir, at the end of the follow-up, in between 3 to 6 months, we found 10% of the patient has developed some wrist stiffness and extensor pollicis tendon rupture. So some patients is having the wrist pain due to carpal instability. That after 6 months, the same patient has results were good. There is no wrist pain, but still 2 patients were developed continue to be having a wrist pain.
So what is the criteria for poor result?
Sir, criteria for poor result. So according to Gartland-Verley scoring system, there is a objective evaluation. We did subjective evaluation, and there is a painful at the wrist joint. Based on that, we gave one score, sir.
So only pain is defining for poor result.
Yes.
Okay, thank
So
you.
we'll move on to the next speaker. Thank you.
Thank you, sir.
Next speaker is Dr. Umesh Nagre, and he's going to speak on 2 to 4 year follow-up results of total knee arthroplasty using a new high flexion prosthesis. Thank you.
First slide, please. Can you put the first slide, please? Good morning, everyone. Today I'm going to share my experience about the 4-year follow-up result about the TK using the high flexion design. So no royalties and research support I got from the Vishwaraj Hospital and ethical committee approval. So in TKR, deformity correction and ligament balancing in TK, using the high flexion implant is always a challenge. So choosing this implant is an important issue. So when I chose the implant and decided to go ahead, the implant is femoral component cobalt chrome, tibial components of cobalt chrome, 3-peg patella is there, and tibial extension rods, they are also cobalt chrome. So this is a design, I will not go into details. And they have PS and CR and tibial tray. So I wanted to know that what is the tibial slope when I deciding to use this implant. And these are tibial insert, they have CR insert and PS insert. So when I decided to go ahead to use this implant, so main study which I decided to go ahead is a femoral dimension, APML dimension, and tibial also APML dimension, whether they have wedges and whether they have the extension rods also, if required, in particular cases with the deformities and loss of bone. Then I decided to go ahead and do the comparison between the implants. What implant I am using, what are the implants available in the market since the last time, so many years. So anterior flange, ROM, PS cam mechanism, Q angle, same femoral component. I decided to look for the distal condylar thickness for the high flexion designs. Jump distance also, so compared both, and APML dimension I mentioned about the femoral components. And then tibial components, look for the keel mechanism, locking mechanism, keel angle, and of course APML dimensions. And same thing about tibial component, went ahead and compared with what are the implants available in the market for their comparison of the sizes. So also the 5 million cycle is important, because when you talk to the patient, you have to give them that why I am using this implant. So tibial component, they have the thickness of the 10, 12, 14, 16 and 18. And seen the other features also, articular options, conformity ratio. So 125 knees, 94 females, 19 males, 5 rheumatoid patients, other remaining patients were osteoarthritis. Combined spinal epidural standard method, medial parapatellar approach, midline skin incision, and did HSS scoring, modified HSS scoring, WOMAC and KSS scoring. So few cases, severe varus case, this is the pre-op video. So this is a post-op, immediate post-op, and these are after the 3 years. So other cases I will just go through. 69 with the wind sweep deformity, one-sided I needed a rod. Then 75-year-old female with the normal varus knee, severe varus knee in 79. Then valgus knee with the bilateral valgus deformity, 88-year-old, 66 with the bilateral valgus, then 62. So there are several deformity, and we use this implant. So follow-up was 3 years. HSS score has improved from 48 to 91. Then tibiofemoral alignment improved from 20 to 5 degree valgus. Mean range of movement improved to 140. And there was no progressive radiolucency seen up till now on this X-rays. So this is range of movement, improvement in KSS score, improvement in WOMAC score, And in complication wise, we had a superficial wound infection in one knee after 3 years, which was treated with the antibiotics and got resolved. There was a transient peroneal nerve palsy, one of the valgus knee after release, which was improved. So in conclusion, new high flexion implants have improved post-op range of movement comparable to the other high flex TKS design in the market. So no aseptic loosening at early follow-up and no premature material failure or unusual biological response to new bearing material. Thank you.
Thank you. Thank you, sir. All the cases were PS or CR or it was a
All
mixed match?
PS.
All PS.
All PS.
Okay.
For the comparison, I particularly chosen the PS implant and only involved those cases.
Yes. Thank you. Any?
So is this a new implant or what?
This is a new implant. This is one of the new Indian implant. That's the reason I did the whole comparison.
So this is an Indian implant?
Yes.
How did you decide in which patients you wanted to use this? Was it a consecutive series or
No,
randomly selected?
the patient was given the choice basically, and their consent was taken that okay, we are going to use this implant, and their consent was taken, and patient has given the choice whether they want attune or new flexion, high flexion design, and the material was also supplied to them.
Because one of the criticisms of high flex designs has been higher rates of aseptic loosening at 8 to 10 years.
Yeah.
That is at mid to long term follow up. That has been one of the criticisms.
We are going to do the long term follow up for doing that one only. That they have proven that in high flexion design we use for the patient, but because of the high flexion they get loosening after like 10 years down the line.
What was the average range of flexion the patients had post-operatively?
It went from 78 to 140, so you can say like 120. And for the Asian population, high flexion is the most like demanding when they come to you. Can I sit down and do all the functions?
Thank you.
So just one question, if I may. We had this issue discussed maybe around 5-6 years back, high flex designs, whether they really work. So do you think high flex is a function of the flexion gap that you achieve on table, the preoperative range of motion the patient has? And how much does the implant contribute to the flexion besides these factors?
Yes, doctor, you are correct. The first thing is removal of the osteophyte, posterior osteophyte. Though you use a high flexion implant, not removing the posterior osteophyte, it's not going to work. So your basics never change. So high flexion design is only the posterior condylar thickness, distal condylar thickness, which is like a 10 millimeter is there, minimum. That then you think about the high flexion, but basics will never change.
Yeah, no, my question was, so this debate has been ongoing, we all know, and correlation of flexion with the design of the implant, high flex design lead to more flexion. This has been negated in the literature a lot of times. So what's your opinion on that?
No, see, this is a very short-term follow-up, but we need a long-term follow-up. As you mentioned that definitely there is improvement. It's not much, it's 5 to 10 degrees if you see the whole cohort.
Okay. Thank you.
Thank you, Dr. Nagri. So we'll move on to the next in essence of time. Efficacy of long versus short PFNA2 implants. The speaker is Dr. Omkar.
Good morning, sir. Good morning, everybody. Presenting our paper, which mainly focuses to determine the efficacy of long versus short PFNA2 implants in intertrochanteric femur fracture fixation. As we know that IT fractures are mostly present in the intertrochlear, intercondylar ridge and posterior distal to the hip stabilizers and the ligaments. It accounts for nearly 50% of the hip fractures, which incidence increasing with the aging population. The main modality of treatment in this is the surgical modality, which traditionally was the surface fixation modality, which has evolved to the present intramedullary nailing. This is important because this further dictates our management options. There are various classifications like the Boyd and Griffin classification, Tronso's classifications, Evans with Jensen's modification, which we'll further see in the study. The main aim of this study is to compare the efficacy in terms of radiological and functional outcomes of the use of long and short PFNA in intertrochanteric femur fractures, and also to assess the post-op complications related to it. So this is a prospective cohort study of long versus short PFNA, in which all the intertrochanteric femur fractures has been included with the age group more than 18 years of age. The patients less than 18 years who are having subtrochanteric femur fracture extensions and the pathological fractures and the previous history of implant use or revision surgeries has been excluded from this surgery. The criteria for the comparison is mainly the functional comparison is mainly done on the Harris hip score and the post-op complication, as well as mean surgical time, the mean blood loss during the surgical procedure, the mean duration of hospital stay, the mean post-op ambulatory status, the mean time required to attain the full weight bearing as well as SLR recovery, as well as the radiological comparison is done on the basis of the mean time taken for the union. So there are 153 patients total enrolled in this study, has been divided into two groups, that is group A with the long PFNA2, of which 76 cases have been enrolled, and group B is the short PFNA with 77 cases, having the mean age group in group A as 67 years compared to 68 years in group B. So here is a statistical comparison of all the intergroup parameters. Comparing the mean blood loss in the short PFNA was 88.5 ml compared to 87.6 ml in long PFNA, and the surgical time in long PFNA was 34.25 minutes compared to 35.5. So there is no statistical significant difference seen in the long versus short PFNA implants. Also, the post-op ambulatory status in household and social ambulation, as well as the post-op hospital stay, which was seen in the long PFNA to be 3.08 days compared to 3 days in short PFNA, that there was no statistical difference. There was no statistical difference in the full weight attaining full weight bearing, as well as time required for the duration, duration for the union, which was our radiological marker. And so we can see that the significant difference was seen in the SLR recovery. The mean time which was taken for SLR recovery in long PFNA was twice less than that of the short PFNA, which was 2.14 days compared to 3.8 days. So there was statistical difference seen in SLR recovery in a long PFNA. The Harris hip score, which was our functional criteria, which mainly includes the pain assessment as well as the deformity and the range of motion, was seen equally in both long and short PFNA. However, the complications which we see are very rare with the use of intramedullary nailing. The complications like implant backout, medial blade penetration and peri-implant fractures were noted. Of the 76 enrolled long PFNA, there was only one case with implant backout and one case of blade penetration and peri-implant fractures in short PFNAs. So there was no significant difference in the complications as such. To interpret that, we have interpreted the functional outcomes on the basis of the Harris hip score and the radiological outcomes on the time taken for the union. We say that the short PFNA has advantage in more simple type of fractures, whereas long PFNA are preferred in more complex fractures such as the reverse oblique fractures or the subtrochanteric fracture extensions, which requires the extra stability. Therefore, both the long and short PFNA are effective in treating the intertrochanteric femur fractures. However, the complications which were seen were low in both the types. To discuss, Christopher Boone in his study focused that there is no significant difference in terms of hospital stay, which aligns with our study. To conclude that both long and short PFNA implants have good clinical outcomes in treating the intertrochanteric femur fractures. However, there was no statistical significant difference in the post-op ambulatory status, the mean time taken for the surgical time, mean blood loss. However, there was significant difference in the active SLR, which was attained in long PFNA much earlier than that of short PFNA. Thank you, sir.
Thank you, Dr. Onkar. In essence of time, we'll move on to the next presentation. No questions. May I call upon Dr. Akhilesh, who is going to speak on intramedullary nailing as an effective alternative to plating for far distal third tibial fractures, extreme nailing.
Good morning, everyone. Thank you, everyone, for being here. My name is Dr. Akhilesh Gokhale, and the title of my presentation today is Intramedullary Nailing as an effective alternative for proximal and far distal third tibial fractures, that is the extreme nailing. To start with, Of all the tibial injuries, far proximal tibial fractures account for 5 to 11%, and far distal tibial fractures account for 7.5%. Traditionally, these fractures are treated by plating. However, in view of complex anatomy, high degree of comminution, and associated soft tissue trauma and swelling, it may result in high complication rates, including infection and delayed functional outcomes. Thus, intramedullary nailing emerges as a viable option, offering a minimally invasive approach, and it also preserves soft tissue integrity while providing stable fixation. To classify, AO has classified these fractures, extreme fractures, to the far proximal and far distal tibia, that is 41A2 and 3, and 43A1 and 3 fractures, within approximately 4 centimeter of the tibial plateau or the tibial plafond. Extreme nailing, this term was given by Sean Nock et al. In 2003. It is defined as nailing in those fractures which were conventionally plated, but by minimally open or fully open approaches, and which are now treated by closed nailing, that is far proximal and far distal end of the fractures, with exception of intra-articular extension or combination. The aim of this study was to evaluate the viability of nailing in two groups, that is the proximal third and the distal third tibial fractures, also to analyze the radiological and functional outcomes of closed nailing in proximal third and distal third tibial fractures. This was a prospective and retrospective study in which 30 patients were taken into consideration, 15 from each group, that is the extra-articular far proximal tibial fractures and distal tibial fractures, which were not extending into the joint space. All patients were treated with locked intramedullary nailing. Suprapatellar nailing was done for proximal tibial fractures, and patellar tendon split approach, that is the standard approach, was taken for far distal tibial fractures. All the closed fractures and open fractures up to Gustilo-Anderson 3A, extra-articular fractures for proximal and distal tibia was taken into consideration, along with fibular fractures in tibial, associated with tibial fractures. All the intra-articular fractures of proximal or distal tibia were excluded, along with cases of polytrauma, other fractures presenting in the same limb, and open fractures with Gustilo-Anderson 3B and onwards. This is a tibia nail advanced. It features its multiplanar locking pattern, which provides 5 proximal locking options and 4 distal locking options. There's much more angular stability. It provides low profile locking screws and better anatomical bends. Talking about the outcome, functional outcome was assessed for proximal tibia fractures using Knee Society score and SF36 score, and for distal tibial fractures it was evaluated using AOFA score and SF36 score. Radiological assessment was done on every follow-up post-op x-rays, and evaluation was done on the basis of presence of callus across the 3 cortices on every visit. Postoperatively, immediately postoperative, 1 pillow elevation, static exercise and range of motion exercises were started. Non-weight bearing walking with walker or crutch support was started on postoperative day 1. For 6 weeks, patient was kept on non-weight bearing walking with walker support, and gradual follow-ups, 25% increase was done on weight bearing every 2 weeks. To discuss about the results, radiological outcomes. Radiologically, out of 25 patients, 9 patients achieved union within the first 3 months, 12 patients achieved in 6 months, and 3 patients achieved the union by 12 months. Talking about the functional outcomes, for proximal tibial fractures, Knee Society score over a period of 1 year showed gradual increase, which was significant, and SF36 score showed the same increasing trend over the period of 1 year. Talking about the distal tibial fractures, AOFA score at post-operative was 27, which increased steadily over a period of 1 year to 98. SF36 score also showed an increasing trend. This was one case. Over a period of 1 year, this was the right distal tibial fracture. Talking about the complications, there were minor complications including implantive bursitis, implantive pain and bursitis. Major complications included non-union and delayed union. Nailing provides offers superior angular stability, enhanced locking options, and anatomical bending. The limitation of this study was small sample size, and the data could not be compared with plating. To conclude, the indication of intramedullary nailing now includes proximal 1/3 tibial and distal fractures. It has minimal infection rates and good radiological as well as functional outcome. Thus, extreme nailing is safe, easy to reproduce, and a viable option for minimal soft tissue involvement. Thank you, sir.
Thank you. We will not take any questions. We'll move on to the last presentation of the session. Thank you, Dr. Akhilesh. May I call upon Dr. Prasham He's going to speak on study on association of leg length and offset reconstruction after THR with clinical outcomes.
So good morning. Good morning. I'll be presenting my study on association of leg length and offset reconstruction after THR with clinical outcomes. So we know that THR is one of the most commonly done orthopedic procedures, and the incidence is increasing because of more prevalence of osteoarthritis, more aging population. The success of total hip arthroplasty hinges on restoring the native hip biomechanics, wherein leg length and femoral offset are the primary parameters. Offset variation of more than 5 millimeters is associated with a reduced abductor strength and more gait disturbances. A limb length discrepancy of more than 10 millimeter is associated with more patient dissatisfaction, more back pain, more limping, and it is also one of the most common causes of litigation. So it is well known that reconstruction under 5 mm is generally well tolerated. Most studies focus on poor reconstruction and not outcomes in well-aligned THRs. So the aim of our study was to evaluate whether restoring the leg length and femoral offset within 5 mm of native anatomy after THR correlates with superior outcomes. To correlate the limb length discrepancy and offset reconstruction with post-op functional scores, and to investigate whether a change of more than 5 millimeters in leg length or offset after THR affects the functional outcomes. So it was a mixed study done in 150 patients undergoing primary total hip arthroplasty. Congenital abnormalities, bilateral pathologies, ankylosis, and THR done for traumatic causes were excluded. So patients were screened preoperatively. They were preoperative functional and radiological evaluation was done. Post-operatively, also functional and radiological evaluations were done. So for radiological parameters, we assessed limb length discrepancy by the Wilson's teardrop lesser trochanter method. Femoral offset was measured as a horizontal distance from the center of femoral head to the long axis. Vertical offset was measured from a fixed point on LT to the center of femoral head. And global offset was measured as a sum of the above two. For functional parameters, we assessed Harris hip score, Womack score, VAS score, SF36 score, and Oxford score. So we found that there was no significant difference in global offset and limb length discrepancy compared to the contralateral limb. 92% of our patients had a limb length discrepancy of under 5 mm, and 88% of our patients had femoral offset restored within 5 mm of the contralateral sites. No patients had limb length discrepancy or femoral offset more than 10 mm. So there was significant improvements in the Harris hip score, Womack score, VAS score, as well as SF36 scores post-operatively. All these values are found to be statistically significant. A subgroup analysis of the outliers was done. We found that there were 12 patients who had a limb length discrepancy of more than 5 mm. There were 18 patients with a femoral offset deviation of more than 5 mm. Though these values were not statistically significant, we found a trend towards lower functional scores in these subgroup of patients. That is, the Harris hip score was less than 80 compared to the general cohort median of 84. In the outlier group median. The Oxford hip score was less than 39 compared to 42 in the general cohort. The Womack score was more than 12 and the VAS pain score was more than 2 as compared to the general cohort median. These values were not statistically significant. So restoring leg length and femoral offset within 5 mm does improve clinical outcomes and patient satisfaction. Trends and outliers have shown that minor functional decline with deviations between 5 to 7 mm, though not statistically significant, might suggest a clinical impact in certain cases. A few patients with near-perfect restoration still reported symptoms pointing towards a multifactorial causes just beyond mechanical alignment. So this is in line with findings by Shapira et al. As well. Debate exists on acceptable thresholds. Some studies say 3 mm, some studies say 5 mm, some studies say 7 mm. We are finding support a 5 mm target, which is achievable, balancing accuracy and surgical feasibility. So to conclude, I'd like to say, these studies have certain limitations. We had a modest sample size. There was a lack of a control group with a higher LLD or a higher femoral offset variation, so that could not be compared. There were few outliers, so which limited a subgroup analysis of extreme deviations. Then this was a short to mid-term follow-up. The functional outcomes are influenced by multifactorial elements beyond radiographic parameters which need to be assessed, and the measurements relied on plain radiographs. So to conclude, I would like to say offset reconstruction and restoring leg length correlates with improved function and patient satisfaction. The outlier trend suggests a potential impact of extreme discrepancies which warrants further investigations. Our findings align with existing literature, reinforcing the importance of biomechanical restoration. However, clinical outcomes are multifactorial, and factors beyond biomechanics also influence patient satisfaction and function. Soft tissue balancing, implant design, rehabilitation, and patient-specific variables play important roles. So future studies should explore these factors alongside biomechanical parameters for a comprehensive understanding. Thank you.
Thank you. I just have one question. Was there any consideration about any spinal conditions in this patient, degenerative spine or previous spinal surgeries?
No, sir. This was undergoing primary total arthroplasty.
Because
No
that
spinal.
contributes to the satisfaction and dissatisfaction in limb.
Yes, sir, that was not a
So
conflict.
that needs to be considered.
Yes.
Any questions from audience? This was the last presentation.
So for your entire study, were the same implant used for all your cases?
No, sir. We had used three different implants.
So that is also to be specified.
Yes, sir.
Because as per your implant biomechanics, your results will also change. Number two, as rightly mentioned in your fallacies, extreme limb lengths were not considered. So if you're saying that more than 5 millimeter or more than 10 millimeter is going to give us functional poor outcomes,
Yes,
then we should obviously have that subgroup as well.
Yes, sir.
So good study.
Thank you, sir.
Good. Thank you. So we conclude this session. If I can hand over the mic to Sir. Thank you for attending this session so early in the morning.
Thank you, Vinayak. Thank you, Sangvi sir, and thank you, Kharat sir, for being on chair and assessing these papers. So with this, we'll move on to the next session. I invite the convener and co-convener, Dr. Abhijit Waghakar sir, Dr. Pankaj Jindal sir, on dais and to please start their session. So the next session is very interesting session, is about the hand, and obviously all the stalwarts in Pune are around to give their pearls of wisdom about the managing the hand problems. So over to you.
Thank you. Abhijit? May I invite the first speaker, please? Salvage osteotomy for mallinear distal radius, Dr. Altaf Warid.
Good morning, everybody. And on behalf of organizing team, I would like to welcome, and we'll start with the first session. Since the theme is about challenges and complications and failure, so we have kept it all case-based discussion. So I'll be discussing a case on a very commonly seen fracture which we see in our practice is a lower end radius fracture. So a 42-year-old man sustained a high velocity trauma, and he had a distal end radius fracture, and this is the pre-operative X-ray. So I would like to have comments from the panelists, and we can have an interactive session. So it's a high velocity, a 42-year-old gentleman, left side, non-dominant hand.
Interarticular, did you by any chance do any CT scan?
Yes, this was done. This is the only image of the CT scan which is available.
For me, this will be a patient for a volar plating.
For a volar plating, right.
So I think if you could go back to the X-ray, let's learn to read the X-ray a little bit. If you use a column classification, I would think that on the PA view, there is an involvement of the lateral or the radial column and the intermediate column. The lateral view shows there is some involvement not only of the volar cortex, but also of the dorsal cortex. So if you see the CT scan now, especially in the sagittal images, you will also appreciate quite a bit of combination of the dorsal wall or the dorsal rim and the volar cortex. So in my humble opinion, I would agree with Jindal sir, maybe we should begin with the volar plating, but I would also keep dorsal plates ready, just in case we need some dorsal buttress also.
Right, agreed.
But if I can interfere, did you have any cross section?
No, unfortunately, actually, this is the only thing available. He was treated initially elsewhere, and we could retrieve whatever investigations he had done at that time. So this was only available.
Why I said that, if you have a cross section, then I'll see whether there's a split and involving the sigmoid notch. Then probably I'll add a screw or something from the dorsum to anterior to block the sigmoid notch.
Agreed. So this was operated on day 1, and a K wire across the lower end radius and the DRUJ and the ligamento-taxis kind of a fixation was done. So any comments on this?
There is widening of the distal radioulnar joint, and I would be uncomfortable accepting this. No.
Absolutely. Anything, Dr. Abhijit?
On the lateral view, I don't think the reduction is quite adequate of the volar cortex.
So because of this overlap, but then you can see that probably it's missing. There's a displacement in the lateral as well.
So for all our friends and colleagues here, there's a very nice paper that was published. I forget the authors, but they looked at cadavers with external fixator, and they showed very categorically that you can correct the deformity in all planes except for the volar antero-posterior displacement with fixators and distraction. So that's exactly what's happening here. If you see the PA view, it would seem it's a very reasonable kind of a reduction. Of course, the DRUJ is not in place, as Sir mentioned, but if you look at the lateral view especially, the reduction is less than adequate.
If you ignore the DRUJ, this may look decent, but in lateral view, there's something grossly wrong. So we have less time. So this is what happened. On 7th day, he was being treated, and now this particular patient, he was told that no, this needs revision, and probably something is not right here. So at this point of time, they removed the external fixator and added a few more wires. This is what was done in the second surgery on the 7th day of the first surgery. So I think, yeah, sir.
DRUJ is still out if you see on the lateral view. So first surgery, this is second unfortunate event.
Unfortunate surgery, yeah. So yeah, probably they've tried to continue the close reduction maneuvers and try to reduce the fracture, and I think it's obvious in all the views that this is still looking mal-reduced, and DRUJ continues to remain not in a very good position. So he was continued till 3 months, till he came to us at 5 months, and there was a lot of weakness in the grip, and this is the X-ray, how it looked, the collapse of the whole block of the articular surface, and this continued to be in the dorsal. So he had restricted palmar flexion, which was just going till 20 degrees of palmar flexion. So what do we do here? Now it's 5 months post-injury.
Before you proceed, may I invite all the other panelists to please come on the stage.
To say, Dr.
Bhatia sir, Anup, Prashant, Chaitanya and Darawde sir, please join us on stage for the panel discussion. Or you can even keep a mic if you would like to, and then join the discussion.
Dr. Prashant, you can join on the stage, and Vijay.
Bhatia sir, please. Vijay.
While they are coming, please proceed with the discussion. Okay.
See, this is how many days?
This is 5 months now.
5 months.
4.5 months, yeah.
Okay. Okay.
So clinically he is disabled. I mean, that's the parameters what he has. He has restricted palmar flexion as well as dorsiflexion, and supination is not possible, which typically they are.
This will require a corrective osteotomy.
Right.
With a bone grafting.
Right.
And fixation with some implant of your choice.
So yeah, we were thinking in the same lines, and we got a CT scan done at that particular. Yes.
What is the main problem now?
Now,
where is the pain? Is the pronosupination is painful, or dorsiflexion, palmar flexion is
mainly palmar flexion is restricted.
What is this complaint? Where is the tenderness or the pain? In the ulnar column, or it is the radial column?
It's all over in that way. Not really specifically tender any point, but restriction and supination was his main concern. Loss of palmar flexion.
So he wants supination, or
he wants range of motion.
All?
Of course. He'll come to you and he would like to have all.
But this much motion is there?
Only 20, not this much. It's hardly a jog of palmar flexion.
Okay, 3 months.
Yeah, and the extension is decent, but then palmar flexion is very less.
Okay.
And supination is not possible. So when we did a CT scan, and you could still see some sort of, this was the CT scan at that particular point. So now you can see a fracture line is still, you can see it's not fully consolidated. And what would you do now? Maybe anybody? Would you like to go in now, or you would like to wait and go in a better?
Looking at this X-ray for me, I think it's going to be a two-stage procedure. In the first stage, I'll do whatever osteotomy to relocate the volar part of the radius back with a volar plate. Down the line, probably, as DRUJ is affected, he'll be a candidate for Save-Kapanji. So for me, this appears to be a candidate for...
So this one is a dorsal fragment, the one which you see
yes,
on...
so still it will be, for me, a two-stage procedure.
Right. Okay. Anybody wants to comment? Anup?
So since this is 3 months old, so I would, obviously sir mentioned that it is two-stage procedure. I'll try to correct the dorsal displacement and dorsal angulation. I'll do wrist spanning plate with whatever acceptable reduction, and
So you'll open the fracture,
I'll open the
osteoclasts,
fracture
try to reduce
from
it
the
and
dorsal side and
put
put
a
a
blocking
wrist
plate.
spanning plate.
Yeah, okay.
And get the radial reduction, whatever acceptable, and get the
Then
length.
do a final stage later. You
And
will
do
go
the
for
final
two-stage
stage.
surgery. Yeah. Okay. So these were the difficulties identified. We discussed these, and we were planning whether to do dorsal or volar, osteotomy, plate fixation, volar or dorsal. So I waited for a couple of more weeks, I think a month more, because I wanted to go into let it consolidate more and then do a proper osteotomy in maybe a virgin kind of an area. So we went ahead with a dorsal approach and opening dorso radial osteotomy and Dirac procedure, and fixed it with the dorsal plate. And bone grafted locally from there, and that is the 4 months follow-up and 2 years follow-up, the consolidated.
Sorry, sir. What? You're saying something,
Any
sir?
question? This one, sir.
Warid is asking if they are two different patients.
Which one? This? No, this is the same patient. This is, we have done a Dirac procedure because the height was not restored intraoperatively, and so learning case, you have any questions, sir?
Yeah.
Yes, sir.
You said that 1 month you have waited.
Yes, sir.
Do you have any X-ray of the 1 month? Because 1 month a lot of change, things are changing.
No.
So do you have? So because I
we
want
did
to
not
see,
repeat a CT scan again.
No, not CT,
Yeah.
X-ray, plain X-ray. Because I want to see a ulnar head again.
Okay.
After 1 month.
No.
Varit, could you please wind up?
Yeah.
Time is over. Thank you.
So, yeah, that was the last X-ray. Thank you.
Thank you, Varit, for that interactive case. I think we will now go ahead with the second speaker, Dr. Vijay Malshikare, to present his case when things fall apart, salvaging a botched fingertip injury. Thank you. May I invite the panelists on stage, please? Bhatia sir, Prashant, would you like to join us on stage, please? Come in.
So, this is a case scenario. A 42-year-old male patient, right hand dominant, history of fall of heavy object on right middle fingertip 1 day back. He was operated in another hospital for fingertip injury. He came to us next day for intense pain and uncomfortable position of the finger splint, which was applied by a previous surgeon. So on examination, there was a severely crushed, contaminated injury at epineural level, comminuted trough fracture. So this is the
day one scenario before operating. So from audience or panelists, what will you do standard to salvage this tip? Very simple, but things go wrong if it is not treated properly. It's always a painful tip if it is not operated in a ascending order. Anybody? Okay. So this was done by a surgeon. See, he has applied Patankar's tension band wire and put it a K wire which is very big. And if you see the X-ray, joint is not reduced because it is not required to go through DIP joint. Just to distal phalanx, you can put a K wire, sparing the DIP joint. And if you see here, these sutures, if it remains like that, that area will be necrose, and from simple fingertip injury, it will be complicated.
Vijay, can I? Learning experience. Never put stitches. Most of the death of tissue is not because of the injury, is because of strangulating sutures.
Absolutely.
One, and keeping the part dependent or maybe a sling. Two things. Always, if in doubt, leave it open. And second, keep it elevated above the heart level as a rule.
Yes.
No chimeral works.
Yes, sir. So we take enough. Again, we have again the operation theatre under digital block. We remove all the sutures. If you see the nail bed is totally smashed, there is a comminuted fracture. Then we debride it. There is a little bit loss of nail bed. Then we fix with the 2 K wires, small K wire, 1 mm K wire, and we repair the nail bed with a 6-hour rapid Vicryl. Then we reposit the nail plate. It's very important to reposit the nail plate, because if you not reposit the nail plate, the space will obliterate and nail will not grow in a proper way. So this is the post-op. This is 3 weeks. And now, after removal of K wire, so fingertip trauma, basically it is a fingertip injury and fingertip amputation. We always call it fingertip injury, but fingertip injury is different and fingertip amputation is different. So finger is highly specialized organ and considered second eye of the body, always, for blind people. Fingertip is a domain of everybody, from general practitioner, general surgeon, orthopedic surgeon, plastic surgeon, and lastly a hand surgeon. So everybody knows the fingertip is started from the insertion of the flexor tendon to the tip of this. This is called as the fingertip. And in epidemiology, most common injury in the hand, middle finger, index finger, and thumb are the common, because we are using for the pinch. Higher incidence in children and young adult. Trapdoor is the more common mode of injury in children, and bike chain injury in young adult. So what not to do? Not every CLW requires suture. Try to salvage finger. If no expertise, then refer to specialist. So simple injury, nail hematoma, to complex injury, one result, another case. And if it is not treated properly, it is always land up into the painful fingertip. So in conclusion, managing the fingertip injury, decision making should begin from simpler technique and progress to the complex option as needed. The surgeon should be well versed in benefits and limitations of all available treatment methods to optimize patient's outcome and satisfaction. Thank you very much. Any questions? I think no questions.
Okay, thank you. Thank you, Dr. Vijay. So we'll call the next speaker, Dr. Nilesh Daraude, a case of EPL rupture after a distal and radius malunion correction. So 5 minutes, sir.
Good morning. Good morning, everyone. Thank you for having me here, the organizers, Dr. Warid.
My job is made simpler because of Dr. Wari's presentation. So we are all aware the acceptable limits within which the distal radius union can give or not give the problems, and we essentially look at these three parameters. What is the ulna variance, radial inclination, and volar teeth compared to the opposite side, and that basically decides the plan of management if there is one. There is evidence that older people tend to do well even with malunited distal radius. So not all malunited distal radii need a surgical intervention. Coming to the case, so 58-year-old lady came with 7 months old injury which was treated with some K-wire fixation. Unfortunately, the fracture kept on collapsing. And if you see the AP, the left side is the normal, right is the problematic side. Then there is a lot of loss of radial inclination and radial height. The inclination is practically negative compared to the opposite side, and significantly positive ulnar variance. If you look at lateral, the dorsal tilt is not so much, maybe around 15 degrees, but the carpus is sort of uncovered. So that should make a treating surgeon uneasy because this can cause problems. And there was an obvious deformity. The lady being 58-year-old, I was not too enthusiastic to offer her surgery. I said, use your hand for a couple of months. If you have trouble, come back, then we'll deal with it. Unfortunately for her, she never felt comfortable with her wrist. So a couple of months down the line, she did come back and said, can you correct this? So we followed. This is not her operative images, but the technique is straightforward. So Dr. Wari showed you a dorsal osteotomy. You can use pre-contoured locking plates with good strength and use them as a correction tool. This is what we did. And for a good measure, usually when it's long standing, it is hard to get the entire radius length back. So a lot of times you will have to add ulnar shortening procedure. So that is her intra-op image. So the ulnar variance in retrospect maybe another millimeter reduction in length of ulna would be nice. The radial inclination has been at least partially restored. And she was doing well. This is her around 2 months after surgery. And she seemed to be doing well. I thought, okay, another couple of months of physiotherapy and she should be happy. Sadly for me, at around 3 months, I got a message from her son, who is a BMS doctor, and he said that the thumb looks limp. And if you see on the left image, the attitude of the right thumb is in flexion. The left one can be extended, the right one didn't. And the underappreciated function of extensor pollicis longus, in addition to extending the interphalangeal joint, it contributes to adduction and dorsal translation of the thumb. So that's what the patient perceived as a limp thumb. So she couldn't hold her thumb like this. So his communication and these images kind of were confirmatory that unfortunately she's landed up with an EPL rupture. I got an ultrasound just to confirm the same, got them back, had to counsel a lot. So that's the point of worry. How do the patient take a complication like this? And once they are willing, once they understood, yeah, this is a possible complication, then they were willing for surgery. So we took her up in OT. This is her intra-op image. So that is the torn distal end of the EPL. And this is the extensor indicis proprius that is being transferred. So that's the proximal part, that's the distal part. Unfortunately, I don't have an intraoperative video, but a similar case in a young girl, that was the one where we shot the video. She had an injury because of a proud nail used for radius fixation, and that's how we checked the tension. So we did a tendon transfer. We have to protect the tendon transfer for at least 3 to 4 weeks. Fortunately, then once the slab was removed, on the left side what you see is the day the slab was removed. So that at least the attitude of the thumb has changed. And this is a relatively recent case. So what you see on the right side is around 10 days after the slab removal. So the thumb function has been restored to a decent extent. Hopefully another couple of months and it will look practically normal. So this was a complication in trying to correct that radius malunion that we landed with. So we went back to literature and tried to find out what are any guidelines available. So this is an interesting old paper back from 1984, But the interesting fact about anatomy that it brings about is, look at the size of the third dorsal compartment which houses the EPL tendon. And this paper basically talks about EPL ruptures being common with undisplaced fractures rather than displaced fractures. So what it says is, if the extensor retinaculum, the third dorsal compartment, stays uninjured, then it is a very narrow space in which the tendon is housed. And the reaction to the fracture, the callus, the swelling, can put pressure on the tendon and cause ruptures. So this is a very old paper. This is a relatively recent paper from JHS 2016. And they specifically looked at the same case pattern that I have, EPL rupture after a volar osteotomy. The osteotomies are not done every day and out. So the incidence of a rupture after correction of margin union, nobody knows. If there are technical errors like the screws being prominent, the drill trying to breach the tendon, then the chances of ruptures are there. But even if there are no technical errors, the contributing factors could be a sharp edge after the osteotomy or the dorsal callus that constricts the tendon. So they have hypothesized the possible pathology behind EPL rupture, but there are no clear guidelines that how can we get rid of this complication. In this paper, they have looked at 60 cases of distal radius margin union corrections. So that is the longest series that I could find. If there is longer, I don't know. And amongst the 60 cases, they had only 3 cases of EPL rupture. But the paper or the authors themselves that it's still a small series, we can't really establish the incidence of this complication.
Nilesh, there's a paucity of time.
Yes. So the learning point is we have to counsel the patient preoperatively about this possibility. There are no hard recommendations, but one could argue that opening dorsally once we are done with the bone job to get the tendon out of the third dorsal compartment would probably minimize the chances of tendon rupture. And then there are some guidelines which say that you should excise the callus or Lister's tubercle to minimize the possible chances. Thank you.
Thank you. Thank you. Do you feel it's the screw which is the culprit or an osteotomy, in your opinion? Because since it's not very clear from all the literature, the long screws or it's the sharp edge of the osteotomy?
I don't think, I tend to keep the screws short of the dorsal cortex to try and avoid this complication. And I think it must have been the constriction of the callus. I didn't think the edge was so sharp in at least the x-rays that I saw.
Yeah.
But unless we open dorsally, there is no way of knowing for sure.
Thank you, Dr. Nilesh. So I'll call the next speaker, Dr. S. Prashant. He'll talk on a complex metacarpal and extensor tendon reconstruction, traumatic, post-traumatic.
Good morning, everyone. So, my sincere thanks to the organizer for giving me this opportunity. Today, we are going to discuss a case of crush injury, rather, a young patient, software employee, road traffic accident, has a polytrauma as well. Initially treated by somewhere other centers. If you look carefully in the image, you can see there is a big crush injury involving the hand. There is involvement of metacarpals. There may be extensor tendon injury. Look for vascularity of the fingers. Look for contamination. And initial things is like that. Just to debride it thoroughly, do skeletal fixation, do soft tissue repairs. These are the basic principles. So this is the X-ray and the initially treated X-ray. This is the only X-ray I got, no other investigation. Yes, of course, he has got polytrauma, long bone fractures, chest injury, head injury as well. So what they have planned is, they have done some fixation, okay, and they have done some debridement, hope so, because this is the way it has been presented to us. They have done suturing has been done, some external fixator has been done. This is around 2 months down the line. This was the X-ray. So maybe initially they are a bit hurried to treat his polytrauma and other things. So this is the basic thing they have done. On examination, if you go back on examination, there is no extension of the middle finger as well as the index finger. and a lot of pain, swelling still there, and rest of the movements are there, and vascularity and sensation on the affected fingers are fine. So what do we think? Any suggestion?
What it appeared, first thing, the fixator.
Right.
Primary assessment was important, whether the extensors were not working. Now we are looking at extension of MP joint or extension of PIP joint.
Correct.
If at all they are working or not working, if you are immobilizing with an external fixator, the most important thing is your fixator should be such that the MP joint is flexed.
Correct.
Because that becomes an iatrogenic complication and causing unnecessary, avoidable stiffness of the MP joints. Now, having said that, what was the active extension of the MP joint and what was the active extension of the PIP joint? My guess, looking at the comminuted fracture, probably the intrinsics were gone, and that was the cause, and that will therefore become a case for secondary reconstruction of IP joint extension.
Correct. So what we thought was we need to explore and see how it is, and do for some skeletal fixation with plates, maybe with some bone grafts, synthetic or maybe allografts. And keep in mind, maybe a primary repair of an extensor tendon may not be possible, so an option of graft. This is on exploration. So there will be a segmental loss of extensor tendon to the index finger. Both the index fingers has been gone. Luckily, the middle finger is intact. Whatever the loss of extension is mainly because of the culprit caver, which has gone directly through the extensor wood right at the center. So it has been thoroughly debrided, all the tissues has been removed, all the fibrous tissues has been removed, and a graft has been harvested. And skeletal fixation is done with a plate. For the extensor tendon, we put a extensor graft, tendon graft. So this is the graft. This is, once we do the distal suturing, this is the distal suturing. Then the proximal part is done with a pulver-taft maneuver. In this thing, it is very important to adjust the excursion of the tendon, how much it should be set, so that we can do a passive extension during the procedure, do a temporary stay suture 1 or 2, then you see the excursion and then do a final tightening. This is the final suturing of the tendon. And of course, I don't have the particular video of that fixation of the plate, but plate is there. So this is the plate with bone graft and the repair tendon. Okay. So post-operative event was uneventful. It went on. But this X-ray was not that much happy, even though we grafted whether it is going to unite or not. If you look carefully, there is also a second metacarpal head fracture as well, which has been might have been treated conservatively earlier time, because there was no wire of that which has healed. That was fine. So next further follow-up will shows this sort of thing. Again, I'm scratching my head. There is, if you look carefully, there is some still that distal fracture fragment showing some radio this thing. Opacity, which indicates it may go towards, again going towards a non-union. Luckily, it went well. It healed over a period of time.
Just
yeah,
30
I'll
seconds
conclude.
more, yeah.
This is the last one. This is after implant removal, which has healed soundly and perfectly, and even range of motions are good. So whenever there is a polytrauma, always try to neglect the hand injury. Give some time. It doesn't mean that you should look after life-threatening injuries. Always, maybe second day, once it stabilizes, do a proper assessment and try to treat it accordingly. And try to put the cavers, especially in this case, never put a caver through the PIP joint. It never going to, whatever procedure, it is not going to give you a good range of motion. Address soft tissue early and anticipate and discuss the complications. Thank you for your kind attention.
Thank you, Dr. Prashant. Any questions? Quickly, one question.
Sir, do you have a video post-reconstruction function of the hand?
Yeah, hand.
I just saw a still photo. I didn't see any flexion in the MP joint. I didn't see any PIP flexion.
that was not completely this thing, okay? This is the only, this might run also. Even today, he is not happy. He is always telling me regarding PAP joint flexion, that is mainly because of that wire, which has gone through his PAP joint.
I'm sorry, but this is the best way to avoid showing the result, because it doesn't show anything.
Still, the recent follow-up is not with me.
Great case, Dr. Prashant. Why the plate was removed? Any particular problem with the plate was there?
Even with lot of bone grafting, that plate was bulky. If I just touch the skin, there will be plate palpating all the time. So that is the reason why I plan to remove it.
I just want to ask our esteemed panelists, would there, in the primary situation, would you have considered a totally different plan of action? Of course, the X-fix is totally out. In the primary situation, in a polytrauma situation, would we really be trying to fix everything? Would you have a different plan? Because I don't think I agree with this kind of plan where we try to salvage everything. It may not be necessary, especially in a person who's quite sick. What's your opinion on that?
Yes, everything primarily, everything. Spend time, do it primarily, because if there is if the word polytrauma, you have femur, you have tibia, hand, and you say put K-wire or something and finish it off in 5 minutes, then you are guaranteeing awful result. So it requires time, patience, and full dedication to do everything primarily. Yes, as I said, with the comminuted fracture of the metacarpal, and as you were showing, the flanks of the metacarpal were empty. That means all the intrinsics are gone, intraossea are gone. Yes, that will require a secondary reconstruction. He has not shown the results. But whatever can primarily be done, it has to be done in toto primarily. These are poor people. Say, you will do it later, later will never come.
Avoid putting wires transarticular through MP joint, PIP joints. If you're doing damage control sort of a thing, I think putting it in a functional position, a frame, a hand frame is very important, which will make your life easy if you're not doing it primarily. But ideally, yes, primarily everything, whatever is possible. Thank you. We'll call Dr. Chaitanya Patil. He'll talk about an interesting case of undecided wrist pain and treatment dilemma. Please stick to time, 5 minutes. Thank you.
Thank you. Okay. Okay, so I'd like to present an interesting case of ulnar-sided wrist pain. Ulnar-sided wrist pain is one of the most commonest cause for pain in the wrist. It's a mainly disabling condition and often called as low back pain of the wrist joint. There are n number of differentials which start from ligamentous and goes on till even tendinous causes. So DIUJ dysfunction is a common complication of distal radius fractures, ligamentous disruptions, commonly seen as well as in rheumatoid arthritic patients as well as in med-lung deformities. The options for this treatment, they range from distal ulnar resection alone to soft tissue stabilization, interposition arthroplasty as well as implant arthroplasty. So we would like to present a case of a young soldier who presented with pain on ulnar side on a non-dominant hand. He basically reports of pain while holding the rifle, and he has previously undergone 7 surgeries for this condition. So while holding the rifle, the non-dominant hand goes in supination and ulnar deviation position. If you look at the C-arm image, you will see that there is some impingement of ulna during loading of the wrist, and because of this he experiences pain while holding the rifle. So what we proceeded is we approached, we took a dorsal approach through the 5th extensor compartment. We removed the scar tissue of the DRUJ. We identified the posterior interosseous nerve and did pin neurectomy for ailing the pain. We found that there was absent ECU, might be because of the earlier surgeries that patient underwent. Then we dissected the scar tissue around, Just a moment. Then we dissected the scar tissue around the distal end of ulna and completely freed it circumferentially. What was done was we did osteotomy of the distal ulna, and after osteotomy 3 drill holes were made through the ulna. These were basically to secure the interposition arthroplasty that was planned. Consequently, drill holes were made on the ulna side of the radius. These are the video of the drill hole, and a fiber wire number 2 was passed through this drill hole by railroad technique. This was the tendoachilles allograft that was used. It was placed volarly and it was secured onto itself. This is the pictorial of the suture placement of the fiber wire. And the tendoachilles allograft was used as an interposition for the DRUJ. It was secured by tight repair of capsule and double breast repair of the extensor retinaculum. Post-tender secure, you can see that the range of movement is pretty good with stabilization of the DRUJ. On compression, you can see that there is no impingement of the distal ulna, elevating the pain that patient experienced. So scientifically, there are basically paper presented by Soteriano where he has shown almost 14 years follow-up in 31 patients with a good range of movement and functional outcome. Thank you.
Thank you, Dr. Chaitanya. That was an interesting case. So,
thank you.
If there are no questions, we'll go to the last case and followed by the debate and keynote session. So, Dr. Anup Bansode will talk on salvage of hand function in the large juxta-articular enchondroma.
So thank you very much for this opportunity. So I'm going to present an interesting case. A lady, 37-year-old homemaker, and she was presented with painless swelling in her hand. So the swelling was present on the dorsal aspect of the hand in the region of the 4th metacarpal. And X-ray showed a well-defined lytic lesion in the metacarpal, 4th metacarpal, which is involving almost entire metacarpal. And MRI also showed a well-marginated lesion, and there was no soft tissue involvement and suggestive of enchondroma. So we were wondering about what treatment that we should offer this patient. So whether to do curettage or bone grafting or to excise the entire metacarpal lesion. If we would have opted for curettage and the bone grafting and yet preserve the joint function, there will be a chances of recurrence. And if we excise the entire metacarpal, her function would have been at stake. So we wanted an option which ensures that we can remove the entire tumor, yet there will be no local recurrence and yet preserve the joint function. So we decided to do metatarsal bone graft, free metatarsal bone graft. So we went ahead with excision of the metacarpal lesion with some portion of the shaft, and this was the excised tumor. Thereafter we harvested the second metatarsal, and we harvested the metatarsal in such a way that we could harvest the deep transverse intermetatarsal ligaments and the collaterals also. You can see on the left image, both forceps are holding deep transverse metatarsal ligaments, and thereafter we in the left side image you can see the tumor. Second image shows the metacarpal graft, and metacarpal graft was fixed with a mini plate, and these wires were passed just to offload the repair, the soft tissue repair. We repaired the corresponding intermetatarsal ligament with intermetacarpal ligaments and corresponding collateral ligaments. And this was her follow-up X-ray, and thereafter this was her function after 4 months. and this was a range of motion post-operatively. She could able to do a fairly good range of motion. So the enchondroma is most common bone tumor of the hand. It affects almost in the age group of 10 to 40 years. And take-home messages, although technically demanding metatarsal graft from the foot is effective option for the joint preservation and reconstruction in case of the metacarpal tumors, metacarpal head tumors. So thank you for your attention.
To the next topic, which is the debate on the distal and radius fractures in the elderly. I'd like to speak, call Dr. Pankaj Jindal first, who will talk on plating, followed by Dr. Abhijit, who will be speaking on K-wire fixation.
Good morning. Thank you for being in the auditorium this morning. I'll be talking why plating is my preferred choice. The best teacher is failure, whether that be yours or mine, and I've learned from failures. And I'm just presenting a single case. This was primarily done somewhere else. He was a 65-year-old male surgeon, a doctor, and he looked into my eye. What do you think, doctor, this is? And looking at his gaze, I was scared. I said, yes, done properly. What's wrong? He showed up the second X-ray. Anything wrong? The external fixator was removed and the wires were there. I said, yes, perfectly fine. Nothing wrong here. The doctor has done a good job. And he showed the third. This is what happened 6 months down the line. The radius has collapsed. The tilt has collapsed. And he then asked me, do you think that the surgery was still done properly? And I had no answer. So deformity is his main concern, deformity. He is not talking about pain, he is not talking about range of motion. The deformity is his main concern. It is possible this gentleman will have be okay at some remote time, as Abraham Coley said 200 years back. At some remote time, he'll be free of all problems except the deformity. So I tell him to live with it till remote time? Or will he wait till remote time? So I learned that K-wiring can lead to late collapse. And that's precisely happening. If you see the yellow, the plate, the board line, in 10 years there is a 13-fold rise in the incidence of plating, and external fixator is going down, K-wiring is going down, because a single word, late collapse, falling fixator, or K-wiring. In 2024, this systematic review had two components. Conclusion, VLP is volar locking plate is better in the first few months. And second part, weigh the risk-benefit ratio. So what is the risk? The patient will have 2-inch incision. And deformity, patient is not going to accept early on. What he will conclude, the doctor is bad, he messed up my hand. What is the benefit? Better will be better cosmesis and early range of motion. And going to the upper one, the volar locking plate is better in the first few months. And that's the time the patient gets mostly judgmental, and that can potentially ruin your reputation. So yes, risk-benefit ratio is there, but are we talking at first few months or few years down the line? What does the Cochrane review says? It says the patient has to participate in decision making. What he prefers, plate, wire, plaster, external fixator. So did the patient say, I want one over the other? Patient has usually submitted himself to you. He wants to be all right. He usually says, doctor, do whatever is best. Did the patient say, I don't want a plate? No, based on your large experience, you have offered him K-wire external fixator. And I've showed a single case where the collapse was not only a collapse, but it was a late collapse, which was not in the hands of the surgeon primarily. You didn't offer plate primarily because it's time consuming. Half an hour versus 70 minutes is expensive. Or you're not trained to cut open and see the fracture site. Or because the Abraham Coley said down the line you'll be okay. The deformity may persist. So why plate for me? You can safely not have a late collapse. K-wire can back out in a porotic finger and a porotic radius. The chances of radial nerve irritation is less. Complications are yes, they are in K-wire, they are in fixator, they are in plate, but probability is much lesser in plating as far as my hands are concerned. In 2009, American Academy of Orthopedic Surgeons says we are unable to recommend one form of treatment over another. And therefore, if there are no guidelines, my failure will dictate my probable success. So for conclusion, if there's a fracture and which is communicated, usually which is not visible early on, and patient agrees, plating is my choice. Thank you very much.
Thank you, Dr. Pankaj, and I'd like to invite Dr. Abhijit Vaigaonkar now. He'll be talking on K-wire fixation of lower end radius.
Good morning, everyone. It's with a lot of trepidation I take the stage after my teacher and mentor, Dr. Jindal, has spoken. And my task will be to talk about K-wires. Quick show of hands in the audience. Elderly patient, distal radius fractures. How many will plate? How many will do K-wire? I think, can we end the debate here? But let me try and be more scientific about it. So in 5 minutes, I have to talk about when should we operate and who benefits from the surgery. What should be the use, what should we use to treat the fractures, and what are the indications and the limitations of the choices that we make. So distal radius fractures, everyone is an expert and we all treat them, whether it's an orthopedic or a hand surgeon. Everyone thinks that we can do it better than our colleague next door. And in the age of and the era of WhatsApp, we tend to share our successes and perhaps not talk about our failures. And that's where we fail to learn from each other. What does the literature say about it? And like rightly said by Jindal sir, yes, there are more than 100 cohort studies from very bright authors. However, only a handful of them are double-blinded RCTs, and that's the reason why there is a paucity of level one evidence as to what is the best modality of treatment. Now, this is the best practice guidelines for distal radius fractures, which was published in 2018 by BSSH committee, and they came up with a conclusion that whether K-wires or whether plates, there is no clear evidence of the advantage of one over the other. Maybe in the early stage, you may have the advantage of early range of movement, but this plateaus off over a period of time. Now, when we talk of evidence, unfortunately, you can justify any choice that you're making, but unfortunately, this is like using the literature for support rather than illumination. Look at this malunited distal radius fracture in an elderly patient. The X-ray looks horrid, but the patient was doing quite well. Now, as rightly pointed out, if you tend to use K-wires, the biggest issue or the problem that we do is early removal of the K-wires, and that may lead to your late collapse. It is a good idea to leave your K-wires subcutaneously and leave them for a longer time till such time that the fracture is consolidated well, and that's when you can take them off. So loss of reduction usually results in these particular problems, and yes, there may be issues that may result. But look at this Malmo study. Even with congruent fractures, there is a chance of development of arthritis both in the radiocarpal as well as the radioulnar joint. So does this kind of justify the use of more invasive and an expensive treatment for elderly patients who are usually low demand and may also benefit from K-wire fixation? Now, whatever modality of treatment you use, there is no denying the fact that the goals of treatment are universally the same, and which are to accomplish an articular congruency, restore the anatomical alignment where and when possible, with a stable reduction in fixation, with early mobilization, and therefore minimizing the complications. And this can be achieved by either a percutaneous arthroscopy assisted or an open technique, but the reduction has to be reasonably good. And in elderly patients, osteoporosis, although is a challenge, it can still be managed, and effectively so, with the use of percutaneous techniques such as a K-wire and at times coupled with an external fixator. So here is again another study by McQueen et al., which say that although active older patients do have the need for an anatomical reduction, but low demand patients are usually doing well despite our use of K-wires. Now, why did this trend of plates come in, which superseded the necessity of fixing only with K-wires? And I think it is pretty much implant derived. After 2000, when Jorge Orbe introduced the volar locking plate, there has been a significant swing towards using plates over K-wires. Clinical results have been published by several authors just to propagate the usage of plates. However, it is a surgeon who must obtain the reduction, not the implant. The implant helps maintain the reduction, and it could very well be accomplished even with your K-wires. So there is no proof of what treatment is better, whether it is K-wires or whether they are plates. We all agree to that. But the determinants of treatment are fracture characteristics, surgeon preferences, and patient factors. And it is important to know which of these factors is the most important. Who defines whether the fracture is simple or complicated, and who defines a simple or a complex? It is a surgeon, and the surgeon is therefore the operation. So the final thoughts, there is no consensus on treatment. Do what you do best. Know the weaknesses of your approach and the implants. Use a literature for illumination rather than support. Treat the patients, not the X-ray, and plan ahead in time. Thank you so much for your attention and the opportunity. Thank you.
So we'll have a quick rebuttal from Dr. Pankaj for a minute, because we are already running a bit ahead.
Professor Vahegaonkar spoke for 5 minutes, but he didn't say a word. There was not a sentence I can carry home. I'm surprised he even made a presentation and wasted my time. I have nothing more to add. Say one sentence which I can carry home.
So I think the audience has already told you what needs to be carried home.
Okay, it was a wonderful debate, and I think it will always remain a controversy which distal and radius fractures to K-wire or to plate, and you have to tailor make it for your patient according to your past experience. Like rightly said by Dr. Jindal, that you learn from your past mistakes, and then that's how it will take us ahead. So moving on to the next important keynote session of this session by Dr. Anil Bhatia, who will talk on restoration of pre-and in total brachial plexus injuries.
Thank you, Sailesh, for including my talk. I owe you. Let's start. It's really wonderful that the hand session is kept right at the beginning, so that there are people to listen to me. I have given brachial plexus lectures with 5 people in the audience. They are all faculty. So, post-traumatic brachial plexus injuries, 1 in 2 are total palsies, where the brain and spinal cord are completely disconnected from the upper limb. So our job is to reconnect the control of the mind on the arm so that that flail upper limb functions. So the principles have always been the same for the last 50, 60 years once we got the hang of nerve reconstruction. But it's obvious that you need something that is connected to the mains, that is a wire that has function. The brain has control on that wire, and connect that to something that doesn't work. And it's obvious that whatever is closer to the repair site is going to function better. So proximal functions are more likely to recover. If we focus only on the shoulder and elbow, we can get, by the standard nerve transfers for the reinnervation of the rotator cuff and of the musculocutaneous nerve, we can get some control of the shoulder and the biceps. And following a secondary surgery, the limb becomes slightly better. He can place it in space. The brain has some control on that arm. But when we are talking about prehension, what do we really mean? We are talking about the ability to manipulate objects by that paralyzed upper limb without the need for support from the opposite upper limb. For that, we need control of the shoulder, elbow, and hand. Now, the resources are few, and they have to be harnessed in the right way. So, it has always been my endeavor to restore prehension in the younger individuals who come with total palsies. So, I'll take you back in history. This is one of the cases that I had shown in my oration in 2008, where the proximal muscles, supraspinatus biceps and triceps were reinnervated using the standard nerve transfers. And subsequently, I projected the biceps further distally using a technique described by my teacher, along with a wrist fusion. So this was the control of the supraspinatus, pec major, biceps and triceps. The biceps was prolonged using a facial autograft, and the wrist was fused, which gave this sort of finger flexion. And he could hold some objects without dropping them. But again, obviously, here the object has been fed into the hand. He hasn't lifted the object himself. Now, I had always had this trepidation about cutting the biceps in order to prolong it to the FDP. So, I experimented with just weaving the facial autograft through the brachialis without dividing the biceps. So this patient, young patient came, the C5 route was used to innervate the suprascapular and the radial nerve, which gave the triceps and some control of the supraspinatus, and the intercostals for pectoralis major and musculocutaneous. Now, the triceps came because of the C5 nerve grafting. So subsequently, I did a derotation osteotomy, wrist fusion, which positioned the limb better. He was able to flex in the sagittal plane, and subsequently, I bridged the brachialis to the finger flexors, so that when he extended the elbow, the fingers were flexing. And he was so intelligent that he sent me this video from his village, where he showed how he could handle a bicycle. And he was intelligent enough to video it from below to show the fingers gripping the handlebar when he extended the elbow. And he also, I will not run that video, he ran a video showing him to being able to handle a weight of 1 kilo. So that is regarding nerve reconstruction using the available techniques for proximal muscles. Since 2013, we have overcome our fear of harvesting the full contralateral C7 and bridging, repairing it directly to the mobilized lower trunk in order to get wrist and finger flexion, and at the same time use the contralateral C7 for elbow flexion, along with nerve transfers for the rotator cuff, that is the spinal accessory to the suprascapular, and the phrenic nerve to the posterior division of the lower trunk for triceps. So essentially, we are using extraplexual sources to get shoulder control, elbow control, wrist and hand control. Now, this was brought into vogue by my dear friend Shufeng Wang in Beijing, and I visited him in 2013, and this was the first case I operated by that technique just after I got back in October 2013. The rotator cuff function is from the spinal accessory transfer, elbow flexion is from the contralateral C7, triceps has come from the phrenic nerve, Following secondary surgery to stabilize the wrist, finger flexion is from the contralateral C7 and finger extension is from the phrenic now. And the patient was so intelligent that she was able to send me this video of her able to handle objects completely independently using the paralyzed upper limb without any help from the non-paralyzed side. I let the video run all the way because I wanted to show how intelligent she is. She shows water in the glass. That means she actually lifted some weight. I have continued with that technique over the last 12 years. This is a patient I operated more recently, 2021. Exactly the similar strategy. See the finger flexion coming from the contralateral C7 and finger extension coming from the phrenic now, which allows him to handle objects in space. All these videos have been sent by the patients, therefore they are not drama. They're all actual utility of the upper limb that a patient executes at home. And if we have an ipsilateral root as well, I have utilized it for getting the biceps rather than depending on the biceps from the contralateral C7. The rest of the reconstruction being the same. So this was the patient I operated in 2022. This is the control of the shoulder from the spinal accessory to suprascapular plus contralateral C7 for the pectoral.
But yes,
elbow flexion. This is the last slide. Last couple of slides. Elbow flexion from the C5, elbow extension from the phrenic now, wrist and finger flexion from the opposite C7. With secondary surgery, the hand can be placed better. He's got better, the wrist is in a good position. And he can manipulate objects. I thank you all for your attention.
Thank you, Dr. Bhatia. One quick question, if we may have, then we'll move to the next session because we are already running 15 minutes late. Thank you, Dr. Bhatia. Thank you so much. So I would like to call Dr. Shruti and Pranav. They will be anchoring from the next session. They are here. And I'd like to invite the next conveners, Dr. Parag Sancheti and Dr. Hemant Patil, for the stage. Quickly, we'll be felicitating the faculty. So, Dr. Vijay Malshikre, Dr. Nilesh Darawde, S. Prashant, Pankaj Jindal sir, and Anil Bhatia, and myself.
Good morning all. Firstly, thank you for the Pune Orthopedic Society Annual Conference organizers, President and Chairman, for giving us opportunity, especially for the surgeons like me coming from a small town like Satara to present my work. So my first case is the revision knee replacement. So there's a case with a female, 66-year female, history of operated bilateral total knee replacement surgery 12 years back, came with a history of fall with the right knee and difficulty in walking. She has got pain and deformity of the left leg, unable to weight bear. The right leg is swollen, tender, flexion was hardly up to 60 degree, and there was laxity of the joint. All her investigations, HB, count, ESR, CRP were normal. And there is a history of old history of fracture of the right tibial condyle just after the first TKR on the right side, for which she was operated with the plating. So this was a fresh injury with twisting of the right knee and unable to walk and weight bear. So what next? When we examined her, all the collaterals were stable, but there was small fracture in the tibial condyle and she could not able to weight bear. This was her pre-operative gait when she landed up in my OPD.
So this is at 12 years, right, when she came to you?
No, this is just after the fall when she came to my OPD. 12 years, after 12 years.
But 12 years post-op?
Yeah.
Yeah. After the index surgery. Right, go on.
So this was pre-operative X-ray.
Right.
It shows the previous operated tibia with plating.
Right.
And
So this was a bilateral case, if I'm right.
Yeah, this was a bilateral
and
case.
you're restricting your presentation mainly to the right.
Yeah, only on the right side.
Okay.
So what are the options?
So go back. Yes, Mahesh, can you tell us what do you think could be wrong with this X-ray? And
yeah, and you said you ruled out infection and that's not a problem.
Yes, sir.
Yeah, probably looking at the X-ray, there is slight persistent varus deformity in the knee joint, probably contributed by the extra-articular deformity, and seems like there is varus alignment leading to stress at the tibia, and maybe that previous fracture is either non-united or refractured. You can see a faint radiolucent line through the callus. Probably a refracture because of now the varus malalignment, which is residual.
Yes, sir.
This fixation is almost 12 years old, right?
Yes, sir.
Fixation is 12 years old. So for 12 years she has been walking on this without any significant pain, yeah?
No, for the 12 years she was walking comfortably without any pain.
Yeah, so she's been walking without any pain for last 12 years. So
Yes.
I assume that the fracture is actually united.
Yes, sir.
At that
Yes.
time, yeah.
And today I think you need to document what sort of laxity she's got.
Yes, sir.
You know, on X-ray we can't make out what laxity she had clinically. So clinically she was lax all around, you're saying?
There was a medial joint laxity.
Medial laxity. But only medial laxity or all around?
All over.
All over. And hyperextension? Was there hyperextension?
No hyperextension.
Okay.
So does that medial condyle of the femur worry you, Hemant? Is there anything going on there?
Well, you can't make out on this. I mean, if you really need to define what sort of osteolysis there is small hint of a small, lysis around on the medial femoral condyle. You need to do a CT scan to define what sort of lysis there is.
Okay.
Yes.
Go on.
Unfortunately, patient was not affordable, so we could not able to do that CT scan and other things.
Yeah. Show us what you were showing us some options. So what were these options for?
So initially we were thinking of the
But why revision? Why are you thinking of revision? Means straight off. With the X-rays, relatively.
X-ray was relatively okay, but there was
revision of?
In the sense to keep the revision ready, open the joint, whether need to do anything to change the tibial procedure or something like that.
Okay.
So we are keeping in mind 4 options. First was single stage revision in the form of LCCK.
I think before anybody decides on any revision, we need to define what is the mode of failure or what are you trying to deal with. Are you trying to deal with a polywear with excessive laxity secondary to polywear? Or it is only, was there synovitis, was there great effusion? And if that is the case, then you can say that this is possibly polywear with secondary effusion, persistent effusions leading to instability. And possibly even that sort of polywear leading to maybe laxity is global laxity. And if there is global laxity, then the plan completely changes. But we need to establish what your primary working diagnosis is before you go in.
Correct. So you were thinking more, you said there was medial joint opening.
Yes, sir.
So that is why you were thinking of revision. Probably the medial side was incompetent.
Yes.
Okay, so that's why you were thinking little bit of revision scenario. Go on.
We keep the everything ready. Initially primary she was operated with the attuned knee.
Okay.
This was the intra picture.
So you removed the implants.
We checked the range of motion. Yeah. There was a partial MCL injury was there. Right. With a small medial condyle, femoral condyle fragment was there. Gross opening of the medial side, but rest other.
What do you think the analysis was? So it was opening. After opening, did you see that anything wrong on the medial side? The MCL maybe, the POL maybe, or what was wrong on the medial side?
There is laxity on the MCL tear was there.
MCL tear.
partial tear was there.
Okay, okay.
And
Go on.
and during the interop, we can able to dislocate the knee. So we thought that there is a partial fracture on the femoral condyle and MCL tear.
So the medial.
So we plan for the revision. We remove the all the tibial prosthesis, and we checked there was partial MCL tear.
So you have put 2 screws on the medial epicondyle. That is what I was asking.
Yeah, there was
initially.
small fragment fracture.
there.
We can see
So that
clearly.
was probably the reason.
Yeah, that was the reason.
Okay.
So we fixed it with the 2 screws, as patient was not affording for going for any other higher prosthesis with the long rod. In the view of that, we found that femur was quite stable, so we don't want to go for the revision, as patient was not affording at all.
Okay.
So we keep the ready for the 2 prosthesis for the debut and Merrill. But unfortunately, we could not able to remove the screw of the tibia, which was broken when she fall down.
Okay.
So that was inside the canal. That was we could not able to remove beyond the 9.
Okay.
And the debut tibial long stem was starting from the 11.
Yes.
So we don't have another options to go besides go for the Merrill stem, which has got the we can easily go for the 9, rim the canal by the 9 and put the 9 size long rod.
Okay.
So that was the only option.
Good.
So we have put a long rod with the Merrill stem, and we could able to manage the fix with the screws, and we can achieve the stable fixed knee.
Perfect.
But this was a irrational.
Time is up. So we need 1 minute more. You have.
Yeah, just one tip for the broken screw that you can see from within the canal. You can actually use a burr if you have burr available, or any, most of these neurosurgeons use it, or other departments. You can actually get the burr and burr that screw out. I've done that in past.
Yes, sir.
Yeah. So you have any more slides? That's an excellent suggestion.
This was her 15 days post-op walking with brace.
Okay.
Partial weight bearing.
Okay.
And this was her post-op video after the 2 months.
Okay.
She was doing quite good.
Okay.
She turned up in the OPD after 4 months. Her flexion was 0 to 90 degree. No
Okay.
medi-jointer laxity, no pain, and patient was happy.
Yeah, just one point, a big learning point I think that should not be taken away from this case is that you should never mix and match company implants. Yeah. One company's femur will not match the other company's tibia, and it can lead to very early failure. So that is not something that you can recommend.
Sir, interop options, we don't have options.
No, I understand that. I understand,
so
but,
that's a
but that
bailout.
is not a lesson, and that should not be the lesson that, oh, this is done.
So
this
is
cannot be done.
Just a message to the house, but you had to bail yourself out. So you did a good job. So big round of applause for Dr. Santosh. Well done. The next case, we have Dr. Sinu, who is going to talk to us about the most hot topic in knee arthroplasty, which is alternative alignments in TKA. So first, let's understand what's normal alignments, Sinu. Then you tell us about alternative.
If I can have the slides, please. Good morning. And like Parag sir said, the hottest topic and controversial rather than hottest topic. If you can get the slides up, please.
Dr. Sinu Kumar.
Dr. Sinu Bhaskaran. So Sinu, while your slides are coming up, which alignment philosophy are you following right now?
Right now, when I'm doing
your slides are
robotics, I do functional.
Functional.
From a kinematic start point. And so that's what I think
Yes,
we should
your
be
time
more
starts now.
clear. So again, good morning everybody, and thank you POSAC for the opportunity. And I'll be talking about alternative alignments, what it entails, what are the different types, what is its relevance, and what is the evidence that we have today. So almost half a century back, Insal and Ranawat had given us this excellent concept of mechanical alignment, in which we cut the knee, cut the tibia and the femur at 90 degrees to the mechanical axis. It worked very well. It was easy to execute. It didn't have any shear stresses because it was completely planar fixation. But what it did is it sort of altered the joint line, as a result of which, it induced soft tissue tightness on one part, especially the lateral side of the knee. And it was claimed by the proponents of alternative alignment that it could give rise to some kind of post-operative pain for patients.
around the same time, Krakow and Hungerford came up with their theory of anatomical cuts. So what they did is they found out that the tibia has got about a 3-degree coronal slope, and they tried to maintain that parallel cut in 3 degrees, and to adjust to that, they gave about 3 degrees valgus to the distal femur. And this is 1980s, and this sort of sowed the seeds of alternative alignments at that time. But along with the anatomical alignment philosophy, they had a few more quirks, like they had their own implant called as a PCA implant, which did not have any posterior slope on the tibia, and it was a CR design. They used this implant with and without cement, and needless to say, there was a lot of failures with this design, and all of this was blamed on the 3-degree varus cut of the tibia, and then this concept was completely banded. So about for almost 2 decades, then we went with the mechanical alignment, straight HK, 180 degrees, 90-degree cuts to the femur and the tibia. And then along came Steve Howell, I think it was 2006, and based on Eckhoff's classic paper of the different axes of knees, what he said is that the knee just does not have one axis, it has 3 axes. And he said if you have to recreate kinematics of the knee, you have to co-align the 3 rotational axes of the knee with that of the component. So how do you do that? So in order to achieve that, what he said is on the femur, you needed to cut exactly the amount of bone that is going to match the thickness of your implant. So that's the distal femur, and your posterior femoral cuts have to be similar to what the thickness of the implant is. And on the tibial side, well, you could just maybe go from 0 to 2 or 3, 4 degrees based on what kind of restriction philosophy you use, and finish the tibia. So kinematic alignment is not about varus tibia. It's all about the femur. You have to resurface the femur, get the femoral geometry as it was, as native as possible, and then you make adjustments in the tibia. So as we see here, so in femur, what we did was just nothing but measured resection, matching the thickness of the implant. On the tibia, you tried to look and match the MPTA, the native slope, and you had well-balanced patients, but the X-rays looked a bit like this and a little bit of varus. And again, the proponents of alternative alignment, what they told is when you're on single stance weight bearing, when you're walking, when you're on a single stance, this oblique joint line becomes completely horizontal to the ground. So again, no shear forces there. But not everybody was happy or comfortable with this extreme amount of varus that you had to impart in the tibia. So then came the concept, Pascal Ventatoli and team from Montreal gave us the concept of restricted alignment. That is, they gave boundaries to what amount of varus that you could give with the HK axis and the tibia as well. So they said about 3 is safe for the HK axis, the tibia about 5 degrees of varus was what is safe. And then there was, to complicate things further, there was the surgeon from Belgium, Vinod de Graaf, who used a robo, and what he said is all the adjustments that is being done in the tibia, now what we'll do is the tibia is going to be sacrosanct. That is, the tibial cut is going to be fixed at 7.5, 7.5. You're going to take out exactly the same amount of bone. That is, the thickness of the component should match on the tibia. And you make the adjustments on the femur, but on the medial side. Not on the lateral side, but not on the medial side, because the knee joint actually, the entire functionality of the knee joint revolves around the medial side of the femur. So he wanted to maintain the medial isometricity of the MCL, but he could make some changes on the lateral side. So that was inverse kinematic. And this is what we practice, something called as functional alignment. Now here we can adjust both the femur as well as the tibia, but within the set boundaries that we mentioned before, 3 degrees of HKA and about 5 degrees of tibial varus. So just a summary of these types, if you can see kinematic alignment, you can make adjustments on the tibia, but then it's unrestricted. You can go to any amount of varus as long as you get your balance right. Restricted kinematic, again similar, but then you have put in boundaries as to what extent of varus that you can give on the tibia. Inverse kinematic, exactly the opposite. Your tibial cut is fixed, but then you can make adjustments on the femur, especially on the lateral side. Whereas in functional, you have restricted boundaries, but you can adjust both your femur and tibia to get that particular kind of soft tissue tension and balance on the knee. So this is just a case in which what we do regularly, a functional alignment pre-plan. This is what, when we are doing a robotic knee, this is what we get the day prior. So if you can see, there is something called as a kinematic start point. If you can see this view here. So here in kinematic start point, my cuts are absolutely fixed. I have 8-8 on the distal, 8-8 on the posterior, and to start off with 7-7 on the tibia. But my valgus and varus, you can see I'm almost putting 4.5 varus in the tibia there. So that's my start point with kinematic. And then I would, of course, adjust it based on what my soft tissue tension is. Whereas on the mechanical, you can see my varus on either, or my alignment is completely zero. I'm not bothered about the cut thickness here. I'm just looking at what my alignment is. I want to get an absolutely 90-degree cut both. But usually, so if the deformity is not much, there's not much of bone loss, what we do is we go with a kinematic start point. And so we do something called a soft tissue tensioning. This is what gives us our laxity targets. That is where I'm going to stop with my cuts. So once I have balanced out the knee, I always try and leave the lateral flexion a bit lax, because I'm trying to recreate the medial pivot on the knee by balancing the PCL. And I have my boundaries set again. I have 3 degrees of varus here and 1.5, so my overall HK is still about 1.5, which is pretty decent, and I'll take that. But again, when we are talking about personalizing or looking at alignments, we are too fixated on the coronal plane. We have to start looking at the sagittal plane as well. And this is what, again, technology does for you. It can match your, and so creating something called as a posterior condylar offset is extremely important. So that is your femur, native femur, and your implant has to be exactly matched. You have a leeway of about 1.5 to 2 millimeter, as you can see in the information chart. So when you match that, that's when you get proper MCL isometricity, and it also helps with your flexion gap, and it gets your medial pivoting much better. So that's what recreating your posterior condylar offset on the sagittal plane is very important. And I think one part of the knee that is completely ignored is the patellofemoral kinematics. So when we are doing a total knee, we are almost looking always at the coronal plane. We do not look at the patella. So again, when you look at the patella, you can see we are matching the trochlear groove here. We also look at our soft tissue window to look at where our quadriceps muscle is lying. It's about 15 centimeter proximal to the joint line. If it is lying outwards, my initial default setting on my my pre-plan is about 2 to 2.5 degrees or 3 degrees of external rotation on the femur, so I get better patellar tracking. And yeah, sorry, and finally, I'll just look at my flexion of the component. That's pretty important to just make sure that my angle of entry of my patella into the trochlear notch is absolutely spot on. So literature, it's massive, like somebody mentioned today morning, it can put you off, but if you look at it, does putting knees in varus increase the failure rate? It does not. So it is pretty safe, going up to 3, 4, 5 degrees. These tibias have survived. You have about 10, 11 years of follow-up. Function and satisfaction, I think that's the most important part. The literature is equivocal on that. We do not have clear studies. The proponents of kinematic telling us that function is pretty good with kinematic, whereas the mechanical guys say there's no difference. So how do you go about? So when you, yeah, fine, sir. So just coming to the practical bit of it, when you have a X-ray like this, where you have a medial compartment or an anteromedial osteoarthritis, I wouldn't think of a total knee. I wouldn't think of a kinematic or functional. What I would do is just go with a unicompartmental here. But if I feel like there's subluxation, the ACL is disturbed there, I would think of a functional alignment or a kinematic alignment based on if the patient can afford robotics. And when you have something like this, severe bone damage, the knee is completely asymmetric. Now, this is a knee that just does not care about what alignment you give it. All you need to give it is a well-stabilized aligned knee, and this mechanical alignment is going to serve its purpose there completely better. So I think the take-home would be that alternative alignment is not a solution for all unhappy TKR patients. What we have to remember is that it is just one of the modalities to achieve better knee kinematics. It does not do a whole lot of change there. You can consider a functional, that is with technology, robotics, or without technology. You can do a kinematic in mild to moderate deformities, especially in something called as a CPAC 1, 4, and 2. That is the varus kind with the oblique joint lines. Mechanical alignment is still very relevant, especially with severe deformities, and if there is bone loss, I think there's no question about thinking of these alternative alignments, just go in for a mechanical. But most importantly, with the amount of technology where we are having, the amount of, and I think with artificial intelligence just around the corner, we should be able to personalize alignment options for our patients rather than just stick to one fixed alignment option. And I think that is the future. Thank you so much.
One quick question to the panelists. With recent technology advancement, there's all new theories coming up for the alignment. But for an average orthopedic surgeon, for a younger surgeon who is still doing a conventional TKR, how relevant do you think that these alignments are reproducible, number one? And
So I think it's basically absolutely, there are marginal benefits to using robotics, no question about it, but really marginal benefits. I mean, all the points that are come out in, that are being used for marketing today are actually 50% of the things are lies. Okay? So let's be very clear on that. It does have marginal benefits, and especially for mild deformities when you want to. The second line was very critical. It's for mild and moderate deformities. It is not for major deformities. And any new surgeon who is starting off, if he starts off using robotics alone without getting the hang of conventional, is asking for big trouble. So you really need to master conventional surgery first and then go on to robotics. And certainly you can use robotics if you feel in your practice, but you need to do significant numbers with that. And anybody who wants to follow the kinematic alignment principles without using technology is again asking for trouble. Because conventional surgery, if you say that I'm going to give 3 degrees varus to this particular tibia, you will not realize when that 3 degrees varus becomes 7 or 8 degrees of varus just by cutting the saw.
Yes, Mahesh?
Yeah, no, I completely agree.
Your philosophy of which you do first and then you can
stick to mechanical alignment. At the most, go for functional alignment if you have a enabling tool like a robotic or navigation. But freehand, don't try to say that I am giving 3 degrees cut. It will never happen.
What do you use in your practice?
I use the Mako robot if I want to chase alternative alignments. For all my conventional surgeries, it's going to be sticking to mechanical alignment.
Okay, but if you're using robot, your go-to alignment is
functional alignment. Yeah.
Kiran?
Yeah, so I agree with what Hemant said. Stick to conventional, and if you're using conventional, stick to the principles. Don't try to use your eyeball, because my eyeball and my varus is different to the other person. So I would stick to mechanical using conventional instruments.
Me, I'm still 100% mechanical. I aim for 90-90, neutral. You know, in those rare cases with severe deformity, now I go to adjusted mechanical, where I don't really release as much as to release before and accept that little bit of, varus there. And that's my go-to alignment. Anything you want to say, Hemant? Otherwise, we go to the next talk.
I do most of my cases conventionally. I don't prefer robo for this. And as the panelist has already mentioned, mechanical axis following is something which is easily reproducible and it cannot be debated unless you have a distinct advantage of technology.
Yeah, true. I think mechanical is, if you do not have technology, that's one way to go about it. But there are ways how you can do it without a robo as well. That is the classic Howell's technique of using a caliper.
Yeah,
but
but
then
very
again, you need to get a
using caliper, it needs a lot of imagination, that you are imagining that there was 3 degrees of bone loss here and then I'm measuring.
Yeah,
even the bone loss with the saw itself, saw is 1.25 millimeters, so that much bone is destroyed. How you use the saw, again, a lot of imagination.
There's a lot of
So anyway, let's conclude that it's difficult. People like Howell can do it, but in a crowd like this, it would suffice to say what Hemant said is that if you want to use alternative alignments, go for technology, otherwise stick to mechanical. I think with that message, thank you, Sinu. Great talk. A big round of applause for Sinu. We'll go to the next one, and we have Dr. Murtuza to speak to us on rotating hinge TKR in a patient with severe varus deformity. Dr. Murtuza, please.
Yeah, hi, good morning. Sinu, thanks for confusing me even more. I feel like from the Jurassic era now. Just one point. I think most of the implants that you put in using functional alignment are actually designed for mechanical alignment. So I'm not sure, they have not really bridged that gap yet. So I think we're probably putting the horse before the cart in a lot of the times. Anyway. So I'm just going to talk about a couple of cases where I had to use a rotating hinge TKR in a primary setting in a patient with severe varus deformity. So basically, this is the easiest sort of varus grading that I found, A, B, and C, basically with increasing varus and increasing bone loss. The basic principles of managing a varus knee are good preoperative planning, a scanogram, a good implant selection, having a lot of things available on table, clinical assessment, thorough clinical assessment, intraoperatively a good medial release, removing the osteophytes, a good metaphyseal correction if required, and bone loss management. I'll just jump into the cases. Now this actually, I didn't use a rotating hinge. This is, I think, a while back, probably 10 years ago. This was a 59-year-old lady with rheumatoid arthritis, with severe bone loss, as you can see, with the severe varus deformity. And at that time, I actually went in for a semi-constrained
Just go back, did you do any neuropathic workup for this case, Murtuza? Because I think neuropathic workup, because if you go back to that X-ray, the first thought, just previous slide, it looks like a neuropathic joint. So this patient is a rheumatoid, you said.
She was a neglected RA.
Okay.
No neuropathic.
Okay.
So basically, I ended up doing a semi-constrained total knee replacement. I think at that time, I didn't really consider the rotating hinge. As you can see, it was a very difficult case. I had to use a lot of bone graft, particularly posteriorly, which was quite difficult. Anyway, she did quite well. She unfortunately passed away a few years ago, but I think this gave her a good 7 to 8 years without any problems. The cases that I want to discuss now are these two cases. This is a lady, I think she's around 60-year-old with this presentation, with the severe varus
Hemant, so
deformity.
we'll just stop you for a minute. What does the X-rays show you? What do you think first thought?
The complete lateral ligament, insufficiency. So there is absolutely no competent lateral structure at all. And in that situation, you will need to do complete medial release and obviously need to go for a hinge. With such kind of soft tissue insufficiency. The question is between LCCK or constrained knee or a hinge. So that is the decision.
चल सकते हो उतना चलो बस.
She was basically bedbound for almost 5 years. We just got her to walk to school.
वो मेरे को उनका पैर दिखना चाहिए सिस्टर. हाँ वो वाला. हाँ बस. आ जाओ.
Challenging
She also has
case.
polio on the other leg.
2-3 कदम चलो ना जितने चल सकते हो.
There's a marked varus.
दूसरे पैर का कुछ करना पड़ेगा.
Varus thrust.
दूसरे का देखिए ना क्या कर सकते हैं. ठीक है ठीक शुक्रिया.
Okay.
With hyperextension.
तो कितने 5 साल से ऐसे चल रहे. इतना कैसे रुके आप लोग यार. इतना सिचुएशन में इतना खराब होने तो कैसे रुके.
Total ligamentous instability, and I basically went in for a hinge primarily.
Nice.
This is her. This is, I think, approximately 3 months after she refused the brace. She was able to manage
मुड़ा पिता सीधा मांडी डाल मांडी जितनी आसानी से जाओ बाकी जबरदस्ती नहीं कर देगा.
Spend a lot of stress on that hinge. Can't be too relaxed. Because hinge as well. So.
This is the second case. This is also non-neuropathic, severe varus deformity.
Was this a correctable varus, Murtuza?
Sir?
Was this varus deformity correctable or fixed?
It was fixed.
Fixed.
I'll just show you some. This is his video working.
Okay. Yeah, go on. That's fine.
I'm sorry, it's not.
No problem. We saw a glimpse of it.
This is the, as you can see, he had a fixed varus and a fixed flexion deformity as well. With it's gone into sort of sublux posteriorly, the proximal tibia, and this is what I did.
The question is, could you have got away with a CCK type of implant here instead of a hinge?
No.
Because most varus knees, you can get away with CCK knees.
He had a lot of lateral laxity as well, a lot of PLC laxity as well. He had a large defect, but I just could cement it. I didn't need augments.
Right. Yeah. Go on.
This is immediate post-op actually. He's very praised, but you can see the...
Very good.
That's correct. He still not come back to the other side. That is one of the reasons. So basically, I've started using this particular joint. I think a lot of you must be familiar with it. It's the buccal papas joint. And I just wanted to mention it because it comes, the femoral component has the hinge actually attached to it. So the tibial insert and the hinge is attached to the femur. So basically, all those steps about reaming a hole, putting the bush cam, etc. are gone. And that the insert, the stump actually goes into the tibia, into the hole into the tibia. It's a little tricky to get it in. You have to put the tibia first, and then while you cement the femur in hyperextension, you have to make sure you get the stump, the tibial.
This is like a mobile bearing kind of only. Mobile bearing.
It is rotating hinge. Yes, and that rotates on it, and also a hinge. Thank you.
Great. Finished perfectly in time. Thank you so much, Adib. Great cases. Well done. Go to the next presentation by Dr. Umesh Nagre, and he's going to show us how he treats infected TKRs, and we'll have some discussions as we go on.
Good morning everyone, and good morning panelists for giving me opportunity to present this work we done in Dinanath. So infected TK is a big problem for any surgeon who is practicing the total knee arthroplasty. So chronic periprosthetic joint infection after TK is difficult to manage. Lots of investigations are required. Diagnosis is multifaceted and elevated inflammatory markers. We used a lot of radiographic changes we have to see. And ideal is two-stage reimplantation and prolonged IV antibiotics is a standard of care. We use static spacers often lead to the bone loss, instability or extensor mechanism injury. And intramedullary rod with the cement spacer offers the stability and able to maintain the limb length. So while diagnosing, we follow this Parvezi and et al. Group 2018 criteria for diagnosing the infection in total knee arthroplasty. Obviously, we divide them whether it's acute, less than 3 weeks or 4 weeks coming to your clinic after the surgery, or it's a chronic infection which is more than 4 weeks. Most of the time it's a coagulase negative staph aureus when they come late in your clinic, and we need a complete removal of the prosthesis followed by extended antibiotics in consultation with your infectious disease department, ID department, and then you continue antibiotic, you stop antibiotics, do the blood test again after 3 months, and then you put the patient for revision cases. So I just want to discuss one option, what we use in our, I will discuss the case also. So intramedullary rod with the cement spacer. So indications are chronically infected TK with extensive bone loss, incompetent soft tissue envelope and ligamentous instability. Then medically compromised patient unsuitable for immediate reimplantation and previous failed surgical debridement. So in surgical technique, we remove the prosthesis, infected tissue, insert the titanium rod across the femur and tibia in a reverse manner, prepare the antibiotic cement, then pack the cement in metaphyseal area around the femur and tibia, mold the cement to preserve the extensor mechanism, and no post-operative immobilization is required. So obviously, first step is explantation and debridement. All periprosthetic component should be removed and residual cement is meticulously removed. Then complete synovectomy is done. Extensive debridement for necrotic bone till you get the punctate bleeding is done, and intermedullary canal of both the femur and tibia is open, brushed and irrigated. So till you get the punctate bleeding, you keep doing your irrigation. Then you take the slotted titanium rod, at least 6 inches. So you do the long leg film, so that from the joint line, you measure 6 inches in tibia, 6 inches above the femur. So there you need you get a length, how big rod you are using. You take a cement, you add standard 2 gram vancomycin per 40 gram, or you can add tobramycin also 2.4 gram. Obviously, jointed held in slight distraction about 5 to 10 degrees of the flexion. Then insert the retrograde that nail into the femur. Then insert antegrade into tibia again. And it's positioned with the bow anteriorly. So you mark it with the marker pen. And there is a flat layer of the cement is placed over the femoral side after putting the metaphyseal cement in tibia and femur, both the sides. So this film is important, so you can make the arrangement beforehand. So you should have the reamers ready to prepare the femoral and tibial canal. So if you see in this picture, there is a white marker is there. So you mark that anterior bow so that before packing the cement. So this is a post-op X-ray. You can see the rod is inversed and it put inside the tibia. So this is a tibial rod. This is an 8 millimeter rod. So if you see this during the insertion, you put the rod in femur first. The bow of the tibial nail should be anteriorly. So your assistant is pushing it inside the tibia. Then you take a marker pen and mark it that that bow is anteriorly, and then you start packing the cement in metaphyseal area. So I will run this video quickly. So you can use your hand. In literature, some of the people, like Japanese people, they use the cement gun. If you have what they mentioned, if you have the immunocompromised patient, you can have the cement gun. You put a cement restrictor, or there is no need for cement restrictor. You push the rod inside, you take a cement gun and put that cement using the cement gun, both the sides. So once you've done the hand packing, then you start putting the cement around that area. So you can use a retractor or Langenbach so that the cement will not go all the way to the posterior capsule. You put cement around that rod. So this is after the surgery. So patient can mobilize on this immediately without using a knee brace. That's the most advantage of this thing. Second thing is cost. Obviously, we are cutting the cost. Where tibial nail is available for any local company, you can use, not needed to be a titanium rod. And if the patient want to go for the revision surgery, you can take it out very easily. So when you open the knee, you break that cement first, which is inside the joint, like inside the, just below the patella. Once you take it out, taking out that metaphyseal cement is very easy. Once you break that, it just comes along the cement, and you can use either RHK or tumor implant. So this is a lady, we did the revision surgery. This is after the 6-month post-op, she is mobilizing. So obviously, use of drain and non-observer suture is standard. No immobilization or brace is required, and patient is allowed to do the full weight bearing immediately. So advantages, it provides inherent knee stability. It prevents the special dislocation and bone loss. It allows early mobilization and brace preambulation. Then higher local antibiotic concentration is achieved. So, but there are limitations are there. The functions as a temporary fusion. It limits the mobility, may lead to muscle contracture with prolonged use, less suitable for the patient expecting early reimplantation, and technically demanding while removing the, during the reimplantation if you use a cement gun. It's very difficult. So I like to conclude, IM rod with cement spacer is an effective option. It offers the inherent stability and early mobilization. It requires a careful patient selection and multidisciplinary coordination. It's a reliable option. Patient can weight bear immediately. It's cost effective. Reimplantation is easy. Even if you see the literature, 64% of the patient can go for reimplantation. If it's an immunocompromised patient having renal issues, uncontrolled diabetes, age, compromised heart condition, in those patients you can continue using this and patient can mobilize, not doing the revision surgery. And when this technique is performed, implant removal is very simple. Last thing is, it's a durable solution for first stage of second stage revision orthoplasty for chronic periprosthetic knee infection, PGIs. It's a brace-free mobilization, and insertion and removal is relatively simple, and it's a cost-effective also. Thank you.
Okay, thank you very much. Any quick comments, Mahesh? For the lack of time, just we'll take one comment.
No, I think it's a good salvage technique if there is a disruption of extensor mechanism, skin problem. So I think it's a good salvage option, can be used as a temporary or a permanent solution.
Thank you.
Next speaker, Dr. Agase. Difficult revision TKR when only hinge knee is not sufficient.
Thank you, Shailesh and Govardhan and the organizers. And I have modified my presentation from a lecture to more of case presentation. And if the panel allows us, we can go for 2 or 3 cases. So, yeah. The first case I would like to discuss is a 64-year-old gentleman, had a primary knee 5 years back, sustained a fall immediately 2 years after the index surgery. He was treated conservatively. The X-ray is not available that time when he had a fall, and progressively experienced difficulty in walking and gradually was unable to bear weight. All signs of infection, blood parameters were negative. We aspirated the joint and the aspirate turned out to be non-infective. And that's the X-ray now we are going to deal with. We are dealing only with the right side. The left side is doing well. And on the right side, the patient has pain, inability to weight bear, and all the signs of infection are negative. So on to the panel, what to do now.
Yes, so this is how many years post-op?
This is 5 years post-op.
After the history of fall?
After history of fall, now 3 years.
So this is 3 years later.
Surgery 5 years. Had a fall 2 years.
Is there a disappearing femoral stem? I can't see a femoral stem.
There is no femoral stem.
Thank you.
Yeah, so Mahesh, how would you tackle this case? What is your thought process, Mahesh? Infection is ruled out.
Yeah, I mean, this unfortunately, the distal femur is completely disappeared with just a hint of medial condyle left behind. So I think you need a complete revision here. What was the stem? Which implant company is the stem?
Looks
TC3.
like Depu.
PFC femur what?
I was not the primary surgeon.
Yeah. So, I mean, a hinge is a good option, but you probably need some tumor implant to substitute for the distal femur, or you can use metaphyseal cones or sleeves. But the problem with cones and sleeves are they're too big for our patient population.
Kiran,
unless
anything
you procure some local
different, Kiran, you would like to do?
Oh, well, just replace the lost bone. Obviously, infection is ruled out, as I said, and I agree with what Mahesh said. So the sizes are important, and I think the new Indian companies are coming up with the tantalum smaller cones. Yeah.
Yeah, so a hinge for sure, in my opinion, probably some kind of a tumor process is what I would keep ready. And if the cones and sleeves are not adequate. So what did you do? Show us.
So the same thought process we had, probably we will probably need a tumor implant for this, but let's try doing a hinge with cones. So fortunately, with the Indian implants available, the cones that are available, the composite cones are comparatively smaller compared to the international companies that we get. And that's the post-op X-ray where we have used a composite hinge, a composite cone which is going into the funnel of the femur. And with that, we could distalize the femur to a large extent with augments put on the posterior and the distal side, and revising the tibia. We chose not to take out the screws from the tibia, but put a rod. We could negotiate the rod on femur and tibia and use a cone and a hinge implant from an Indian company.
Okay, nice, well done. Any more case?
Yeah.
So last case.
70-year-old gentleman, bilateral total knee 2 years back, was doing functionally very well, but had a road traffic accident in a car and sustained lower end femur fracture. And that's the X-ray that we have got.
Yeah, Hemant, this is what intra-op now, the femoral component has come off. What are you going to do?
It's a pretty low fracture, so there's no fixation is going to be out of question here. And again, the simple question is how are you going to build up the distal femur? Especially when these patients are quite elderly and porotic, so fixation I don't think should be done for any of these very low fractures. So RHK is going to be the treatment of choice. Otherwise, you're talking about a tumor prosthesis to replace the distal femur, which is expensive affair.
Okay.
So a cheap, what I have used, especially in low demand elderly patients in such cases, is a fully cemented stem with RHK. And I've actually built up the femur and done a fully cemented, even with a cement restrictor and using a syringe gun like a hip.
So
and
pack
pack the whole femur with. That's the only instance where I would use a fully cemented femoral stem.
So my question to the panel is, this is just a 2-year-old total knee, well functioning just before the road traffic accident. Now you have this X-ray, and any guidelines how to take out that well fixed femur and preserve the bone at the same time?
You can't, practically can't. So if here again, if this is a younger patient, then you would actually need to build up the femur, and you could use cones in that situation. You'll have to use cones and build up the distal femur.
So maybe a flexible cone in this case where you go up to the diaphysis.
You can use the metaphyseal fixing cones there.
The only thing is I can say is, of course, Hemant has definitely said that, and I do agree. But if you have a very aggressive trauma surgeon, you don't remove it only. You just try and fix it, use a allograft, and build up the bone. That's one way you can avoid removing. But yeah, I do take Hemant's point. But that's the only different solution I might put forth.
If one chooses to fix it, then you need a double plate. Never use a single plate. You need plates on both sides.
Right. Right.
So when we went in, we saw that the whole distal femur was separate from the proximal shaft femur, and it just came out in hand. So taking out that well-fixed femur was impossible. Now reconstructing it with a sleeve, that time the Indian sleeves were not available, so the cones were not available. So we chose to go ahead for a tumor implant like this, where we have reconstructed with a tumor implant with a cone of around 50 millimeters or 80 millimeters and a sleeve added on the top of that so that we get a plain surface cut where our cone and the sleeve goes and matches flush, and a cemented stem on the femur and the tibia.
Yeah, nicely done. Great. So any comments from you, Kiran?
Yeah, well done.
Nice case.
So can I show one more case very close to
Okay,
my
30 seconds you have.
Yeah, my heart. A 51-year-old lady had a road traffic accident 15 years back, a compound femur fracture, lower end, treated multiple times, multiple incisions on the front side, was treated initially with a fixator, and was walking non-weight bearing for 15 long years. And that's the X-ray we have, and this fracture is 15 years old.
Right.
And the reason for not getting treated
So this was non-union
financial
completely.
issues.
So this patient came to you with this kind of a picture.
Yeah, this is the picture the patient came to me with.
Yeah. So the options you have are, of course, the tumor processes in my hands, or then think of a knee fusion if the patient is not willing for a replacement. Yes, Hemant?
The one thing you need to rule out is residual sequestrum or infection by doing an MRI scan, because the external fixator pins could leave a little bit of sequestrum with some dead bacteria there, and the recrudescence of infection is a possibility.
Absolutely.
But otherwise, the answer, as everybody has said, is a hinge with tumor.
We had 3 questions in mind. First, is there any residual infection? Second is the multiple scars on the front of the knee. So which scar to choose? I had a plastic surgeon to help me out in the scar. And the last portion was the affordability of the patient.
Yeah.
That's the tumor prosthesis that's done by the Indian company, and this is the intraoperative video of the patient showing this is a non-rotating hinge type of implant that we have used, which normally we use for a tumor implant. We had done a Keblish approach going on the lateral side and reconstructing the whole distal femur, and her 10 years post-op function after the index surgery. This was done in 2015, and this is the video shot in 2025.
Nice. Congratulations. Big round of applause. Thank you, Abhijit.
Well done.
Thank you, sir.
Go to the last talk of this session, and we have the best person at the last. Abhishek, please show us TKR in a neglected case of rheumatoid arthritis with 50 degrees valgus. I have never seen one.
Yeah. Thank you, organizers, for the opportunity. So I'll quickly move on to the cases. So she's a 62-year-old female who was a known case of RA. Neglected, gradually progressive deformity and pain. She neglected it till the point of extreme disability. When she presented to us, the range of motion, she had 15 degrees of hyperextension and further flexion up to 140. Valgus deformity of around 40 to 50 degrees, which was partially correctable up to 20 degree valgus. Quad strength was fair, rest was normal. So those are the clinical pictures to show, and the deformity is mainly in extension and disappears in flexion. So this is the gait of the patient preoperatively. And please excuse me for the quality of the x-rays. These were done in a peripheral center. So we can see the AP and the lateral view, the AP view showing us the bone loss. And under spinal anesthesia, when we tried to give a valgus stress, that is the amount of valgus on your left side.
So I think that is an important point where the deformity is correctable. Had this been a fixed valgus, this would have been a very, very challenging case. So from 50, it is coming to 20, 25, which is a good thing. So Kiran, what implants will you keep ready? What will you tell your resident?
Whenever you go in for such cases, you have to keep the entire armamentarium and don't be sort of complacent.
So what all will you keep ready? Just regular conventional in addition to that?
I'll go to the hinge. I'll go right up to the hinge.
You'll directly think of a hinge in this case.
Yes.
Yeah.
Okay.
So that is exactly what we thought of, and we had kept it on table. Of course, these were the issues: exposure, releases, angles, how to balance the cap, rotation, how to manage the defect, which implant, and whether there will be a common peroneal palsy post-operatively, and how to rehab this patient. So in these extreme valgus deformities, we typically go with the mid-vastus approach. Minimal exposure that is just enough for the minimal release that is just enough for the exposure. -2 cuts on both sides to minimize our cuts. Gradual release to balance the gaps in the extension, and then focus on getting the proper rotation using all 3 landmarks that we have. And then we trial with stemmed components, build up the defect with cement, and we trialed with the semi-constrained implant.
Mahesh, would you think of a lateral parapatellar arthrotomy to expose this?
No, I don't like to do it. I stick to the medial parapatellar approach in nearly all my cases. It's something that you need to be aware of, but I don't like using that approach.
Okay.
The problem with using lateral parapatellar approach is that the approach itself you are using as a release.
Yes.
But at the end of the case, you cannot get a watertight closure there. And any subacute infection can track down to the prosthesis.
So in these extreme valgus, instead of using the medial parapatellar, we typically use the mid-vastus approach, which we believe helps us with the patellar tracking.
Right.
So this is what we could get. We've used a semi-constrained implant with offset stems. This is LCCK with a minimal poly of 10. After trialing, the ligaments were good enough, and I thought at the end of the case that I could have gotten away with a simple PS also.
This is the LCCK.
Yeah, this is LCCK.
So Hemant, let's say you go for your post-op rounds for this patient, you find that she cannot dorsiflex the foot. What do you do?
I would have warned this patient pre-operatively about the foot drop. So, first of all, important thing is that immediately post-surgery, you should not be keeping the knee in full extension. Keep the knee in 30 degrees flexion. Make sure that the lateral poplity is actually functioning, and then gradually extend. Because on table, if you got the full correction, I mean, I didn't see much of, huge fixed deformity. It's only correctable to 20, so I would not expect. But in case it happens, see, many times, in fact, pericapsular infiltration also gives you sometimes this transient lateral poplity, and that recovers in 24 hours.
Yes.
So just be patient, and usually it recovers.
Yes. So we nursed her in flexion.
Anybody has explored a nerve post-operatively in the audience after a severe valgus deformity? You get a foot drop. I have never explored, and only one patient didn't recover out of the 8 or 9 which I had.
The only policy that I have had is a fixed valgus secondary to the high tibial osteotomy.
Yes.
And those fixed valguses secondary to high tibial osteotomy become extremely difficult challenge for balancing and lateral popliteal palsy.
Yeah. Okay.
So we started with full weight bearing on day 1, long knee brace for the first week, and we had to be very aggressive with the quads workup. So that's the patient walking at suture removal, and that's her walking at 1 month of follow-up. So we have a 5-year follow-up on this patient. She's mobilized comfortably without any support. So just to take the spectrum a little ahead, and this is similar, not a similar case, a different case, but at the other end of the spectrum. This was a 51-year-old gentleman with history of tuberculosis as a 20-year-old, so 30 years back, and gradually progressive arthritis and deformity of the knee, and it reached a point where he could no longer carry on. He's been free of infection for over 30 years now. So that was the left knee, and we can see the tuberculous sinuses on medial and lateral side. And that is the pre-op X-ray and scanogram. And when you ask him to do an SLR, he couldn't do an active SLR also, so he actually turns his leg and uses the IT band to help in SLR.
So is that patella subluxated by the side?
Yes, yes, yes.
The patella is out.
Yeah, so last case we didn't have many issues with the patella, but in this case we did.
So in valgus knee always patella is an issue, So that is why sometimes if you have a fixed dislocation of a patella, probably a lateral approach is one of the indications, in that situation.
Yes. So in this case, we had to do a lot of planning, and in this case, it was a no-brainer. We had to use a hinge, and we did anticipate that patella will give us trouble. So the same hinge that Murtaza Adib sir showed, the same hinge, Bishal Papa hinge with a rotating platform was used. We had a lot of difficulty in getting the patella tracking proper. So we used the mid-vastus approach. We did a complete inside-out release. And at the end of the closure, the patella was still subluxating. So we had to do a VMO advancement to get it back in its place.
Exactly. I was just going to ask you that. So you did a VMO advancement.
VMO advancement. And therefore...
Along with some kind of a lateral release or...
So complete release and then VMO advancement.
Okay.
And of course, so in this, he was not allowed any flexion for 3 weeks. We started flexion after 3 weeks and gradually progressed. The maximum flexion we could achieve in this case was 90. Quadriceps were very weak, so we had to really work for over 4 months to get his quadriceps strength. And now, currently, there is no lag, and these are the walking videos of the patient.
Nice.
That's his activity, and that's
Great.
his...
It's a great outcome. I think just one word of caution here. Anytime you're relying on your sutures to give you that, soft tissue tightening, that's what you're trying to achieve. 3 weeks is not going to be enough. So it's either 6 weeks or even sometimes 3 months.
Okay. Yeah, so we did it at 3
And
weeks.
in fact, as a surgeon, we want to mobilize the patients fast. We want to get the knee flexing very, very rapidly. And that's a problem if you try to mobilize them early, because once the sutures give way, it just comes back. So in fact, sometimes 3 months, patients in plaster for 3 months.
And so the take-home message is don't get intimidated with what you see. Examine the patient carefully. Most of the laxities that you see in these cases are pseudo-laxities, where the actual ligaments may be good. Anticipate all your problems and be ready with the backup. Expect the worst and choose the right implant. And lastly, not to emphasize more, failure to plan is plan to fail. Thank you.
Congratulations, a big round of applause. So I think we'll wind up. Govi, we have finished in 55 minutes, 5 minutes before our time. So I call all the speakers. Dr. Santosh, please come up. All the speakers will take a photograph.
Good morning, everyone. So I'll be presenting 3 case scenarios on total hip arthroplasty with ankylosed hips and spine. So this is the first case scenario. A 44-year-old lady who presented with bilateral hip pain since 5 years, and these are her pelvis with both hip antero-posterior view radiographs. So,
what is going through your mind? I mean, we've ruled out infection. These are arthroplasty patients. You are going to do a hip replacement. So what is running through your mind when you see such complex?
This is the only X-ray in front of me. I would prefer more imaging, but if this is the only X-ray in front of me, so the things which come to mind are, the space where the femur has gone up. So my idea is to get the hip back where it belongs. So the teardrop is a good sort of focal point for me. I would look at the offsets here, and I would look at the canal, and that will dictate my implants and my approach.
Yeah. Any other options, Rohit?
Yes, rightly said. The patient has a posterior superior widening of the acetabulum. So it's a shallow acetabulum. So you have to get the hips center back. So I would like to see the lateral X-rays also, and also the spine X-rays. So we're going to see how the spine is.
yeah, so we'll focus the discussion around the workup for the spinopelvic relationship. So these are her sitting and standing lumbosacral spine X-rays. This patient actually had spondyloepiphyseal dysplasia. As you can see, there are bullet-shaped vertebrae which are elongated antero-posteriorly, and she also has an L3-4 anterolisthesis.
Anything that you notice, Abhijit, seeing the standing and sitting X-rays? Obviously, we haven't given you the angle calculations, but can you tell us briefly what is it that you're looking at?
The mobility of her LS spine seems to be decreased, so you'll have to adjust your versions, in this case at the acetabulum.
Yeah. So basically, as Abhijit has mentioned, you need to look at the mobility of the spine to see if it's a stiff spine or not. And the second thing you need to see is if the sacral slope changes from standing to sitting position. So I think we can move on.
So as I rightly said, this was classified as what we call as a mobile spine. If you can see in standing position, the lordosis is well maintained. and the sacral slope is about 35 to 40 degrees. And in the sitting position, you can see that the lordosis has been obliterated. The patient has a more or less kyphotic or a flat back, and the sacral slope has reduced to about 10 degrees. So this is where we classify the patient as a mobile spine. So here, how would you change your component positioning? What would be your bearing surface? Would you try to restore the center of rotation or accept a high hip center?
Yeah, Kiran.
Certainly, I will not go for a high hip center. It's a deficient acetabulum. The bone stock is, and there's enough bone stock down there. So I would try to bring the cup down where it belongs. I won't accept a high hip center. The surface, bearing surface, depending, I would prefer a ceramic bearing surface, but depending on the patient affordability is an issue.
Dual mobility, would that be an option here?
I'm sorry?
Would you opt for dual mobility?
That is again a cost option, but with a large diameter head. So I want to know the diameter of the acetabulum and what, if I can get a 36 head, I won't go for a dual mobility. I would stick to the standard components. But yes, that is always in the armamentarium.
Rohit, anything different that you would like to think?
I would still want a lateral X-ray.
So the patient had only 5 to 10 degrees of abduction, so there was no way we could do a lateral X-ray for this patient. But how would that change?
How will you lateral? How is lateral X-ray going to help you?
It will quantify whether how the shape of the acetabulum is, whether it's elongated superiorly, or is, so we'll get to know how whether we'll be able to get an AP fit of the cup.
Yeah.
So if not, then we can do a CT scan so that we can
One
plan
point is, this is a bilateral case, so I would not mind to put my hip a bit on a higher side, because getting the hip into the native acetabulum is going to be difficult. The head is destroyed. You do not have a graft to put in. So don't mind putting the head or the hip in a bit higher center. Antiversion, I would not change. Bearing surface, ceramic on poly. Unless on table, after trialing, if it is becoming unstable, I would change it to a dual mobility. But otherwise, it would be a ceramic on poly. A bit of higher hip center is okay.
Yeah. So what did you do, Sahil? Yeah.
So since this was a mobile spine, this is not really an indication for dual mobility. Here I went for a high hip center because in CRO 1, 2, and 3, a high hip center is well acceptable because that is where the bone stock is the best for that particular patient, especially in a bilateral case. So here I opted for a ceramic on poly bearing, since there was no risk of impingement with standard component positioning.
Yeah, looks good. So what Sahil is trying to say is, even if there is a spinal deformity and if it remains mobile, then they fall into the category of 2A. And those are mobile spines. You don't need to really alter your acetabular position or use dual mobility for those ones.
So just to highlight the basic biomechanics is, when you go from a standing to a sitting position, you want the posterior tilt of the pelvis to allow the acetabulum to open up, which is what we refer to as biological opening of the acetabulum. Because when we sit, it's not really the femur that is flexing 90 degrees. Femoral flexion is only up to 70 degrees, but there is a posterior pelvic tilt of about 20 degrees. So as you can see in the video here, as the patient goes from a standing to sitting position, the pelvis tilts posteriorly, and that changes from lordosis to kyphosis of the lumbar spine. So going to the second case.
He's reamed out the acetabulum quite a bit, so there's a lot of protrusion there. So I would still be careful about preventing bone loss, where already there's superior bone loss. Then
So that was a slight-
medially there's bone loss. So I would try to prevent that from happening and concentrate like on the combined offset and what femur you're going to use. Again, because of cementless stem, you can't play around much with that. So
Yeah, so in these cases, there is increase in the native anteversion, so I kept a Wagner cone on standby, but I didn't really need it for this case. And the slight medial protrusion was intentional cortiloplasty that we do to get a better fit of the cup.
This is a jumbo cup which you use, right?
No, this was a routine. I think it was 4850. So the second case is a 54-year-old gentleman who had known ankylosing spondylitis, and these are the radiographs of the pelvis with both hips, and he had pain in the right hip, and that is a lateral radiograph of the right hip.
So again, Abhijit, what do you think?
So looking at the X-ray, this is a cat-eye view. So that means your pelvis is in flexion, and you are probably a stiff spine most probably. So you need to have an X-ray of the spine in sitting and lateral position. If you have a stiff spine where the sacral slope is not changing.
Yes, so these are the standing and sitting spine X-rays.
So I think the sacral slope, it looks to be a stiff spine where it's not a mobile spine, and the sacral slope is not changing. In this case, I would change my acetabular version and would definitely consider a dual mobility in this case.
Yeah. So as rightly said, this is a stiff lordotic spine where the patient is stuck standing. why we say stuck standing is because in standing position, you expect lordosis in the lumbar spine, but in the sitting position, that lordosis is still maintained and it has not transitioned to kyphosis. So as you can see, the sacral slope is more or less the same in the standing and the sitting position. So this is what we call as a stiff lordotic spine or stuck standing position.
This is an excellent case, Sahil, because in a ankylosing spondylitis case, normally you get stuck sitting because the spine is absolutely flat.
Correct.
And they sit with a flat spine, they stand up, it doesn't correct. This is a rare finding of an angspond which is fixed in lordosis. So this is actually an eye-opener, this case.
So I was also surprised to see this because as Agashe sir said, on the AP view you can see the cat's eye open. So that would lead you to believe that it is a posterior pelvic tilt, but that was not the case out here. So what would be your plan here, bearing surface and component positioning?
So would you change anything here? What? Yeah. Kiran, what, the same?
So most important is, again, dual mobility component in this situation, especially with angspond, and also make sure that the combined version, the TAL, is always guiding you.
Rohit, anything different?
Slightly more anti-version and it will not get back up.
I have a question for Rohit. He does a dual direct anterior approach so well. And do you really have to think so much about the spinopelvic relationship if you're doing a DA, or you don't really need to worry about it?
DA is just an approach. I think it still matters. So all patients, we will have to consider the spinopelvic relationship. So doing DA does not solve the problem.
Away the problem.
Mahesh, just one question. You talked about using TAL as a landmark, but in these situations, you're trying to alter your versions with respect to TAL. So TAL, you are actually not going to go parallel, but you're actually going to increase the version with respect to that TAL.
That's why it's so
that's why it
important.
becomes a reference during surgery.
Yes. Exactly.
So TAL serves
You
as a
still use it
landmark,
as a pole star.
reference point, correct.
Yeah.
Actually, with a DA, he should use less anti-version. The tendency is to put more in
standing would
Yeah.
increase.
So Sahil, I think, do you want to show the third case or you want to explain the spinopelvic finding?
So here the biomechanical... So if the patient is standing in the normal position like this, if the patient has a stuck standing position, means the pelvis will be tilted more anteriorly, the acetabulum will then face downwards. So what will happen in this patient is, as the patient sits or flexes the hip, there will be a risk of anterior impingement and posterior dislocation. So in this patient, to avoid this problem, what we have to do is increase the anteversion, and this will allow the patient to have impingement-free flexion and extension. So the take-home message here is that because there is a risk of anterior impingement and posterior dislocation, I opted for dual mobility and increased my anteversion in relation to the transverse acetabular ligament.
Yeah, excellent, excellent case.
So if you allow, I can just run through the last
Yeah,
case.
run through the last case.
So this was a 40-year-old gentleman who had fused hips and spine since 19 years. There was a 50-degree fixed flexion deformity in both hips, no fixed flexion deformity in the knees. These are his radiographs.
So fused hips. Say, Rohit, what do you think?
So this patient is ankylosed, so we will have to again plan it accordingly. So I would definitely plan to do both the hips on the same day because then post-op mobilization will be easier. And this can be taken down easily with the help of direct anterior approach. And we've done a couple of cases with this and they really do very well. So because it becomes easier, in fact, with the DA, when you do an osteotomy, it becomes very easy. You can dream over the...
Yeah, you directly land up onto the anterior neck, so it's much easier. What about the spine relationship here?
As we expected in the previous case, here you can see there is a posterior pelvic tilt with oblong obturator foramina or cat's eyes open, as we say. And these are the standing sitting x-rays. But as you can see, it's actually the entire trunk that is moving. There's no movement at the spinopelvic junction. And this patient actually has a flat back or stiff kyphotic spine, which we call as stuck sitting, because there is obliteration of the lumbar lordosis in the standing and sitting position, in both positions as well. So here, would you like any additional workup? What would be your plan for component positioning? and bearing surface.
Abhijit,
additional workup would be to do a PFT,
Yeah.
pulmonary function test for this patient, because these patients have a very restrictive lung disease also. So spine X-ray of the cervical spine, be ready with fiber optic nasal intubation. Try and do both the hips on the same day so that you do not have to give the anesthesia twice. And be very careful when you're reaming the acetabulum. The bone is very, very, very soft. You dip in without even noticing it and you ream out the internal iliopectineal line. So those are the things. Bearing surface, I don't think I would need a dual mobility. A ceramic on poly would be okay since he is not very stiff and he has a flat back on the spine.
component position, any change, Rohit?
I would reduce the anteversion. So
Yeah.
yeah.
So one quick question, Sahil. I mean, I think we have too many patients of angst-pond. The previous generations of hip surgeons in our country vouch that these patients don't have that range of motion and they don't really dislocate. So are we talking theoretically when we say that use a dual mobility, change the version, or do you think it's a real concern?
I think they don't really end up with that range, which is very flexible. So the risk of dislocation is slightly less in these patients.
Yeah.
But at the same time, dual mobility is not the answer for them. So that's why you can go ahead with standard ceramic on poly bearing.
Okay, great. So explain the rationale for stuck sitting.
Assuming this is the standing position of a normal patient, if the patient is stuck sitting, then there will be a posterior tilt of the pelvis. So in this patient, what will happen is, as the patient flexes, there will be no problem. But as the patient stands or extends the hip, there will be a risk of posterior impingement and anterior dislocation. So to reduce or prevent this problem in this patient, you have to reduce the anteversion, which will allow the patient to stand and extend the hip without any impingement.
Perfect.
So here there was risk of posterior impingement and anterior dislocation. So my plan was to reduce the anteversion. And as you can see better on the right side, you can see an end-on view of the acetabular component. So that's why I went for a relatively 5 to 10 degrees of anteversion. And my critique here would be that the left side femoral stem is in a bit of varus, but the bone was very sclerotic I tried to correct that with the help of the C-arm as well, but the bone was extremely sclerotic, so I accepted that position.
Just a technical sort of point where in such cases where the trabeculae pass across, it's very important to do what is called as a napkin ring osteotomy.
Correct.
And stick to the approach you are comfortable with, and also have a low threshold for using C-arm to know where you are. Otherwise, like Abhijit said, you can ream out most of the pelvis.
And you've done a nice mini posterior approach which looks very good on the
No, so I think the staples have been cut off, so I've done a standard, it's a standard approach. I'm not in favor of MIS or anything.
Excellent talk, Dr. Sahil Sanghvi. Next speaker, Dr. Kunal Bansal, is going to present post-op hip dislocation case.
Thank you, Chairpersons, for this opportunity. Thank you, Pune Orthopedic Society. So the topic given to me today is post-operative hip dislocation. So I'll just give a small brief before I get to the cases. It's one of the most annoying and disastrous complications in the post-operative period. The incidence is most common complication post-hip arthroplasty. It's dreaded by the surgeon and the patient and is a driving force for new innovations and larger head usage. And there are many recent advances for prevention and treatment. Incidence, it's about 1 to 3% globally. 70% occur within the first month. 75 to 90% are posterior dislocations. Dislocation rates after primary THA range from 0.09 to 2% depending on the primary approach. Dislocation rates after revision are high and are almost up to 30%. Most common causes of revision in the US. And redislocation rates after revision THA are to the extent of 30 to 35%. Risk factors include neurological disorders, advanced age, female gender, DDH, RA, prior hip surgeries, obesity, spine pathology, abductor insufficiencies, revision surgery, revision for instability, isolated component revisions, and reimplantations. So I'll get on to the cases. So this is the first case. It's a 37-year-old male. History of being operated on the right hip 2 days back for osteonecrosis. kept in bed for 2 days. The moment the patient attempts to sit and mobilize, the patient hears a pop, gets a severe pain and a shortened limb.
Yeah.
This is the X-ray.
Okay, let's start with Rohit. What do you think is a problem here, Rohit?
See, we cannot comment on only on one X-ray. So I would like to see more X-rays and also maybe a CT scan just to see the component position. So most probably on this X-ray, it looks like a little more anteversion, which may have led to it.
The cup looks very odd. Yeah. I mean, that's pretty clear. Anything else? I mean, we're not talking about spinopelvic dynamics in this presentation. So we will stick to other causes of dislocation.
So looking at this X-ray, ideally you should get a lateral X-ray also, and if possible a CT scan, but the cup looks more open and more anteverted. So the problem looks to be the cup, and most likely
the cup is probably even shifted.
Yeah. It's not even probably fixing well onto the
So essentially the cup is facing end on. It looks excessively open and excessively
anterior
anteverted.
dislocation. Yeah.
So as we already elaborated, role of CT scan, if CT is not available, then at least an additional radiograph. So we did have the option of CT scans. Now these are the CT scans.
Yeah. So the most important CT scan is the axial view. And what do you think, Kiran, on the axial view?
Certainly, the surgeon has not managed to get the version optimal in this case.
So options?
So I'll just run through the other sections as well.
Yeah.
Just to see the femoral component as well.
Is that excessively anteverted as well?
Yes.
Yeah. Yeah, I mean, to decide whether or not the femoral stem is anteverted, you need to have a superimposed image of the distal femoral condyle. So do we have that? Or
no, sir. Unfortunately, we don't have that.
So till then, I think it's probably just lying in external rotation.
Neck can guide you, but the neck is not the ultimate thing.
Yeah.
As Mahesh sir has said, you have to have the supracondylar area onto the neck to know the version of the
So
stem.
options, Abhijit, what will you do for this patient?
Since it's just a 2 days old, I would go in and change my acetabulum, and if possible, if it is still not stable on table, I'll try extension and external rotation. If it is dislocating, I'll convert my bearing to a dual mobility.
Yeah. So what are the problems of dual mobility in your practice actually? Forget about the concept of dual mobility. What are the problems that you face when you want a dual mobility cup or bearing for your patient? Rohit?
One is the cost.
Yeah, cost is higher. Second?
Secondly, we don't have a backup all the time. So,
Not uniformly available. Service may not be possible. Cost is high. And also the sizes.
So just one
for smaller patients,
question.
for smaller patients especially, if the cup size is less than 44, then you struggle getting a dual.
So
Less
just
than
a-
44, it's almost never available.
Yeah.
So we have seen Angst point, we are seeing dislocations. So is like dual mobility is a safe option in this cases. So with of course longevity is an issue. So I wanted to just opinion of the panel. Should we decide on it easily, or it should be like the threshold to use a dual mobility should be very high?
Should we use routinely a dual mobility case in say
In such
Angst point,
cases, in such cases,
bad
not in a
spines?
primary
That would be my last resort.
Yeah. What are your reservations about dual mobility in each and every patient?
No.
Is what he's asking.
No, sir. No, I'm not talking of these cases. The
Complex
difficult, complex primary cases.
I would definitely do a trial for all patients and then check the intraoperative range of movement. If I'm happy, then I'll not go for dual mobility. Dual mobility is only a backup in such cases. So if on table my stability is very good, I will never do a dual mobility for primary.
My reservations for dual mobility, first is cost and second is longevity of the implant. So if I can get away without a dual mobility and give a better life to the patient on terms of implant, I would always go for a regular implant rather than a DM.
Yeah, the concern for modular dual mobility in a younger patient is you're using a titanium shell and you're using a cobalt chromium liner inside it, and you are introducing another phase where you can get trunnion wear and metal ion release, and that is why you need to be very careful of using them in younger patients.
Thank you.
Yeah.
So the principles of management, as rightly pointed out by the panel, is to assess and correct the anteversion inclination of the component, assess the femoral component if found to be incorrect and not within the acceptable limits, to revise that component as well. Keep a dual mobility implant as just as a standby, avoid usage as much as possible. So intraoperative findings were cup was found excessively anteverted, inclined to the extent of almost 60 to 70 degrees and almost 30 to 40 degrees of anteversion. Femoral side was within acceptable limits and was well fixed, so nothing was done there. The cup was revised, placed in a revised anteversion of about 15 to 20 degrees and about 40 degrees of inclination with a multi-hole screw. We did that because once we extracted the acetabular component, we noticed that the previous surgeon had reamed a lot into the posterior quadrant, and there's a lot of thinning of the posterior wall and column. So we used a lipped liner. A new head was used to reduce the hip and found satisfactory in all ranges of motion, and a standard closure was done. Yeah. So this is the post-op X-ray.
You use the lip liner on the anterior or the posterior?
On the posterior side, sir.
Yeah, looks good. Yeah, any comments from the panelists? No. Do you have another case, Kunal?
Yes, sir. I have 2 more cases. So I'll just skip through this. We'll go to the next case. 72-year-old male presents with recurrent dislocation since 2.5 months. 3 attempts of close reduction done in the past elsewhere, all successfully reduced closed. Last dislocation happened in bed while attempting to get up, presented to us with 4th episode of dislocation. Clinically, limb was shortened, external rotated, no neurodeficit, gross telescopy was positive. On jetted attempts, the hip re-reduced but dislocated again, spontaneously on extension. Found grossly unstable. This is the X-ray.
This was a hemiarthroplasty, you said. Yeah. Kiran, what do you think? What approach was used, do you know?
Posterior approach was used.
Posterior approach.
I mean, as we all know, the standard of care for hemiarthroplasty in elderly is anterolateral approach and cemented hip, but the surgeon for some reason has done this. So obviously, I don't know, you cannot comment on the version of the stem on this particular X-ray. I don't know, we don't have previous X-rays to understand and compare. So obviously, you have, if you go in, I mean, 4th dislocation, so when you counsel the patient, I would counsel about a full sort of a revision, you know, and then go ahead with it.
Yeah. It was none, sir, none. So it was basically we just tugged on it, it came in, but the moment the hip was extended, it was going back.
So it was
dislocated on extension, so it's anterior dislocation most probably.
It was, to be honest with you, it was just
global.
Flipping. So it was going on to the anterior side, then it was flipping again, reduced it, again it was dislocating anteriorly.
Anterior, so
yeah.
Anterior dislocation.
Yeah. So I am going to ask you the choice of approach. What approach do you use for your hemiarthroplasties, Abhijit?
Anterolateral.
Anterolateral. Kiran? Anterolateral. Anterior or anterolateral?
Anterior, anterolateral.
Yeah. So is there any concern for direct anterior in fracture neck femurs?
So initially, yeah. So direct anterior approach is not an ideal approach to start doing bipolars because of the large head. It becomes difficult to reduce under the rectus.
Yeah.
So you may struggle for your first few cases. So I would not advise to start. But once you have crossed that learning curve, then you can easily do it.
Yeah, I agree. I mean, if you're using an uncemented press-fit metaphyseal stem, and if you use a posterior approach for your hemiarthroplasties, the risk of dislocation is high. Because the stem will find its own version. You cannot really antevert it more, and then it can dislocate. So I think hard-hinge or a direct anterior approach is a good option. And if you want to use a posterior approach, use a cemented stem or a conical stem where you can change your version.
Point taken, sir. So we did take this patient up on fluoroscopic examination. So on fluoroscopy, it was grossly unstable. So plan was to assess if stem was an acceptable version, which apparently it's not. Standard cup revision and dual mobility and long stem were kept standby. Same approach was taken as in the primary. Hip was found grossly unstable on table. Femoral implant was relatively loose. There was a fracture of the trochanter as well. Abductors were lax and partially ruptured. Implant was removed. Cemented dual mobility shell was implanted on the acetabular side with a short Wagner on the femoral side. Fiber wire repair of the trochanters and the best possible configuration for the abductors was done, followed by a standard closure. So this is the post-op X-ray. Yeah. Any comments?
Why a cemented dual mobility was used?
So the patient was 75-year-old. The acetabulum was pretty lighting and pretty soft. So we did try to get a regular cup in, but there was absolutely no hold. And we did opt for a dual mobility precisely because the abductors were partially ruptured, trochanter was broken, and plus patient was 75-year-old.
How did you manage the trochanter?
Fiber wire. So we repaired with the fiber wire.
Long-term survival of a cemented dual mobility particularly is not very good. So 70 is not very old, truly speaking.
So
you should
as
try
per
all your possible ways to
Some of us will be there soon, Kiran. So anyway,
uncemented dual mobility is always
looks
a better
very
choice.
good. Yeah.
So I'll go to the last case.
Yeah. Go through quickly because.
Yes, sir. So 55-year-old rheumatoid, operated around 12 years back for a primary RA hip. Primary cemented THR done. 10 years later, stem loosens. Stem revised to a solution stem. On table, cup deemed well fixed left. 2 years later, the cup also loosens. Same surgeon revises with a cup with a multi-hole uncemented cup, which again loosens in 6 months. Tired patient goes to a third surgeon who revises it with a cup cage construct and bone grafting. 7 days later, patient dislocates again while getting up from a sleeping position. Close reduction attempted, dislocates again. This is the X-ray.
So what could be the reason for dislocation here? Any?
The acetabulum component, it's too
Look at the ring inside the cage.
Ring is also
the
too vertical.
liner.
Acetabulum is at 90.
Yes.
Yeah.
So
and also there could be a femoral ischial impingement as well in this. But that's really minute. I think the cup position looks grossly wrong.
So probably the surgeon aligned the cup in relation to the cage and put it in a vertical.
So what did you do then?
So plan for partial, complete or explant because patient was financially completely bogged down. She was also willing for a girdle stone as counseled by the previous surgeon. So technical considerations, we ruled out infection as always. We had already counseled for a girdle stone. Plan was kept to keep bone graft, a cemented cup and a cemented dual mobility liner standby.
Yeah.
So what was done? Adductor tenotomy, release of anterior capsule to permit subluxation of the femoral component. Abductors were atrophied, but they were largely intact, well fixed. The stem was well fixed and was in about 10 to 15 degrees of anteversion. Fortunately, the cage was well fixed. Cup was completely open at about 60 to 65 degree inclination and neutral version. We revised the cemented cup with a cemented dual mobility liner in permissible anteversion and inclination as much as possible within the cage. Yeah. Revised the head to a bipolar head, and this is the
Show us the X-ray.
We could get. So this is the X-ray.
Yeah. So this is a dual mobility cemented.
Yes, sir.
Yeah. Looks good. Thank you. I think we were overrunning the time, so I'm going to request Dr. Bhaskaran to come and join and show his.
So this is just the last slide. This is the algorithm. All of us should be aware of this algorithm.
Take a picture, guys. This is a difficult algorithm for him to explain now in the short period. So take a photo. Sinu, please come up. Sorry, Kunal.
No,
but excellent cases.
That was the correct indication of using a cemented dual mobility.
Yeah. How did you, by the way, till Sinu is setting up, how did you remove the previous poly shell?
So we put a screw in just towards the inner part of the cup and just press the screw and the liner just pops up.
It was a cemented one?
It was a cemented.
Cemented one?
No, sorry. It was an uncemented one. Sir.
Yeah. Okay.
Sorry. That was another.
Other technique is to actually take a reamer and just ream through the poly. Quick questions, a couple of cases.
Yeah. So coming finally, since we have a mixed audience of trauma.
Because if you overrun, I am going to have to cut down my talk. So.
Oh. I'll just go through the X-rays. So we are going to be talking about fractures around total hip. So this is the first case. First of all, a disclaimer. I mean, these are X-rays of the Kulkarni sir. So he would be in a better position to talk about it. But I'll just go through the initial part of this. So this was 71-year-old male. Slip and fall at home. So if his history, he's got this initial THR done in the 1980s. So this is a classic low friction John Chanley.
Yeah, this comes from Bombay Hospital.
From Bombay Hospital at that time. And he's, since then, 2 decades later, he's got his acetabulum revised. He's got a lot of problems, arthrodesis on the ankle. He's got a history of hemiparesis on the same side. And then this fall. And he's presented to the ER with this kind of a picture. So this talk should be mainly about when you retain an implant and when you're going to, have to change the implant. So that's the importance of the Vancouver B2.
So to be or not to be?
Yes, absolutely.
It's a B-type Vancouver fracture.
So Kulkarni sir, please.
Yeah. Abhijit, what do you think?
So I would like to take a traction view of this patient, and as Kulkarni sir said, it is a type 2 fracture, type 2B, and below the tip of the implant. If my stem is still holding on too well, I would fix it with a GTR plate. And if it is loose inside, I will just change the stem. Since the cup is revised in 2004, not very long back, the cup doesn't seem to be loose. The only thing is I need to understand what is the head size that the cup takes, and if that head is still available with me.
Yeah, what do you think, Kiran?
Yeah, so obviously whenever you go for revision and fixation, you have to keep everything on the table here. And from this Chanley thing, it's like a small 22 head. So, but the cup was revised to what we need to find the details of that as well. But yes, certainly, if the stem is well fixed, then on table, stabilization. We don't have allografts like strut cortical allografts, which are useful in such situations. Otherwise, go for a bypass the defect and go for a long stem.
Rohit? Fix. So this is the usual debate is whether it's a B1 or a B2 fracture. A B1 fracture is, B is a fracture around the stem and the stem is intact. So this looks like a B1. B2 is when the stem is loose, and B3 when the stem is loose and the bone quality is poor. So this looks like a B1 because the stem looks very well fixed, the Chanley monoblock. So what did we do? Yeah.
So this is the immediate post-op. So
this is an immediate post-op, and this is a plate that we have used when we did not have the hook plates. So we use the distal femoral plate from the opposite side and reverse it, and the bow will be fine for this patient. And we have used the system of periarticular locking plates with unicortical screws and cables through the plates. So this one probably was a Zimmer plate, I can't remember. And we do have a follow-up X-ray after 4 or 5 years as well for this patient.
It's completely united.
Yeah, so they do well. These are the B1 type of fracture.
And this very important point for the audience is look at the length of the plate. The plate has to be really, really very long for the lever arm to be nullified. So just 2-3 screws below the fracture is not going to be sufficient. You should have at least 6 to 8 holes below that, and then don't fill in all the holes. You can keep some holes empty so that there is some micro motion at the fracture.
Yeah, so the construct shouldn't be too stiff. You need to space out the screws. So the second case now, again now here we have, this is a B3 now. So that means the implant is unstable, the fracture is unstable, and you can see the patient, the fracture line extending all the way down to the diaphysis. So
yeah, options, Kiran, stem options.
So certainly we have to look at the extent of the fracture line here and try to bypass it by at least 4 finger breadths. There is an implant down also. So it's very important to choose the correct implant here. And with modern stems, we have the conical tapered versions, which I would use here on the table.
The same.
Yes,
same
similar. I would just add, maybe I'll keep a plate ready on table in case if required, and we bypass the fracture, go for a longer stem, and maybe use control cables to fix it around.
So that's the immediate post-op.
Any concerns with the length of the stem? The fractures seem to have gone quite distally.
I would like to have the stem go a bit longer.
Yeah.
At least
what are the problems of a longer stem? I mean, I have a successful outcome, so I can brag about it. But what are the problems if you go? This is probably a 265.
This is a straight stem, so there are problems of hitting the anterior cortex. So if you can get a bowed stem, it would be better. But even with a straight stem, if you enter wisely into the proximal segment, you can negotiate that bow.
Yeah. So a longer stem would probably end up perforating or causing a distal fracture, because it's a straight stem. You have one more, or that's it?
No, just one point about bipolar stems. So in a traumatic scenario, is the new collared stem more advantageous as compared
Opinion
to
about a collared
versus
stem
non-collared stem?
in elderly neck of femur patients versus...
In elderly, yes, a collared stem would probably have a better choice. In a younger patient, uncollared stem would be better.
Yeah.
And
so the collar has been, anything you want to add, Rohit?
The advantage of using collared stem is it gives you stability in terms of vertical, so it avoids subsidence. Also, it gives a torsional stability, because once the collar sits on the cut surface of the neck, it will also prevent micro motions in the torsional force. So it gives you immediate stability intra-op. So,
Yeah.
so for patients who are osteoporotic, especially elderlies, and even I would not mind using in young patients
Yeah.
also, because it gives me that immediate stability on table.
So increasingly with elderly neck femur, I think a collared stem has become a, because you are not in a danger of actually going for the biggest size. The only disadvantage is you might undersize it if you don't check the stability of the brooch on
So
table.
just one question on that. Collar and a press fit, aren't these two concepts crossing each other? Because if you're relying on press fit, you don't need a collar. If
still-
you're using a collared stem with an undersized stem, you are actually contradicting the
Yeah, I
principle.
agree. I mean, collar is like a parachute. You are jumping off your aeroplane, you have a parachute, you can inflate it. And in an elderly patient, you don't want to really go bigger and bigger with your uncemented, otherwise just go for a cemented
Yeah,
stem.
exactly.
If you're using an uncemented stem, make sure that the brooch is stable, so you have a press fit, but the collar gives you that additional parachute where it doesn't sink.
So rightly said, the principle does not change. It's always a press fit. Even when you're putting a collared stem, you have to have a press fit with the brooch, and then you select that size. If you're not happy with the torsional press fit, you give a torque, and still, if you can go up one size up. Once you get a good press fit, then you use the same size collared stem.
I think it's time to just remind the audience that the standard of care is a cemented stem
So-
in a elderly fracture neck of femur.
Worldwide data unequivocally says that a cemented stem in an elderly patient is the most modular, less periprosthetic fractures and better long-term results. Slightly increased risk of mortality and complications using a cemented stem, but I think it still remains a gold standard using the Cochrane database review and all other publications.
Okay, sir. I think excellent points. Thank you, sir.
Is that it? Yeah.
That's all, sir.
Perfect. Thank you very much, Sinu. Sham, you have got one, you are going to present a young patient, 30-year-old. And you have to remember everybody, Sham is an expert in hip arthroscopy. So don't tell hip replacement as an option.
Thank you, my sir, for your kind words. Up till now, previous session and this session also, we have seen replacement. And now I'm going to focus on the preservation part. Daily, we come across many cases of hip pain, low back pain, unilateral low back pain, thigh pain, and knee pain. In those cases, many a times, there is a pathology of hip, which we overlook or don't see the hip. I see many cases where there is a hip is a cause for low back pain, even for the knee pain. So, it becomes very difficult when in MRI there are some disc bulges which are not causing pain, but hip is a cause, but we get in confusion whether hip is a causative factor or the spine. In such cases, hip injection proves to be a diagnostic tool. Let's see one case. This is a not 30, but a 27-year male patient with a bilateral hip and thigh pain since 5 years. Pain is activity related, especially activities involving flexion of hip, like squatting, sitting, rising up from the sitting position. Initially, pain was intermittent, but now pain was continuous and gradually progressing. There was no radiation of pain below the knee, no tingling numbness. On examination, both hip flexion was restricted up to 70 to 80 degrees. Internal rotation of hip in 90-degree hip and knee flexion, I will term it as a FIR. FIR on right side was -10 and on left side it was 20 with groin pain. FER means external rotation in flexion. It was full without pain. And see this clinical examination. This is FER, means external rotation. Internal rotation is not possible. It was -10.
So what goes through your mind, Abhijit, when you see such a young patient with restriction of
From an arthroplasty surgeon's point of view, it looks like a sectoral collapse.
He is directly gone to avian. So anything else that you can think of? There is no history of COVID, steroids, nothing. Young, male, fit.
It can be an FAI leading to an impingement and the neck hitting the acetabulum, preventing ankle rotation inflection.
Yeah, so
what
probably.
What other differentials come into your mind, sir?
Paralabral cyst could be an option.
What?
Paralabral cyst.
Paralabral cyst.
Leading to
Paralabral cyst is a result of impingement.
What else can you think of pathology-wise? We should give an answer like we do in MS orthopedics: infection, congenital, traumatic, and what is something else?
Most common condition which restricts internal rotation is restricted in avian. So avian comes in our mind.
You were right then, Abhijit. Yeah.
Yes. What is the most valuable investigative tool in this case?
X-ray AP and frog leg lateral or cross table lateral.
Okay. Dr. Raghavendra.
The most investigative. The most useful is probably MRI.
MRI scan.
Yeah.
These are the X-rays. Can you read X-ray, Dr. Raghavendra? He is also hip arthroscopy surgeon.
Yeah. Okay, so this is properly positioned APU, probably slightly outlet because we don't see a proper 2 centimeter distance from the pubic symphysis to the sacrum tip. So if you see the AP view, there is it's a short neck. There is a slight cam deformity.
Yeah.
Ideally, which I could have properly commented on the 45-degree Dunn's view, but this is fine. So there is a slight cam deformity, and on the femoral head, on both sides, and acetabulum looks okay for me. There is a slight sclerosis on the right side, especially superolateral margin.
Yeah.
Probably that is suggestive, and decreased joint space, probably, and more on the medial joint space than the lateral. So probably this is Tony's 1 or 2.
So Raghavendra, you can sit here as well because you're going to speak next.
Okay.
Yeah. So I mean, what is the next investigation? So probably a cam type of impingement.
Yes, you can see definitive cam here on left side also there. Here is a impingement cyst there. This is an impingement cyst. And there is a sclerosis. That clearly indicates that there is an impingement going on, and predominantly this is a cam type of impingement. Usually we get mixed type of impingement.
Yeah.
Yes, in MRI. Panelist?
Who wants to read the MRI scan? Raghavendra or? Yeah, I think he will be the right person.
I think, sir, one question for you. How often we see a cartilage problems of the femoral head, which can be read on MRIs?
Honestly,
not very often.
Not very often.
So, I think MRI looks fine. Maybe a slight cyst on the right side, the impingement cyst.
Do you also have sagittal views of the MRI?
Yes, we have.
Yeah.
Look at, can you see this cyst in acetabular wall there?
Yeah.
Here.
There's a cyst
and
there also.
Here.
Yeah.
Now, this is the useful view.
Yeah, here it is pretty clear now.
Yeah.
For a person who doesn't read MRI scans, you can see a cyst on the right hand side on the anterior aspect, probably secondary to that cam.
You can see the cyst here.
The femoral head impingement, I mean, rather than a cyst, I would say the signs of some porosis on the anterior femoral head. Is that right?
Yes, sir.
Yes, there are. This is a.
Yeah.
What should we do? What should we do in this case?
And I usually send them to a person who does hip arthroscopy to see if it can be benefited. I wouldn't be touching it.
Yes. Dr. Raghavan.
The joint looks quite visible. Tonus 2 is a cutoff for hip arthroscopy. Anything less than tonus 2, 1 or 0, we can preserve. Tonus 2 is, of course, we have to replace the joint.
So what was this?
So it is somewhere between 1 and 2 because
We have no clue, so you can tell whatever you like.
Yes, sir. Because subchondral
We have absolutely no clue.
subchondral cyst in the acetabulum is tone is 2,
Yeah. So this one is a borderline.
borderline. But I think since the joint,
But if he's really symptomatic, you would consider
yeah,
these are the
consider
options.
age, yeah.
Okay. I did right hip arthroscopic acetabular rim trimming, then labral repair and cam osteoplasty.
Nice.
This is the video. See this labrum. It is a torn labrum. You can see the status of the acetabular cartilage. You can see this acetabular cartilage is eroded. Then shreddy acetabular, shreddy labrum. It can be lifted up from the. Can you see this?
Yeah.
Yes.
That's the labrum.
Yes.
So do you have your own separate hip arthroscopy set?
Yes, sir.
And do you use a fracture table for hip arthroscopies?
Yes.
Yeah.
We need, actually it is a basic requirement, fracture table.
Yeah.
You can see the, I am ablating the soft tissues above the labrum.
Yeah.
There is a abundant soft tissues between the labrum and the joint capsule. We have to ablate it and then we have to ream it. How to forward?
And then you use anchors there?
Yes, sir. For labral repair, we use anchors.
Yeah.
This is rim trimming with the burr.
You freshen the edges with a burr?
Yes.
Yeah.
But this is a excision of the acetabular wall, and then it becomes refreshing automatically. Then we lift labrum from that position, the original position, and anchor up.
Yeah. So like tuck it up a little bit higher, away from the impingement.
How to forward?
Yeah, you can go on the screen.
Okay.
Yeah, you can press ahead of that white bar. Yeah, click. Yeah. Yeah.
Now the cam osteoplasty.
Yeah.
See this significant cam damage pattern.
Yeah.
This is a cam bump, and this is the impingement groove.
Yes.
You can see there is no smooth transition. This is a cam, and these are the impingement cysts. Impingement groove.
So then you burr it.
Then trim it with the burr.
Very nice.
And make smooth. It becomes a impingement-free movement. And you can see the post-operative range. It was -10, now almost around 15 degree internal rotation. This much the gain we achieved.
Yeah. Excellent.
These are the post-operative X-rays. You can see in Dune's view, there is no impingement cyst there. Still, you can see some contouring convexity, but it is not going to have impingement.
Yeah.
Then rehabilitation, 3 weeks, partial weight bearing, half squats and stationary bicycling allowed immediately. Then abductor strengthening exercises after 3 weeks up to 6 weeks, can resume work after 4 weeks. Then a very minimal post-operative pain actually. In conclusive, FAI is a clinical diagnosis. Radiological investigations are here to support the clinical diagnosis. Role of MRI is to exclude some of the hip pathologies like AVN. Many hips can be saved if intervened at the right time. Hip arthroscopy is very useful, minimally invasive tool to treat many hip pathologies. Thank you.
Yeah, thank you. I think hip arthroscopy is something which is need of the time. I wouldn't ask Dr. Wakankar to comment about hip arthroscopies though. He doesn't like it. I tried learning it.
Some 25 years back, it used to be said, well, in the UK, it used to be said that it is an operation in search of indications. But I think situation is different
I think they
today.
have found some indications now. And he also called it a staged hip replacement. That's very bad, but I would not say it here. So can you change the slides, Dr. Mahesh Kulkarni, future of hip arthroplasty? Because of lack of time, we have covered most of the topics, so I'm just going to go through the slides very fast. So once it is projected, yeah. So future of hip arthroplasty. Now hip arthroplasty has been labeled the operation of the century because it really worked wonders since John Chanley introduced it with excellent results, less pain in the post-operative period. So few things which are new, dual mobility, we talked about trunnion wear, cobalt chrome and titanium interaction. There is a new oxinium dual mobility which will prevent that because we know that oxinium with titanium matches very well. The iron release will be less and that will lead to less of a problem. And the second thing that this liner seems to have achieved is the original modular dual mobility cup actually did have 14% incidence of mal-seating. So the liner did not sit in, the metal liner did not sit in the bone properly and it seated what is called as a canted liner and that actually increases the wear between the cobalt chrome and titanium. So I think those two problems have to be claimed to be mitigated by using an oxinium on a titanium cup. So that is one new thing that I have found. Hip resurfacing is making a comeback. Can you believe it? When I saw it, we have gone through 15 years of disasters of hip, large head hip resurfacing. The whole operation was not bad. The Birmingham hip resurfacing did very well. But the newer bearings now have been introduced. One is ceramic on ceramic and second is metal on highly cross-linked polythene. So H1 ceramic resurfacing by a company called as Embody Limited now has completed 2 years trial and has been now started being used in the United Kingdom. Again, the same people. Derek McMinn is using the metal on poly and ceramic is by some other surgeon, I can't really remember. And the Resurf is another company's product. So 2 ceramic on ceramic hip resurfacings are going to be coming back in our practices. Problems of ceramic remain squeaking, brittleness and stress shielding that we're not going to go into details now. Second advance is ceramic on, metal on highly cross-linked polythene resurfacing. Again, Derek McMinn, he's done 88 cases, very less iron release, less stress shielding, but the polythene wear question is, so it's a monoblock polythene cup and that is used with a resurfaced femoral head. And that is something which will probably give you normal lifespan. What are the other modifications? Implant modifications are now being considered. Nanotopography will give you surfaces or dragonfly wings on the coating itself which will prevent bacterial adhesions and that will come in both hip and knees which will prevent, reduce the risk of infection. Some of the silver antimicrobials also have been tried on the implants, effective against E. coli and Staph aureus, reducing infection. So implant nanotopography with inclusion of antimicrobials is an area that we need to think about. Additive manufacturing, I think we are all seeing it. All companies are coming up there with their own version of porous tantalum-like materials. You cannot call them tantalum because that's a monopoly of one company. They are increasing their manufacturing abilities with 3D printed cages, cups, cones,
So all of these things will, and they are cheaper in India. So I think that is something that will come in big time. Surgical approach, Rohit is a big proponent of direct anterior approach. That has really lit up the world in North America. That was because majority of the surgeons were using a direct lateral approach, and they have been converting. Not many of the posterior approach surgeons have converted. Europe, United Kingdom has not been converted. Australia and America are the two countries where it is really been latched on as well. In technology, I think we are going to have a revolution. You have virtual reality and robotics. What does the virtual reality do? Let's see. I mean, this is a video of the technique. The education for us is going to be easier. Very quickly, we'll go through this slide. I'm not going to waste too much of time. Johnson & Johnson, the glasses that you can wear will tell you how to do a knee replacement by just gestures and movements, and you can see it. So quickly, I can't forward. Yeah. So this is how you see. You can pick up the implants, instruments. You can see your hands. I think there was a demonstration. This is an attuned set. So virtual reality might be something that will come in. Robotics is not future. It's already here. You have enhanced planning, haptic feedback. You can position your cups. All that Sahil was mentioning, reduced version, increased version, change the alignment that Sinu was talking by 2 or 3 degrees will probably be possible or more accurate with robotic training. Hip dislocation concepts have changed. So there is an article called as Death of Levenick Safe Zone. So that is really now gone. You are going to personalize your cup position more accurately. So that is the Lawrence Dorr article, Death of Levenick Safe Zone. We've talked about the stuck sitting and stuck standing. I'm not going to dwell upon it too much, but this is the classification that you need to remember. This is the Vigdorchik classification. Only 2 things to be remembered. One is stuck standing and stuck sitting. So stuck standing, you need to increase the anteversion, which is usually a lordotic spine that you see. And stuck sitting is an ankylosing spondylitis, stiff spine, like a bamboo spine, which is fixed in where the kyphosis is actually straightened out. If you are kyphotic, which Sahil showed was unusual. So stuck sitting, remember angspond with a flat spine, you reduce the version. That's all that you need to remember. Problems with technology is expensive. If you want all applications, it's going to cost a lot. Patient is going to be paying that money as well. Increased use of CT scan, the dangers of CT scan for that patient, training of the surgical team, consumables of drapes, saw blades, all of that will add into the patient cost. Pre-operative CT scan is a limitation for the modern robot, but I think that remains the only precise robot that we have. So in future, what else can we think of? I mean, we talked about so many things. In knee replacements, VeraSense is a guide which will give you the joint laxity pattern, which will actually calculate the pressure on the medial and lateral compartment in both flexion and extension. What about autonomous robots? That the surgeon just stands and the robot does all its job? It's a problem. You have to remember, not far long ago, the automation in airline industry caused a massive problem where the pilots were not ready, they were not trained to overcome the problem of automation in the Boeing 737. And we had 2 massive crashes because there was no understanding of how to override. So if you learn the technology and don't learn the hip or knee replacement in a proper way, then you will not be able to control that genie that has been left out. So I think definitely improved accuracy, reduced soft tissue injury, better discharges, pre-planned implant position and alignment can be tweaked, but an accuracy and precision can be improved. One has to remember though, this is Ernest Hemingway saying that he used it for financial crackdown. People think that it's going to come, but it's going to come very gradually and mera 20 saal nikal jayega. But the technology doesn't take that long. It is gradual, but then it's sudden. And then you don't want to be left out. You need to embrace technology, because if you don't look that technology is going to be part of our everyday life, you won't see it. So embrace technology and use it rightly. Thank you.
This was a keynote lecture. Do you want to ask any questions, sir? Dr. Raghavendra. Dr. Raghavendra is a hip arthroscopy surgeon from Bengaluru.
Sorry, from Mysore. Thank you, Pune Orthopedic Society and Dr. Shyam Sinde for a kind invite. Very happy to be here. It's an honor and privilege. And happy to see Dr. Pramod as well, my colleague from JIPMER. Yeah, hi. So my name is Dr. Raghavendra Kimbavi. I work in Mysore. And I'll be talking about a few difficult cases I came across on hip arthroscopy. So one of the major problem in hip arthroscopy is the question of I'm not able to get into joint, and that's because of the tighter joint or some other reasons. So difficult access is a major concern. So most common performed technique in hip arthroscopy is central compartment first, where we enter the central compartment directly with a needle. But what happens with the cases like this, where there's a coxa profunda or the global overcoverage of the femoral head? So then comes the second technique, which is very handy, that's peripheral compartment first technique, where we enter the joint perpendicular to the neck axis. And more fortunately, most of the problems in FI are the peripheral compartment, and this is the article which states, so we don't have to necessarily enter the central compartment in all the patients. Addressing the peripheral compartment is more than sufficient. So then comes the third technique, which is called outside encapsulotomy techniques, where we cannot use the previous two techniques, especially when we have to address the rim in tighter hips like coxa profunda. So here is a technique very very easier or simpler compared to the other two techniques, where we enter the joint from outside to inside. That's from outer surface of the capsule to the inside, inner surface of the capsule. So essentially, it is very simple technique, as I mentioned. It doesn't need any specialized instruments. So here is a case which I had a problem with, difficult entry or the access. So this is a patient profile, 55-year-old, bilateral hip pain, history of a COVID. He had a night pain, so present with the problems of difficulty in walking and sitting cross-legged. So this is the patient pictures, basically antalgic gait, joint line tenderness. So global restriction, terminal restriction of the movement on the right side. I'm not commenting on the left side because left side was a stage 4 AVN, so straight away I did a THR very next day, but I'm mentioning only on the right side here. So flexion, adduction, internotation was positive, that's impingement. And more importantly, you see the picture on the right lower side, he had a flexion internotation of 0 degree. So these are the patient x-rays. Lateral central angle of 70 degree, radiological parameters, anterior central angle of 65 degrees, and tonus was reversal, not even 0, it was reversed. So, and floor was, acetabular floor was medial to ilioischial line, and posterior wall sign was positive. CT wise, as we can see clearly, it was a clearly global overcoverage of the femoral head. So my diagnosis was severe pincer, more on the posterior lateral side, and due to global overcoverage, coxa profunda with a labral calcification. That's an important aspect here. And he had also AVN of stage 4 on the left side and stage 2 on the right side. So stage 2 on the right side, I tried to preserve, and he also had a chronic synovitis with adhesive capsulitis because of the uncontrolled diabetic status. So my plan was to do arthroscopy here, to do a rim trimming, that's acetabuloplasty, and I had planned for labral reconstruction as well with a semitendinous graft. So my plan of resection of rim was from 11 o'clock to 3 o'clock on the right hip, and I also plan to do arthroscopic assisted core decompression. So few words about labral reconstruction. There are only 3 indications. One is irreparable labrum, revision cases, and labral calcification. And here my indication was labral calcification. So hip arthroscopy, central compartment first, peripheral compartment PC first. In this case was completely ruled out, so I had to do a outside encapsulotomy technique. So intraoperative radiography is very essential. So these are the just 2 portals. One is anterolateral portal. The second portal is mid-anterior portal as a working portal. And in case I had to enter the peripheral compartment, I just marked peripheral PEL, that's proximal anterolateral portal as well. So to begin with, the outside in capsulotomy. So as I mentioned, we have to enter the joint from outside in. So with the radiological assistant, as you can see, my instruments are right there at the superior lateral acetabulum rim, enter the joint. So next thing is once I enter the joint, what I was happy to see was MCFA arteries pulsations here. So this was a case of AVN. To see a pulsation like that, it's a very good sign. Next thing to do is rim trimming. Burr is a very important tool here. So as I mentioned, I did a rim trimming from 11 o'clock to 3 o'clock. So that was almost at the end of my rim trimming. So next step was to excise the calcified labrum. So banana knife here to separate the labrum, calcified labrum from the rim, and I used a shaver to resect the labrum. So next thing is to measure the defect. So this is a 5 mm probe. So 6 times, that's 5 into 6. 3 mm was a defect I got here from 11 o'clock to 3 o'clock. And next step is to pass the anchor. So one at 11 o'clock, the second one is at 3 o'clock. I use 2.3 peak single-loaded anchors. This is at 11 o'clock, the second anchor. First anchor at 3 o'clock. And next important step is to prepare the graft. So 3 centimeter graft I took for semitendinosis. So once I pass the anchors, so I make it two ends, one the longer end and the shorter end of the anchors. The longer end I used to tie the graft. So this is the tying of graft with the longer end of the thread in figure of 8 position. So once it is tied, it is ready to pass like this in the center picture. So graft passing, very important step. Do not be harsh here, be gentle. So I pull the thread on the lateral anchor, that's at 11 o'clock. So now that's passed on the lateral side of the rim, and this is the medial side at 3 o'clock. So 8 mm cannula is very essential here. So once I pass, just going to rush to pass the knots, 4 or 5 half inches is more than enough. And once it's tied on the other side, I used knotless anchor in the center to fix the graft. So this is a graft stabilization, so to check the stability. So one of the wrong thing I did here was to do a hip arthroscopy under spinal anesthesia, because we do not have any control on the BP here, so ideally to be done in general anesthesia. So once I've done, so this is a arthroscopic assisted core decompression using 2 mm drill bits. So the picture on the right side was before the pump, reducing the pump pressure, and picture on the lower side is after I reduce the pump pressure. So we can see the bleeding sides. So radiological parameters after the X-ray, after the surgery, 70 degree was my lateral central angle pre-op, and post-operatively I got very much normal 45 degree. And on the right side, I did THR next day. So this is what is the most important aspect in this surgery was to have rotations. FIR was 0 preoperatively, and what I got after surgery was almost 45 degree. So how much resection we are supposed to do? 1 mm trimming ideally increases internal rotation by 2 degree, and 1 mm rim trimming reduces central edge angle by 1 degree. So probably I have done around 20 to 25, that's lot, 20 to 25 mm of resection of rim trimming. So I got 45 to 50 degree of internal rotation. So this is one more case, shortly proceed. Challenges again, difficult access, rotation, but more important thing here was to get the rotations right or the proper excision of the cam. So this is a patient profile, 23-year-old, history of RTA 3 years back. And presently, he complains of restricted ROM, pricking pain in the groin, and weight, but he was weight bearing. So most important here was the flexion external deformity of 20 degrees. So you can see on the picture on the right side, video on the right side, I'll show you later. These are the patient x-rays. So 3 years back, he had a fracture dislocation of the hip. Somebody had done safe surgical dislocation and fixed with Hubbard screws and a couple of KYs for the neck. 8 months post-op. So this is the present picture. So it's fortunately united, malunited, but with a huge bump on the superlateral part of the neck. So this is the video. This is why he came with flexion external rotation of 30 degree. So my diagnosis was malunited neck with a cam-like deformity at head-neck junction with a secondary adhesive capsulitis and probably avian. So plan was to do a hip arthroscopy to get a proper rotations. Few words about the cam. Either we can have an under resection which can leads to residual impingement, or we can over resect the cam deformity. In such cases, there will be a problems with the loss of suction seal, catching of the labrum, and in worst cases, it can lead to iatrogenic fracture. So what are the endpoints, intraoperative parameters? So I can see in the Dunn's view, lateral view, we have to have proper concavity. So this is intraoperative dynamic assessment. We have to have good clearance between the rim and the neck. So medial template, we have to follow the medial template radiographically, intraop, and release the
Dr.
traction.
Quick.
Yeah. So here I did peripheral compartment first. So I'll just run through. So first thing was to do a capsular thinning, bony resection, looking at the intraoperative radiographs. Like this, and probably I got a good cam resection, and this is preoperative videos, flexion rotation deformity of 45 degree, 20 degree, 30 degree, and after surgery I got almost 45 degree.
Excellent.
Thank you.
Thank you. Excellent, Dr. Raghavendra. We are overrunning the time, so I call all the faculties on the tape dais. Yeah.
I would like to request the conveners Dr. Mahesh Kulkarni and Dr. Shyam Shinde to present the awards to the panelists and the speakers. Dr. Neeraj Akkar.
No, they will felicitate Dr. Kunal Bansal, Dr. Shyam Shinde, Dr. Raghavendra and Dr. Luthra. Yes. Now I call upon Dr. Govardhan Ingre sir to felicitate Dr. Shyam Shinde.
all the POS members for this very novel oration of POS by a past president. And with this, I will give a brief of Dr. Srinivas Shintre sir, who is going to be there today, who is going to give us a oration. So Dr. Shintre sir is a professor and head of Department of Orthopedics in BJ Medical College, Pune and Sassoon General Hospitals. So he's a professional experiences that he in 1990 to 2000 he was lecturer in BJMC. Then 2005 to 2005 he was an associate professor, and after 2005 he became an HOD and professor of Department of Orthopedics, BJ Medical College, Pune. He has also been awarded a Ranawat Fellowship, ROC Fellowship way back, and he has many certifications include BTLS, ATLS, BLS, ACLs on American College of Surgeons, that is ACS. He was a faculty recognition has been given by the Royal College of Surgeons, UK for basic surgical skills. He has conducted many workshops accordingly. And he was a mentor and guide for 24 MS orthopedic students, as well as he was a convener at many conferences and CMEs. He was an internal external examiner for MBBS as well as MS orthopedics, as well as he has conducted examination of few fellowships in spine, fellowships in arthroplasty, as well as for the sports medicine. He was also an examiner from the university that is MUHS, so the Maharashtra University of Health Sciences, Nasik, as well as Pune University, Mumbai University and DY Patil Medical College. He had been taken an exam at Mauritius also as an examiner. He has taken a charge. He was working as a dean in BJ Medical College in 2023 to 24. Sorry. So he was a past secretary of Pune Orthopedic Society. His tenure was from 2014 to 2016 under the presidentialship of Dr. J.M. Talesara. And he was the president of POS in 2018 to 20. And during his tenure, there were many good academic activities as well as very successful annual conferences has been conducted, that is POSAC. As well as he had, first time they have introduced the short surgical technique videos for 2 minutes, and many delegates has voluntarily participated and delivered their work experiences in those videos, and that was presented in POSAC. So he was also an associate editor and author of Hardikar Orthopedic Operation Textbooks and Atlas, which has been published in 2018. Also, he had more than 12 plus scientific paper presentations in reputed journals, as well as he has also in Mahocon 1994 at Sholapur, he has presented his paper on interlocking nailing. He was faculty at many as I said, many workshops, CMEs, POSAC, ASICONs, and Pune HIP course. He has also done lots of social work, active participation in camps at rural areas of Maharashtra, Ralegaon, Siddhi, Hingoli, Mawa, etc., etc. Then he is active in promoting healthcare of accessibility and disability empowerment. And he is a one of the chief surgeon in BJ Medical College for disability assessment. And today he is going to enlighten us during his talk about the same. And he has a special interest in mechanical and electronic innovations, process improvement in clinical practice, listening, music, and reading. So with this, may I present to you the most humble and very jolly past president of Pune Orthopedic Society, Dr. Srinivas Shintre sir. Please, sir.
Many thanks for this kind word in introduction. At the outset, I thank Dr. Govardhan and Dr. Shailesh for giving me this opportunity to express my thoughts. Dear friends, the senior and junior teachers from the audience and students, and the other orthopedic friends. Witnessing the changing paradigms in orthopedics. This is the first part of my talk. The second part will be disability calculation, which will be not a very long talk. I devote this talk to my parents who made me and always thought of my well-being, and my wife and children who loved and sacrificed for me, and also a great source of energy. Also my teachers and students who loved me and my progress. I will be sharing my own experiences and some of my personal opinions which everybody may not accept, but please listen to them and then you may comment later on. During my presidency tenure in Pune Orthopedic Society 2019 and 20, I, along with the Secretary POS, Dr. Sanjay Patil and others, conducted 24 clinical meetings with the theme of basic orthopedic learning along with allied subjects, which was first. We considered the topics as giddiness, orthopedic rheumatology, and also pediatrician taught us about the IV fluid and medicine doses calculation in children. We prepared for POSAC 2020 till last few days, but unfortunately due to COVID breakdown, it had to be cancelled. This is the picture of the Pune Orthopedic Society meeting conducted in this tenure itself in Sassoon, where the two giants are arguing with each other, Dr. Panse and Dr. Damle, and also senior Dr. Salunke sir from the department, who is always enthusiastic to attend the department, to visit the department, and along with that all his students along with me. So the encyclopedia definition of paradigms, actually there are many definitions depending on which subject you select, like science, research, then sociology, English, and other subjects. So in science we will consider the definition. It is the framework of assumptions, theories and methodologies that guide research and understanding within a specific field. So it is a way of looking at the world. Similarly, for the research, the definition is again similar. It is a set of beliefs, assumptions and values that shape the entire research process, from formulating questions to analyze the data. So essentially it acts as a lens through which the researchers will view the world and their research problems. Now, how the changing in paradigm is occurring. You might have seen the BJ Medical College library, and can you believe that this is a picture of library, not here, but in US. I visited recently in North Carolina State University, and this is the library where the beach chairs are there, and the semicircular arrangement of the bookshelves, and also the different types of arrangements. They are making comfortable, you comfortable when you are reading, and the basic aim of changing the paradigms is to attract more people. So this is the book bot, where the 2 million books are stored in the racks which are sideways, and they pick up the book, whatever you want, and then they will deliver in 1 hour or so. Looking back in the past, now in this discussing the paradigms, I will be stressing on the past mainly, because future and the present will be discussing in this conference and all the conferences we have been discussing. So I think the newer generation may not know what was there in the past, what we used to practice at the time when we were residents or MS students. So it is called as, it is said that old is gold. Now, how I enjoy the Hindi songs. Actually, this phenomenon may not be there, those who are looking at the video songs right from the beginning. If we just hear the audio songs like in the radio or the tape recorder, and in that incidence, when we hear the song first or later on also, that particular memory piece is attached to that song. That's what I feel. Means this is my experience, it may not be your also. Then when we hear the song again, and then we go in that past, and we depending on that past situation, if it is stressful, then I will say that okay, I have come over that situation. If it is pleasurable situation, then it will be like going in the past, so bringing that pleasure again. So it will be like phenomenal, like bad or good dreams. I have observed that there are many bad dreams or stressful dreams than the good dreams. That's what I have. And when we wake up, then we'll experience that the good dream, bad dreams is not, it is dream only. It's not a real life. So I enjoy that. Why I have become orthopedic teacher? That was a question which was asked by Dr. Shailesh. So late Professor Lohkare sir, which was our head of the department, he was the second head of the department. Dr. Tatke was the first head of the department. So during his UG lectures, undergraduate lectures, he used to tell that suppose he discusses any of the topic in orthopedics, the treatment of this is very simple. So that was the first message. Second message was, patient comes to the orthopedic surgeon by car and goes walking. That means he leaves the card with the orthopedic surgeon. So jokingly, but that was the message which we took, and then we selected the orthopedic. The changing concepts about the philosophy of my life are also there. So we say that I do everything initially, then later on the God does everything. Both are blind faiths. So going towards the faith is that I tried to edit part of my life which is editable, and lived major happenings or which are not editable to the God who knows my well-being better than me. So it is in Bhagavad Gita, Karmanye Vadhikarasya Ma Phaleshu Kadachanam. So that is the thought, and in future I have not gone up to that. Whatever happens to in the bodily world is good for soul, and God takes care of your physical world, everything, and if you are honestly helping others. But that up to that stage I have not reached. Dr. Ranawat sir, he is my divine mentor. He used to say, orthopedic surgery is your lifetime commitment. So again Dr. Chaudhary, Sharad Chaudhary, who is again a senior professor of our department, he used to help us even if that help is not asked by us. The second picture, Dr. Prashant Kate, Dr. Parag Sancheti, and Chaudhary sir. Hardikar sir is more than a mentor for me. Discipline, time, punctuality, and command in English are his characteristics. We could please him only by hard work and nothing else, no good talks. My mentor at different stages, actually everybody is mentor that way. I should mention everybody from here also, senior people, but late Dr. E.P. Patil sir, who was our teacher as well as examiner, Dr. Srinivas Prakash sir in Hardikar Hospital, Professor Dr. C.A. Talwalkar sir, Professor Dr. Nandu Lad sir, Dr. V.R. Kakatkar sir, Dr. Ashok Desai sir, and Dr. Madhav Borate sir. So everybody tried to bring me up. Causes of fastly changing paradigm in orthopedics. So due to increased surgeons' confidence about the results of surgery. So the surgeons are also more confident, patients are also more expecting, and that's why there are increased surgeries. Advances in implant material and design like titanium, where patient can bed bear immediately. Better understanding of fracture anatomy because of advances in imaging technology like MRI, 3D CT. Emerging super specialities. So every super speciality will have to have his own chunk, And so more operative, of course, that is nothing wrong in that. Better and safer anesthesia techniques also, last but not the least. Changing paradigms about teaching and exam. I am a teacher, so let us discuss that. So examiner used to fail the candidates if they could not elicit clinical signs correctly, and if the examiners feel that candidates have seen X-ray before. Now there is more discussion about the MRI findings rather than clinical, which is, I don't agree with that, that is good. Dr. Arun Salunke sir, Secretary MOACON 92, where I was Joint Secretary. So I remember him scolding me because I could not elicit ankle movements properly. It might be happening with every student, but that was a story. So clinical pathological correlation, that was another good meeting which was happening in BJ Medical College pre-MRI era. Because when suppose patient dies because of some reasons, then the clinician and the pathologist who is doing the clinical PM, they used to discuss what would be the cause of death, and that was an interesting teaching type of meeting. Importance of putting the notes on the paper with clinical examination findings, always stressed by our senior teachers, Dr. Lohkare sir. When we entered as a resident, he said, you put notes on OPD papers, I will rectify the mistakes. So that was his supporting, he never scolded us. And this is our unit. Dr. Arvind Bhave is also there, then Dr. Manoj, Dr. Bagul, Dr. Panse, who is having a jet in US, own jet, and so Dr. Salunke sir and Dr. Lohkare sir and his wife, and Dr. Rizbur sir. The post-operative protocols also, there is a lot of shift in the paradigms. I can say that there is almost 180 degrees shift in almost all the cases. So here, big surgeons take big incision. That was the first previous saying, and it has turned to minimally invasive surgeries, arthroscopies, etc. in every field because of imaging, C-arm and arthroscopy techniques. Post-operative ambulation protocol, initially we used to give physiotherapy in bed, then start non-weight bearing walking after 10 days, and then slowly partial weight bearing when we see callus in the X-ray after about 1 to 2 months, and then full weight bearing after you are sure that the union has 100% occurred. Nowadays, you know that it is immediate partial weight bearing and then full weight bearing. Dressing protocol also, in Sassoon, we used to dress every alternate day, and that was because of fear of infection. Nowadays, we are just opening the dressing if there is any problem, otherwise directly at the time of suture removal. Antibiotic prophylaxis again has changed a lot. Initially it was 8 to 10 days of IV antibiotic, and then followed by long oral antibiotic till the wound is totally clear. Now the protocol is only 1 to 3 days of antibiotics. Suction drain again, initially each and every case we used to put suction drain. Whenever you are in doubt, put suction drain, but nowadays it is very rarely put. Concepts came and vanished. So there were some concepts which were there in the emerging in our residency days, like carbon fiber for ACL reconstruction, then isoelastic joint prosthesis. But that never came, and then they vanished like that. And distal locking jig or targeting device for interlocking nailing. So actually that distal locking jig or targeting device I tried to make. At that time there was only X-rays, no C-arms. And so in order to do distal locking in case of interlocking, I devised a jig having a mesh, and then we used to take X-ray and see the location of the distal hole, and then put the screw in the hole. So this was the first case which was supported by media in paper, and the operative picture, you can see that it was a hand drill at that time, no power drill was available. So changes in the orthopedic instruments also are there. Instruments vanished with the implants, like K-nail hook extractor, which we used to use, but these are undergraduate and postgraduate students will not know that. Purchasing inventory is now obsolete. Nobody purchases the instrument set because the company provides it. Instruments, hardly any surgeon using them have vanished. So Lohmann's bone holding clamp, actually I remember that Lohmann's bone holding clamp was a very good instrument. If there is an oblique fracture, for putting the interfragmentary screw, it was a very good instrument, but nowadays it is hardly available. And second is the Ashnish jig, where we can put parallel K wires or parallel guide wires. That is also not there now. And some instruments modified, like slotted screwdriver initially we used to use, that has been modified to hexagonal screwdriver. And diagnostic arthroscopy has been modified to operative video arthroscope. This is a photograph when we purchased the arthroscope first in the BJ Medical College and Sassoon in 1988. Where Dr. Lohkare was HOD, Dr. Bhave, Arvind Bhave also there, Dr. Salunke sir and myself. And that was having just instruments, operative instruments like punch or the scissor to cut, or meniscectomy knife. These three instruments were mainly there. Changes in the orthopedic operations, surgeries which are still done, like medial collateral repair, etc. Surgeries which are modified. Now the principle remaining same, but lateral jet in place of Bristow, where the sling operation is there to prevent the instability. MPFL reconstruction in place of lateral and medial plication for habitual dislocation of patella. Some operations have vanished, anterior spinal fusion. I remind Dr. Vilas Zog, late Dr. Vilas Zog, we used to say that don't get frightened by looking at the pulsating aorta. It has its own anatomical place. So it is in its own anatomical place. Why you are getting afraid with that? By seeing the pulsations. So similarly, in other words, your emotions should not interfere with the patient's surgery or examination. So this is also a very good teaching, that while examining especially female patients, why your emotions should be there. That is the thing. So remained with the limited and specific indications are like Eliza Rao. Initially, we used Eliza Rao for each and every one simple fracture case also, and nowadays there are limited indications. So for MS orthopedics, we studied Campbell, which was a standard textbook, 11th edition. In 1990s, 80% of times we have realized that we are performing only 20% of surgical procedures which was described there. And now we can say less than 5% of that edition. Those surgeries described as about one page or one paragraph and couple of figures. So there was little bit less understanding how to do surgery. So that's why Hardikar sir, Dr. Panchan Nadikar along with me and other contributors published a book, Hardikar Orthopedic Operations Text and Atlas, describing the common surgical procedures in a stepwise manner with surgical photos. So this was a book which we had published, one of the greatest achievements in my life. And this was the publication ceremony at IOACON 2019. And it is now recognized by Maharashtra University of Health Sciences also as a reference book for undergraduate and postgraduates. Now changing paradigms about the treatment of fractures. Better understanding of fractures anatomy with 3D CT. So the concepts have little changed, like 4-column fixation for tibial condylar fractures, intra-articular fractures are done. Previously there used to be only 1 or 2 plates which you used to put at the buttress plate. Fixing anterior column of spine with posterior instrumentation, taking biopsy and draining the abscess, putting the cage, bone grafts using transpedicular approach. All these things can be done by transpedicular approach. Actually, Bhave sir is there and he will agree with me. So mode of the fixation is semi-rigid, simple plate or V-nail, it was initial mode of fixation, to rigid, dynamic compression plate and external fixator. Nowadays, the mode of fixation has changed to dynamic or elastic. Compression osteosynthesis to distraction osteosynthesis. Bone union, electromagnetic bone stimulator came and vanished. Nowadays orthobiologics is talked more, and today we are having one session on that also. So to share my experiences, previously we used to do some surgeries and good results were there. Like shaft femur fractures in a child used to be treated with Tobruk cast 100%, and we got very good results. Nowadays people like to nail that. For each and every fracture, is it necessary? That is the question. Lower third of fracture femur treated with DCP, then it broke, and then treated with canal with good union. DCP and canal was initial, so we had to go back with the canal. One hefty patient treated of subtrochanteric fracture femur with canal, driving bicycle in 3 months. So you senior surgeons might have similar incidences. With the old implants, we are getting good results. Young woman having a fracture shaft humerus operated with closed V-nailing stood for her own marriage. This was actually done by our senior teacher, Dr. K. Sancheti sir. So I was fortunate enough to get blessings recently from sir, and my observation is that he can handle everything with his extremely soft hands and gentle speech, and it impresses anybody with his confident but gentle attitude, empathy, and also he is fast but gentle in handling tissues during surgery. So he is giving very best results to his surgery. Fracture clavicle, as you know, previously conservative treatment, figure of 8 bandage, and lateral end we used to give Robert Jones tapping. Nowadays lot of fixations. Upper limb fractures, again arm to chest tapping or aeroplane splint for neck femur, neck humerus. Now Philos plate we are doing. Humerus shaft, hanging arm cast, V-nail, combo, and nowadays replaced by combo plate and interlocking nail. Radius ulna, again we used to use Tolwekar square nails, and later on dynamic compression plate. Nowadays LCP and combo plates are there, and which are made up of titanium or stainless steel. Fracture pelvis, we used to be treated conservatively lot, and nowadays at some times we used to put external fixation, especially open book injury. Then if there is a sacroiliac instability, then we used to fix that joint. Now the pelviacetabular surgeons fix those. Fracture acetabulum previously treated with bag of bones method, skeletal traction or longitudinal and trochanteric. So 2 vectors, and then ultimately that force is at the parallel to the neck. Fracture dorsal spine, conservative if there is no dural deficit. I think similar surgeries are Harrington rod fixation where only hooks were posterior and no anterior fixation, and later laminectomy plus laminectomy, and also later on there was Lucas rod, L-shaped rods which are shown here, and then the Steffi plating, there the force nucleus concept was there, and nowadays we have the Moss-Miyavi fixation. Spinal decompression again has changed a lot. Wide laminectomy plus fusion was initial, then hemilaminectomy, then fenestration. It has got minimalized, and caudal epidural injections were there, and now minimally invasive surgery or endoscopy, anterior cervical plate fixation and root blocks. Fracture neck femur, before there was a garden screw which used to be put cross garden screw. We have not seen that, but Ashney screw we had done. So parallel Ashney screws were similar to CC screws. The Austin Moore pin for children we have used frequently, which has got a bolt and a non-threaded portion. And non-union Mayer's procedure, muscle pedicle graft, and McMurray's osteotomy we used to do quite frequently. It was an intertrochanteric, oblique, valgus and medial displacement. CC screws, total hip arthroplasty and bipolar are the nowadays done. So intertrochanteric and subtrochanteric fracture. SP nail plate was initial implant, also Jouet nail plate. And late Dr. Rizbud sir, I remind him, because he used to put his first guide wire right. At that time again no Siam. So with X-ray shoots, many have seen that 10 to 20 shoots were necessary for putting the guide wire correctly. But sir used to put every guide wire only by one shot. Nowadays, the Richard screw or DHS, that was the terminology we used to use. This is a similar DHS. Diamond osteotomy also we used to do quite frequently. And now, of course, PFN long and short. This, as far as neck femur fracture is concerned, this paper was a landmark paper in 2008, and which was published in Acta Orthopedica. Close nursing care, physiotherapy and pain management for conservatively treated fracture neck patients as unfit for surgery, same mortality rate as operative. So conservative was used for even patients which are unfit for surgery, and the results were same. Fracture shaft femur, Thomas splint, Tobruk cast and K-nail were the devices. The K-nail, we used to say that 3-point fixation, and the side wall fixation by putting the oversized nail, and the concept of interlocking, we know that we put a loose nail or undersized nail for telescoping. The supracondylar fractures in femur in adults, we used to use either the skeletal traction plus gutter splint or open reduction internal fixation with blade plate, and distal femoral locking nail and distal femoral combo locking plate is nowadays used. Tibia fibula fractures, bony cast, plaster cast wedging, PTB, V-nail, and condylar fracture tibia, tourniquet reduction and AK cast. Interlocking nail and proximal tibial nail and distal tibial nail and combo plate by MIPO method is nowadays used. Foot and ankle injuries, there is a foot and ankle speciality, but initially we used to use only fracture calcaneum plate and screw and tarsus or metatarsal K-wire and below knee plaster. Malleolar fractures, we used to put that malleolar screw which used to have a tip so that no tap was necessary while putting that screw. But now we put CC screws which doesn't have any pointed end. Posterior malleolus fixation, we used to put only one lag screw if more than 30% articular surface was involved. But nowadays the thinking is that fix each and every posterior malleolus fracture and CC screws for medial malleolus. Pediatric fracture, the paradigm has changed a lot. Almost all conservative to some operative, and because parents demand insurance coverage and economic conditions better for better understanding about the remodeling capacities. So supracondylar fracture, humerus, close reduction and Dunlop traction. Dunlop traction we used to give 60-60 traction, and radius ulna, close reduction and plaster cast, shaft femur, Thomas splint, Tobruk cast. Tobruk cast is a cast which we used to put the plaster bandage over the Thomas splint. That was a Tobruk cast, and then patient can be discharged. Fracture tibia fibula, Aboni plaster cast, and nowadays we use tense nailing. Knee injuries, IDK. Previously it used to be said that it is internal derangement of knee, but I don't know. That was another long form of IDK. But nowadays with MRI etc., the picture is very clear. So initially we used to do open meniscectomy, figure of 4 position, open meniscal repair and extra-articular ACL reconstruction, ACL tear with a carbon fiber which vanished as I told you, and diagnostic arthroscopy only. Now the arthroscopies have evolved so much, meniscectomy, meniscal repair. Meniscal repair is outside in, inside out, or all inside, and ACL also double bundle, anatomical, all these options are there. Frozen shoulder or stiff knee, manipulation under anesthesia was very common and popular procedure, but now I don't know whether anybody is doing that. And injection local hydrocortisone as Rizwood sir used to teach us, that it gives a dramatic result or dramatic relief to the patient, and it really is so. Now with the MRI, the exact lesion is clear, and people many times go for shoulder arthroscopy, injection, PRP, and arthroscopic adenolysis for the knee, arthropfibrosis. Osteoarthritis, hip and knee. Previously, knee osteoarthritis, high tibial osteotomy was different. Nowadays, it is oblique and open wedge. It was previously closed wedge osteotomy. And it has extended indications used to be discussed, like even if lateral condyle is involved, still we can do that. Then nowadays, of course, visco supplements, braces, PRP, and low threshold TKA, as it is called, not TKR, by the patients and surgeons. Hip, girdle stone, arthrodesis, THR, hanging hip operations, THR. THR is actually a total hip replacement. Instead of that, now talk about THA, that is total hip replacement, total hip arthroplasty, and total knee arthroplasty. TB spine or pot spine, initially long back, it was a pure rest. That was a basic mainstay of treatment. The pure is prolonged, uninterrupted, rigid, enforced. So that was told by again Vilas Jog sir. Middle path regime, Dr. S.M. Tuli is in MOACon 92 with Damle sir. Cold abscess, we used to do aspiration by Z technique, non-dependent site, wide bone needle, and costotransversectomy, anterolateral debridement and anterior decompression and anterior spinal fusion. These are all forgotten now because they are very major surgeries, and instead of that, posterior approach is preferable, where there is less risk of injuring the intrathoracic or intra-abdominal structures. So transpedicular decompression and Moss-Miami. Tuberculosis of knee, again the triple deformity was very common, and we used to use Russell traction, knee cage, and Wilkinson joint clearance was a very important surgery where we used to go in and then take out whatever is diseased. Nowadays with arthroscopy that is more easy. And knee arthrodesis using Chanley's clamp. Now Talesara sir might be remembering this, that this Chanley's clamp we used to be there, where we used to tighten it till the Stedman pin starts bending. Nowadays, we are doing TKR for tuberculosis also. And previously, if we would have talked in the exam TKR, then the examiners would have thrown out of the exam hall. Chronic osteomyelitis, excision, incision and drainage, suction and irrigation, and sequestrectomy, saucerization, papinus, all were techniques used. Infected implants, debride, retain or remove, external fixation, and gap non-union, Chacha's procedure was there, that is tibialization of fibula. That means we used to cut the fibula at lower down, and we used to put that lower end of the upper fragment inside the medullary canal of the lower part of the tibia. And then patient used to walk with the fibula which used to be very thickened. Elizarov, then LRS, antibiotic beads, stimulant, mascalate, antibiotic nail spacers, articulating and non-articulating. These are devices which are nowadays used. So, is this changing trend in orthopedics really helpful always? There are some discussions, but this is an article by Dr. Sudhir Singh, Professor Sudhir Singh, and he has described it little different way. Generalized versus specialized treatment. So specialist faculties, even though employed in a teaching hospital or teaching medical college, then they shy away from teaching and try to function only as a specialist. That is a disadvantage. Specialist teacher in that area alone. Then the comprehensive care versus procedural care. The proceduralist is the orthopedic surgeon, lack cognitive or non-operative skill. So only he will be thinking of procedure only, like arthroscopies. So that was the described picture. Major disadvantage is to exaggerate the importance of surgical procedures of totality of patient's care. So if the patient wants a non-operative care, then he doesn't get it, because you will insist on surgery. So Charles Heck termed as an orthopedist and not orthopedic surgeons. And nowadays, surprisingly, he has noted that research emphasis versus practical emphasis. So decreasing emphasis on research, which he has noticed, so less awards are won by orthopedic surgeons. That was his observation. This book I bought from Kolkata airport, and this is a very good book. Actually, it mentions that different type of surgical practices, how they can be disastrous to the patient. So he described one South Indian female athlete which was undergone arthroscopic surgery, and then later on somehow she got paralyzed, her leg paralyzed. And so she was having just an instability while running. So for that, was that necessary? That was a question. Later on she sued the hospital or orthopedic surgeon, that is a different story. But then we should make the patient aware. Actually there was in the last discussion, it was going on. So Wakankar sir said that I will discuss always with the patient that whatever complications can happen, maybe rarely. Good doctor, 12 things are required for zero talent. They require zero talent. These are the 12 things. And actually, my father used to tell us that even if you come first in the exam, you are not that all you have achieved. But this is only 1% you have achieved. 99% you will achieve by means of these 12 things, which are very important. More important than the talent. Now we will go to the second part of the talk, which is less. So this is musculoskeletal disability evaluation and certification in road traffic accident victim. So we know that pediatric orthopedic surgeons, they purchase Mercedes, arthroscopist Audi, arthroplasty surgeons BMW, and all the big cars. And if I ask Dr. Govardhan that whether he can reach his you can say goal by just a small car, electric car, and then he will say that I am fine with that, but I should know the exact basis or the rules of driving that car, about the charging and discharging, etc. I can reach the goal in the city better. So the private, so that's why I will teach you little about the disability management and the goals or the basis, scientific basis or the mathematical basis a little. So private practicing orthopedic surgeons, they need to give disability certificate for compensation claim. And we are doing our job, we are giving the disability for other people like post-polio or other for benefits. But what court says or what law says is preferably that should be given by treating doctor. But treating doctor is reluctant to give that. Why? Because difficulty in calculating the disability. Precious time and practice wasted in the court, and fear of giving expert witness in the court. These are the 3 points which we will be discussing. When in the orthopedic department Sassoon, we were planning and implementing an objective system to assess the physical disability in order to give PS certificate. Actually, upper photo is our internship photo where Dr. Shetty and Dr. Shelar were our medical officer, which now they shifted to Sassoon as a RMO. So they also were involved, they took lead, myself and Dr. Pandey, Ganesh Pandey, who is the physiotherapist. So 3 sat together and started developing some system which should be uniform, where there should not be any subjectivity involved. Then there should not be any monopoly, like only HOD is giving certificate and no other person is giving certificate. That should not have been there. And the legality of course has to be there, so that Ministry of Health and Family Welfare, they have given guidelines, according to that we have to go. And uniformity also has to be there. So if there is any other person giving certificate, then it should be almost uniform. Documentation has to be there, because previously we had incidences that previous head of the department, they gave certificate just by looking at the patient. That was a system initially. Just you look at the patient and you decide 30%, 35%, whatever. And then what happened that later on that patient, same patient came to him, say after about 6 months or 1 year, he did not recognize it, again reassessed, again gave some other certificate of other percentage, and like that 2 or 3 incidences, and then he produced the same 3 certificates that what is the exact disability. So that's why the recording and documentation is very important. So assessment of disability, now let us discuss about that. The certification threshold is minimum 40%, but not for you. This is for permanently handicapped certificate for benefits. Assessment scale, the disability quantified from 0 to 100%. Then locomotor definition is impairment of bones, joints and muscle functions is the locomotor system. Duration classification. If it is a temporary disability, then it has to be less than 1 year or 2 years. 2 years for spine, 1 year for extremities. And permanent means after that. So Gazette of India guidelines, they have published different guidelines, and then the standardization has to be there with those guidelines by certification. And comprehensive coverage. So protocol addresses multiple disability types including locomotor, visual, hearing, etc. This was a Motor Vehicle Act which was in 1988. So they commented that the certification for compensation is same, should be same as that of Workmen's Compensation Act, which was published much before. So these were the different guidelines or acts. The Workmen's Compensation Act is 1923, Motor Vehicle Act 1988, then published Minister of Health and Family Welfare Guidelines 1991, then Gazette of India Part 1 2001, Gazette of India 2018, that is the latest, and Gazette Amendments 2022. So let us talk about how to calculate the disability. That is very important part of the talk. So upper limb amputations, depending on the level, the amputation is directly calculated as disability. Of course, the additions are like if there is a dominant hand, dominant extremity, or if there are additional problems like pain or deformity, etc. So upper extremity, again, they have given the chart, and directly you can look into the chart and give. These are the additional allowances which can be given. But here one hitch is that if there is a little finger amputation, then the disability mentioned is about 2 to 5%. So in that 2 to 5%, if there is a dominant extremity, you are adding 10%, and if there is a pain, then you are adding still more 10%. So the disability will become 23%, which is wrong. So accordingly, you have to add that allowance. So what is the step-by-step calculation process? Now we don't quite often come across the amputations, but we come across the patients like if there is a Colles fracture which is malunited, or other fractures with the complications and with the limitation of movements, etc. So in such a situation, how to calculate the deformity? So measure range of the motion, that is the first step. Then grade muscle power, we know grade 0 to 5 powers. Then the stability component is there, there is a reference, and then combine the values, that is a process. So measurements of function in the lower extremity. Now first we will see the example of lower extremity. So mobility component, mobility component and stability component. So mobility component is the range of movement and muscle strength. So it is divided into two. So strength, ROM and the stability. These are the three basic things. So in hip, knee and ankle or foot, there are 30% which are given out of 90%. Again for strength also same thing. Then this is the first record of patients which we have to keep, diagnosis, department name, etc. Hip joint active range of motion, knee joint active range of motion, and ankle joint active range of motion. So you just note all these. The standard range is there, as you know. Then the muscle strength also you have to note that. And the stability related activities directly you can enter if the standing on the both legs, is it effectively possible or not, depending on grading 0, 2, 4, 7, 9, etc. Maximum 9. So we have the hip joint mean loss is 30%, that is 0.3, and knee is in 30%, and again ankle is 30%. Again the strength loss is also 30, 30, 30. So if we add to the extremity loss, then that is 90%, out of 90%. So now how to add that mobility component and strength component, because both are 90%. So if we add directly, then it may be more than 90%. If the average out, then it becomes too far less. So you have to use some different combining formula by adding A and B. Now this formula which is given down is value is equal to A plus B. So if you want to add A plus B, it is A plus B into bracket 90 minus A divided by 90. Some complicated formula, but the basis is, mathematical basis is, it is the fundamental principle of economics, diminishing returns. So it is in the production theory also. So suppose consider a pizza shop, and in that case the labor given left side and right side is the pizza as output. So if one labor is there in a given time with the same infrastructure, he will produce 3 pizzas. 2, then they will produce 8, 3, 20, and so up to this there is doubling, more than doubling, but after 4 and 5 it becomes less and less. So similarly you might have observed that if there is a hospital and employee is there, hospital employee is there, and he is doing 40% of the work in the hospital, and if you want to employ another 2 which are waiting list, so if you consider that you will employ 1 or 2 more, in that case will that be 100% work will be taken care of? No, it won't be. That production theory doesn't say that. So that's why if A is occupying and 10% is occupied by doctor, that means 10% of the work is occupied by is done by doctor. So area available for B is 90 minus A of 90 and B of 90. That is the area which is available ultimately. It is not that 90% is available. So out of that area, the B will be doing say 40% of work. Not exactly 40%, but it will be in proportion. So here is the solution. That is B divided by 90 into 90 minus A divided by 90. That is the area occupied by B in that. So here,
so can we
that's
cut down little time?
Just a few slides, only 1 or 2. So only 1 or 2. So additional weightage, and these are the formula, by formula you have to add. So this combining formula is used for adding apple to orange, etc. This additional weightage, and then upper extremity also a similar combining formula has to be used for different muscle strength, range of motion, etc. and coordinated activities. And this is the documentation and reporting. So this is the format which anybody is interested, I am ready to share that. And these are the different FAQs which are used in the court. So actually recently we visited with the lead of Dr. Chetan, Dr. Parag to district court, and then they have assured that even online witness also is possible and they will be doing. So your time will not be spent on the practice. So to conclude this Sivavalokan, one or two take-homes for the audience. If they have got, then I will be more than happy. And actually, for my own comment, I should stop, because I have already, we can say, spent more than 2/3 of the active life. So I should stop recording each and everything of the conference. So with that, I thank you for silent listening.
Thank you, sir, for excellent presidential oration. And we move on with the felicitation of Shintre, sir. Yeah.
So, thank you, sir. You have taken journey from your residency to HOD. So, it was a marvelous journey. We experienced all basic of orthopedic, which was started long back to advance. And it was a beautiful session for the disability you took. So, we like to, on behalf of POS, we want to felicitate you for the beautiful lecture. Thank you, sir. Thank you, sir, for beautiful oration. Now,
and hand surgery, Dr. Sudhir Warrior, with the decades of expertise, groundbreaking innovations, and international recognition as a teacher and surgeon, Dr. Warrior continues to inspire generations of professionals. Sir, we request you to kindly come forward and deliver your keynote address. Over to you, sir.
Thank you so much. When I got this invitation from Shailesh, I was a little worried. And I said, I really don't know why POS does not want to give me an academic topic. Maybe I'm past sell by date, ho gaya mera, expiry date khatam ho gaya, to abhi joker in the pack karke bula diya. Until yesterday, my wife just told me, here's the newspaper, the sports section, 6 patients there, 2 from the badminton, 4 in those teams, and that wrestler, all of them in yesterday's paper. And then I realized, oh my God, this seems like my patient list, not a newspaper. So I have been seeing celebrities over the years, but when I started my practice, the door never opened for a patient, and when it did, that was my best celebrity. So when you start your practice, every single patient remains a celebrity forever. That's very, very important. It was 14 years into practice that I got the first call-up. It was Anand Joshi who called me and said, come out of Leelavati Hospital, stand across the road. And he drove me to a building. I didn't know where we were going. And then suddenly when we reached in front, there was Tendulkar written there. He had a sesamoid fracture. I was a hand surgeon. I really didn't know. Just like the POSAC invitation, I didn't know why I was invited there. Well, that was my introduction to a new world. After which, of course, things progressed. And now when you ask me to speak about how you deal with celebrities, I first wanted to know who is a celebrity. So I looked it up and it says it's a person who's widely known and recognized, and often for their achievements in the fields like entertainment, sports, or public life, and who commands a degree of public and media attention, and that sets them apart a little bit. Because you need to be a little careful when you're dealing with such people, because it can affect your practice and it can cause a lot of problems too. So you do enjoy what you get when you deal with them, but you must understand it's a two-edged sword. For this talk, I'm keeping out, for obvious reasons, politicians, industry captains, the constabulary or the police, and the underworld, many of whom we all treat or ill-treat. Well, famous. Where are they famous? They can be famous in a village. He's a celebrity in a village. He can be famous in their own sphere, may not be outside his sphere, but he's still famous. So you need to be, you must understand who each person that comes into your room is, and therefore they become celebrities. Sometimes they may be celebrities who are in the state, who are in the country or international. But remember, as you move to a bigger atmosphere or environment, you realize your responsibility multiplies. Your vulnerability just goes haywire. You are shivering when you're dealing with them. You must understand that you must take utmost care when you're treating celebrities. Well, each one of us sits and thinks, यार ये warrior तो बहुत अच्छा है, उसका तो solid celebrities, patients वगैरह आता है, मेरे को भी चाहिए यार. How does this happen? Well, the first thing is dint of hard work. You just keep on doing good work, keep great records, keep looking at your records, improve each time, present your work, present it forcibly, show what you can do, get noticed, and continue working hard until an angel comes by. For me, that angel was Anand Joshi. He was the doctor of all celebrities, and he called me to treat a patient whom I did not charge, and he immediately told me, I'm not sending you any more patients. I was so scared. I said, my God, this guy has come to me. I can't treat him. This was not when I went to Sachin's house. Incidentally, Sachin's wife is a doctor, so I don't charge the doctor's families, so I don't charge him. Well, then there was this general practitioner who dealt with all the film personalities in Juhu, Ramesh Agarwal, and there is Rajiv Sharma, another general practitioner who deals with all the people from Rajasthan and Calcutta, and he takes them all over the world. And suddenly one day he said, can you see this patient? And I'm wondering, he's been all over the world with these patients who can go all over, and that put that responsibility on me. This was a minister's son whom I operated, and the story will continue later. Ram Chadda, of course, famous in the film world, so I got a lot of references from him. And Nitin Patel, the physiotherapist of the Indian team for a very long time, and then the head of NCA in Bangalore. He's been a constant source, and every time I sent back results to him, he would say, this is doing very well, better than what we saw elsewhere, and therefore you keep doing that. Then you get seen, the word of mouth keeps going wider and wider, you keep working hard. And remember, your results speak. If your results are not good, you're not getting the next patient. And then the word of mouth spreads and spreads and spreads, and then suddenly I get to see a celebrity because of his dog. I did a lot of veterinary work with Dr. Wakankar, not Hemant, but Dr. Wakankar in Bombay. He's a veterinary surgeon of great repute, and he would call me and say, "Ek VIP ka kutta hai yaar. Uska jara non-union ho gaya yaar." So I used to go and do a lot of veterinary work, and then I would get to see more celebrities because they would always be there with their dogs. And then, of course, you get invited to POSAC and you'll get more celebrities next time. The first thing you do is you dress properly. I have started dressing in t-shirts. Anand Joshi goes in shorts. Well, you have to dress appropriately for the person you're going to. Don't overdress and don't underdress. You have to, and not try to match them, and don't try to be too fashionable or things like that. Address even younger celebrities with great respect, because once when Sachin came into the hospital in Lilavati, there was this security officer who said, "Come, Sachin," and he put his arm around Sachin Tendulkar. He's a security officer. And I took his hand off and I said, "Excuse me, this is Mr. Sachin Tendulkar. You treat him with respect." So you tend to, because you heard the name, you've seen him on television, they talk to you through ads, they're always there making fun, you think you know them well. But they are not. They are people who have their own feelings. This is a young girl from Kolhapur, and that's Dada Laute, the coach. And he brought this little girl when she was small, and I didn't know she was a girl. She had short hair because she's a wrestler, they don't keep long hair. So I was standing outside and I was talking to her, and I put my arm around her and I said, "Come and sit down." And those days we used to write the names, and I said, "Now, Sang." After I went into the room and she said, "Swati Shinde." I immediately told the coach, "I'm so sorry, because inappropriately I may have touched her." So keep those feelings, understand whom you're dealing with, don't try to be overtly friendly, and keep to time. I never do that, but you must try and keep to time, because many of them are extremely punctual. They are sometimes very late and give you trouble. And choose your words and control your staff. They're always with selfies. Now with the phones, it's crazy. They want photographs, and it irritates the hell out of all of them. Don't cut them short. Listen. There's a study that says that on an average in America, a doctor's interview is interrupted by the doctor when a patient is talking to him in 17 seconds. We don't want to hear more. What do you have? I've got pain. Before they can finish their story, they've already interrupted them. So patients don't like that. So don't interrupt, don't cut them short, don't be overawed. He may be a big person, but he's come to you. And you're the one who's going to provide him relief. Don't be a doctor and a fan. I'm always that. And I always say, wow. Don't ever say, I'm a great fan of yours. I saw this movie, or I did that, or I saw, I watched that innings when you were playing. Or that. Doesn't matter to them. They've done that, they're moving on, they've come to you in pain. Understand that. Take care of their pain, that's what they're there for. Be honest. Don't say anything that is not right. The first time I was called for a hand problem with Sachin, he had a metacarpophalangeal joint instability, and I was asked, have you done one before? It was a chronic one, and I hadn't done it. So I said, no, I lost that patient. He went abroad and got operated by Dror Pelly and his hand surgeon, who's not even a hand surgeon, but he got operated there. But I was honest because I thought I don't want to mislead him. And I did call 3-4 colleagues, and they said even they hadn't done one of the 4th metacarpophalangeal joint in a chronic stage. So therefore, you should be honest, and I think it comes back to you. That honesty brings you much more work. Proficiency. If you're not good enough, you need to be upping your practice. And now I send a lot of patients to Abhijit for scopies because I don't do it. So I wouldn't keep those patients back. Dinshaw gets a lot of patients. Deepak Bhatia gets a lot of patients of mine because I just don't want to do something open when there's a better technique just because he came to me. And always call in a friend if there's a problem. So the first minister's son that I saw, I did a distal radius fracture malunion correction in a young boy, and the wires wound around his superficial branch of the radial nerve. So I called in Mangal Parihar, and the two of us then worked the second time. I'm glad that they came back to me, and the boy is doing extremely well. They have medical advisors or medical concierges as they are called now. You need to deal with them. You need to treat them with respect because they respect their advisors more than they respect you. It looks as though they are interested in you, but no. The moment you say something, the advisor has already decided, nahi, this fellow, iska patta kaat dalo. So you respect them. Talk to them well. Ensure that they will definitely ensure that you get more and more celebrities, and don't contradict them. Even if they're wrong, be very diplomatic with them because that's very important, and don't belittle them. Don't miss them in the room. So there's a big personality in front of you. Don't spend all your time there. Always explain things like that and look at him and talk to him and then come back to this guy. So he feels important, and that's very important that you show this to the person that I know that this man is important to you. And if he says something wrong, say, I agree with you, but we should think different. Are they different? Well, priority. You need to give them some priority because otherwise they get sick of waiting in rooms and things like that. So you need to be a little careful about that. Call them before, call them after. See that there's not much of crowd. Call them to an appropriate place. There's a patient who came to me and said when she was going, I'd gone to a hospital and I said, give me a room, I want to examine this patient. And as I examined her, and I sent her out, she called me back later and she said, don't ever examine me in that room again. So I said, what's wrong with the room? I turned around and looked at the board, it said, Women's Incontinence Clinic. She's a well-known person, so you need to be careful about where you see that. Now, about your proficiency, here's a cricket bowler of national repute who I reduced for a PIP joint and conserved. His physiotherapist decided that it's time for extension. And then the team decided to send him abroad, and he got a joint replacement, and his career ended. I did not do a hemi-hamate in those days, and so 14 years ago, I learned to do the hemi-hamate, and I started doing it on a regular basis. You must demand compliance, whoever the patient may be. It doesn't matter who the patient is. You have to insist because you must remember that every celebrity that comes to you, so first it was every patient was a celebrity, now you remember when they come to you, every celebrity is a patient. So if they don't comply, you're not going to get your result. So here's a spring splint, that's Sachin's hand, and the splint is broken, but his finger is all right. So you need to get that. Now this is Pollard, whom I told you should not go and play this game. I don't know why this is not working. Yeah. Because he had a dislocation of his little finger, and 3 times it dislocated. He went the next day to play. He dropped the catch once. He dropped the catch a second time. Just when I told my son, see, I told him not to go. The same over, he took one of the best catches of the time. So they will always prove you wrong. They will always prove you wrong. So you must be careful when you're dealing with athletes. Should you charge them? I'm just going to quickly tell you one story. Very big film personality, his wife brought the son in for a small congenital problem. I saw that, and as she moved towards the door, she said, "Should I pay you?" And I said, "I stand in line to buy tickets for your husband's movies." "Yes, ma'am, you need to pay me." She was very upset. And she threw the money on the table.
राहुल साहब, बहुत बरस पहले आप रेस खेलने जाया करते थे और हमेशा एक जगह गाड़ी रोककर अपने जूते पॉलिश करवाते। हाँ, क्यों? मैं आज भी फेंके हुए पैसे नहीं उठाता।
कोई भीख नहीं मांगता, पैसे उठाकर हाथ में दो।
So I thought I should have said that, but instead I just told her, "Madam, wait." I wrote a receipt and I gave it to her, and I said, "Madam, you'll need this for your income tax." They never ever came back. Yeah, so you need to devise your own method for that. Remember, you're just another vendor, don't expect gifts, but, well, my wife is extremely happy. This boy brought me a gift. He's Abhijit Shinde. He got me a Belgian chocolate because he got a medal over there for the under 19. And he carried that Belgian chocolate from Dombivli in a local train in his pocket. And then his father kept on nudging him and saying, "Dena, Dena." He's a Shiva Chhatrapati Award winner, and Deepak Karmarkar comes to his thing in Dombivli, and he set up a fantastic place in Kalyan, and he's training new athletes. But the boy just wouldn't put his hand in his pocket, and his father got angry and fired him. And then he took it out and he started crying because the chocolate had melted in the heat from Dombivli to Dadar. So gifts, they will come. You have to be very, very thankful when they return and come back and tell you. Sometimes they tend to forget you. Often they remember you. You get these rare opportunities of going to great weddings and things like that. And then sometimes they will turn around and give you something that you can remember that you supported them and you were there for them at that time. Don't bring family into friendship. I always did it, but you shouldn't do that because it tends to get the whole relationship a little different. Then there are these guys like Vidhu Vinod Chopra who became very friendly for a very simple problem. And what happened was he started paying attention to what we were doing. He learned ultrasound and he said, "What are you doing? How are you seeing this?" So then he said, "Come and see my craft." And he called me to his studio. And we went there and we watched and things like that. And then he said, "Yaar, tu bahut acha shirt color pehna hua hai." So I went straight back to the shop where I bought the shirt, bought him another shirt, and then he wore it and he said, "Here's my friend." And from then on, we were friends together, and I've been to all his movie releases, and every time there is a problem, he calls me and things like that. So sometimes you can forge a relationship with some of them when they're very nice to you. Celebrities are fodder for the press, and this is the last part of this talk. Remember, press is sometimes not so great. My first thing with the press was when Harbhajan Singh had to go to Australia and Anant couldn't go, and he said, "You will go." And my wife's brother was the person who printed this in the newspaper on my birthday, that is 15 June. And he said, "Dr. Warrior is getting a headline in the sports page." And that was the first and only time I came in the press. Sachin told me, "Don't make the mistake." I got 4 phone calls. He said, "Don't make the mistake. Write out what you want to say and say the same thing to everyone. Keep it on your dashboard in the car. When you receive a call, open that, stop your car, read that thing and forget about it. Don't say anything more or less. Confer with the celebrity that this is what I'm going to speak, because otherwise you can get something like this. Because Harbhajan Singh became ill, Sudhir Warrior ka number bhi aa gaya. This was when that ad was there, Mera number kab aayega? It was so bad, it resonated very bad with everyone. So you should be careful about that. And after 24 years, this was the greatest gift he could give me and my wife, and that was after so many injuries that he invited us to his retirement party, where he had invited only 200 people who helped him along his way in his entire life. That meant a lot to both of us. And I thought the story ended there, but I recently got a call and he said, can you come and see me? I'm getting a little pain and I've got this Masters League to go to and I'm leading India in that league. And I said, I'll come up, but I'll come with a bat. And he said, for what? And I said, I'll tell you the story about the bat. The day I was going to get a bat signed from him was the day when Anant was opening his new sports med. And on that day, I got a call from Gautam Chakravarti in UK saying, from Yorkshire, saying, I'm the president of the Yorkshire Indians and I'm holding a dinner and I want something to auction for a charity in India. So they have a dinner in Yorkshire, they auction something, they collect the money, send it to India. So I took that bat, got a signature, sent it there through one of the plastic surgeons who was traveling the next day, and it got auctioned for £15,000. And that auction money came back without anyone knowing to Apnale, which is Sachin Tendulkar's mother-in-law's charity. Fantastic. That circle was just completely done. I did not have an autographed bat. So I had already bought another bat and kept it in my car. It traveled in my car for 12 long years. And I decided I will not get it signed in a consulting room or in a hospital simply because they come to me for pain. They don't come to me to sign autographs. And I took it to his house because he called me home, got the signature, and he went and won, of course. That's his habit of doing things. And he won everything. So now it's come to the point that I want every celebrity to be my patient. That's ego, no? But the thing is, like I said, every patient should be a celebrity. At the start of this IPL, 6 of these captains had visited Lard Clinic sometime in their career. By the end of this IPL, now we have 7. So we've been treating one fellow through this IPL also. So that's how it spreads, because the physiotherapists will spread it. You know, it just keeps on and on. So we need to be very aware of that. And finally, before I close, all the names that I have taken in my talk today, I have taken permission from them and then only spoken about them. There's so many other stories which I don't want to talk about. Remember, information about patients is privileged information. Never give it out without permission of the celebrity. So guys, thank you very much.
Thank you so much, Dr. Sudhir Warrier, for that truly inspiring and insightful talk. Be on the dais, sir, please. Your journey, rich with experience and compassion, and the stories from your innings with celebrity patients have not only enlightened us, but also reminded us of the deep human connection behind every clinical encounter. Thank you once again, sir. I invite our President and Secretary to on the dais to felicitate, sir.
On the dais, and Dr. Hemant Wakankar, sir, please join us, and Dr. Karne, sir, please join us on the dais, and Dr. Yogesh Panchwal. Yeah. So I must thank first to Parag sir, Wakankar sir, and Karne, and obviously Yogesh. Yogesh is my contemporary, so I'll call him by name. But at the outset, when I asked them that we are going to conduct such kind of a session, which they are absolutely unaware of the questions or anything. I just said it's just like fun. So before I start, whatever we talk here, it ends here. That is first thing. And second
At
thing,
the outset, thank you for using my 20-year-old photograph on that flyer.
that was not me actually. But anyways, but you're looking smart, Dad. And second thing, a small oath, the dignitaries has to take that whatever they will say, it should be a truth and the only truth. Okay. So we'll try to finish it quickly.
You have to believe that whatever we say is going to be the truth. You have to believe.
Okay, whatever is there, I hope that there should not be any recordings for this. It is just for fun, just get relaxed from all the academics and everything. So for first question is obviously for Parag sir. Sir, if a very beautiful heroine, Miss Rashmika Mandana comes to you for a knee problem, she's having pain for whatever that time, and she heard your names as a celebrity. She is a celebrity and she heard you. And she came to you and she's having knee pain. You have seen her, everything, and suddenly she gets back pain also. So will you see her, you will examine her back, or Shailesh will be privileged?
No. So as a routine, it is my principle and practice that I always examine every part of the body. I think because you have to have a thorough clinical evaluation. Even though I am a knee surgeon, I still have my basics right. So I will examine the knee and definitely send it to Shailesh. The only thing different I'll do is I'll accompany her all the way and take her down to Shailesh's room.
With a hand around her shoulder.
Yeah.
Vakandkar sir, if Cindy Crawford comes to India and she comes to Pune to see Shaniwar Wada and she has bad knee pain, arthroscopy or plasty?
Cindy Crawford, I guess today is more than 60-year-old.
No, she's 59.
Okay, so
she's matching you
probably.
probably.
She's in the perfect
She's
age group.
matching you
So
then.
I think at the age of 60, there is any role for arthroscopy, you tell me.
She is managing to walk well, just some amount of pain and some
I will
here
treat her
and there.
conservatively and treat her very well.
Okay.
Call her for traction every day.
Okay, one more question for Vakandkar sir only. तुम्हाला रेखाचं THR करायला आवडेल का ऐश्वर्याची इनिस्कोपी करायला आवडेल? नाही, you can only one.
No, I can do both. So
No.
although I have stopped doing scopies from around 2007-8, I think. So
करणे सर, तुम्ही आता सगळ्या ठिकाणी प्रेसिडेंट म्हणून इलेक्टच होत आहेत. जर कुठल्या पार्टीने ऑफर दिली तर राष्ट्रवादी की बीजेपी?
Well, I am beyond politics.
उत्तर द्या सर, उत्तर द्या.
फक्त वन लाइनर.
I stay close to the politicians, but not too close. What I feel that they are like a fire. Stay away from there and take their warmth, but don't go too close. So I stay away from the politician. I don't go in any politics.
Okay, sir. मग ठीक आहे. Not political party. If tomorrow you have to leave one association, either MOA or POS, which you will leave?
First of all, I'm a life member of both the associations, so there is no question of
official
living
post,
in association.
official post.
Official post now, certain doors they get closed when you go ahead. So once door.
Sir, एकच उत्तर द्या.
गुगली.
प्राईम मिनिस्टर झाल्यानंतर MLA नाही होऊ शकत ना.
योगेश, तुला घरी बायको आयर्नमॅन म्हणते का कूलमॅन म्हणते?
Depends on the mood.
बायको घरी आहे म्हणल्यावरतीच खुश असते.
Yogesh's next question. See, you burn 40 calories at least when you kiss someone. And at the same time, if you run, you will burn the same calories. What you will do?
No, if you run for 1 kilometer, it is 70 calories. You should have told this me earlier.
So the question is, for burning calories, what you will prefer, running or kissing?
बायकोला kissing.
म्हणजे you prefer physical exercise, it's not that necessary.
Is there any difference in burning calories of the wife or the girlfriend?
Govardhan is the expert. Govardhanच्याकडे डेटा आहे सगळा.
Parag sir, if not an orthopedic surgeon, what you would be?
If not an orthopedic surgeon, I would have been a good lawyer.
Now, when the wife finds you kissing somebody, त्यावेळी double burn होते.
Double calories.
The real expert.
बरं. Next question मग वाकणकर सरांना. If you are kissing, which part of the body pains a lot?
You're kissing. Which part of the body?
Pains a lot.
Pains a lot.
ऐकू कमी येत आहे.
Brain.
No. Body part. If you're kissing, which part of the body pains a lot?
Why should it pain? It's all about pleasure, right?
नाही sir.
It's all about pleasure, right? Where is the pain?
If there is pain anywhere, they will go off.
सर हाताची बोटं गाजर किसून बघा एकदा 1 किलो.
I didn't know it was a trick question.
Sir, Yogesh, first crush, year of crush आठवतंय का?
Year of crush.
Meaning?
6th standard, mountains.
करणे sir, crush. College.
I can't expose. You know, there are so many things. there were so many crushes.
बरं करणे सर तुम्हाला काही वेळेला पेशंट डिस्चार्ज घेताना डिले करतो, थांबतो नाही का, मला अजून दिवस दिवस राहू दे हॉस्पिटलला फॉर वॉट एव्हर. त्याचं कॉमनेस्ट कारण काय आहे, म्हणजे घरी बायको खूप त्रास देते म्हणून पेशंट असा वागतो का यू हॅव ब्युटिफुल स्टाफ अराउंड?
वेल इट इज द अदर वे की जनरली पेशंट आम्हाला सांगतात लवकर घरी सोडा म्हणून, असं आहे.
वाकणकर सर, खूप इरिटेट करतोय पेशंट. हाऊ डू यू मॅनेज दॅट? क्विक, वन लाईन.
With patience.
Parag sir.
I refer that patient to Hemant Wakankar.
Yogesh, do you get angry on patients sometimes?
Not overtly, but covertly. I don't show it.
Okay, Parag sir, has your wife developed, you have developed for your wife a selective deafness yet or not?
Long ago.
Married for too long. Obviously, it happens automatically.
So all are sailing in the same boat, I feel. Yeah.
Sir, how often you have changed the plan with your family to go out, Karne sir, because of your academic and orthopedic commitments?
No, the family is already used to that within the first 5 years. So till we go out of the house, they think anytime the plan can be changed.
One regret, Yogesh, in orthopedic practice.
Orthopedic practice? One
regret.
Actually, none.
Parag sir.
Yeah, lack of time for the family, to be honest.
Wakankar sir.
I don't regret anything in my life.
Karne sir.
Really googly? The regret is, I couldn't build a bigger hospital, which I had a dream, nothing else.
बरं पराग सर, एक क्वेश्चन कॉमन सगळ्यांनाच म्हणजे की POS प्रेसिडेंट तुम्हाला परत व्हायला आवडेल का? करणे सर तुम्हालाही परत व्हायला आवडेल का? आणि जर झाला तर व्हॉट शुड बी द विल यू बी?
I will be if the circumstances are such.
You are past president, so.
No, so if the circumstances are such that there is nobody and you know the post is light vacant, I will take it very happily, and I'm sure I'll do a good job because I have a lot of experience. I was 2013-14 the president of POS, and if the opportunity does arise, with love and liking, because I like these kind of positions.
What is the funniest thing a patient has ever said it to you, Yogesh?
To me? Well, you look too young.
Karne sir, funniest thing by a patient to you.
What?
Funniest thing a patient has ever said to you.
तुम्ही अजूनही 30 वर्षापूर्वी दिसत होता तसे दिसता.
Wakankar sir.
I can tell you a small story about maybe 20 years back. I was sitting in my clinic and a patient came from far away place and started asking me about my father. Where is your father? You know, I want to see him. I was wondering why. And he said, no, he's the one who does joint replacement, right? I says, no, sorry, I am the one who does. No, you look too young.
Oh.
It must be your father. And that patient was really serious. And I said, there is a serious problem with the way I look. So Next time, when I went to cut my hair and the barber said that you have a bit of few white hair, shall I color them? I said, please keep them. That's very important from my practice point of view. Those white hair are really important.
Parag sir.
So I don't know whether this is the patient was being funny or trying to give me a compliment, but I still remember this in the young days when I used to do trauma. I had done one tibial nailing, closed tibial nailing. I went for rounds and the patient was there looking at me and she said, thank you so much, you've done a great job. So I said, thank you, we are going to be discharged today. So anything you want to say? Yeah, she says, I hope I have an accident again and come back to you for a nailing again.
Oh.
Honestly said that, but I think that was funny.
Yeah.
Not a compliment.
One about the presidents, you asked about the past president to be a president again or not. I will say now the young generation, young means below 50 also young generation. Now they are so much experienced, so much exposed. There is no need for us to become president anymore now. They are the one who can take this, you can say the boat of the POS to still a higher level than what we had done.
Thank you, sir. Now you all are very famous surgeons and everyone recognizes you everywhere. And just want to ask you, enough of orthopedics, one thing you want to do if given a choice. Starts from Yogesh.
Well, go on a world tour, cover all the mountain ranges.
Parag sir.
Yeah, do a lot of traveling and see the world, at least see 100 countries out of the 200 plus countries. That is what I would do.
I mean, exactly same what Parag is saying. Otherwise, very happy and contented with my life.
Karani sir.
Well, my real passion is the yoga and the meditation and the mind power. Had I not been an orthopedist, I would have gone in that field.
Beer or wine, Yogesh?
Water.
Parag sir.
First beer, then wine.
Hemant sir.
I think I transitioned from beer to whiskey, but in real moderation. I mean, it's only one. That's beyond which I can't have much.
Karani sir.
Well, it depends upon the company and what you get at that time. You know.
What the company is doing to you.
But if your gender is changed, what first thing will you like to do? Yogesh.
If your gender is changed, first what?
First thing you will like to do.
Not harass my husband.
Nice. Parag sir.
Yeah, if my gender is changed, I would like to, attract many boys around me.
If my gender is changed, I would like to marry Hemant Wakandkar.
Well, that was I was going to answer.
Sir, patients come to our clinic and they have that gouty arthritis, something like that. And आपण generally म्हणतो, beer patient, they always ask whether I should drink beer. कारण त्यांना beer पिल्याने gout वाढतो किंवा arthritis वाढतो. So what is your take on it, Yogesh?
Is that a medical question or a trick question?
Sorry. Since you said gout, me फारसा लक्ष दिलं नाही.
Just repeat the question for him.
Beer पिल्याने gout होतो किंवा uric acid वाढतं.
I'll refer the patient, both of them.
Parag sir.
See, whatever you tell the patient, he is not going to listen. Just take the medicines properly. That's what I will tell him. And irrespective of what you tell him, he's going to continue to drink.
Hemant sir.
Yeah, I mean, you can only advise them, but you can see in their eyes that whether they're actually, listening to you or they're going to do what they want to do.
Well, I will tell him if you really love the beer, have the beer as well as take the medicine of the gout with that.
Okay. Good. But आता एक क्वेश्चन, बसंतीची मावशी इफ तिने ठाकूरला राखी बांधली असते तर त्यांच्यात काय नातं क्रिएट झालं असतं? शोले पिक्चरमधलं बसंतीची मावशी असते आणि ती ठाकूरला जर तिने राखी बांधली तर त्यांच्यात काय रिलेशन होणार?
तुझा तो किसिंग सारखा प्रश्न आहे त्यामुळे ते तू उत्तर देऊन टाक.
नाही त्याचं कारण एवढंच असते की ठाकूरला हातच नाही तर ते राखी बांधू शकत नाही.
ठाकूरला जन्मापासून हात होते.
बरं आता आपण आता क्रिकेट IPL इज गोइंग ऑन. रिसेंटली रिटायरमेंट हॅज बीन गिवन बाय कोहली ॲज वेल ॲज रोहित शर्मा. तर एनी प्लॅन फॉर दॅट? म्हणजे बाकी सर्जन्स विल बी लिटिल गेटिंग मोर बुस्टेड बाय यू गाईज.
Can you repeat that again?
रिटायरमेंट प्लॅन काही आहे का थोडक्यात?
सिनियर लोक रिटायर झाले तर नवीन लोकांना चान्स मिळतो. तर प्रश्न
बाबा,
आहे, कोहली रिटायर झाला
आता
आणि
थोडं काहीतरी बरं चाललंय, कुठे रिटायर करतो?
पराग सर
I would have loved to retire yesterday.
I can do that any moment, no issues.
करणे सर
नाही, जोवर ब्रेन आणि हात चालू आहे तोवर चालू आहे.
आता प्रॉब्ली वी आर ॲट द एंड आणि सो आम्ही रिटायरमेंटचा क्वेश्चन अगदी शेवटी ठेवला होता. आय जस्ट रिक्वेस्ट द डिग्निटरीज हू हॅव जॉईन्ड अस टू सिंग वन सॉन्ग विच दे लाईक फॉर 30 seconds each one. Or you can have
One regret I have in life.
एकच हां, जीवन also okay. हां,
Somebody just about half an hour back was telling me that he likes my voice very much.
Oh man.
But one regret I have in my life is that I cannot sing. I cannot sing. My voice is not suitable for singing. No, I think everybody will rush out for lunch quickly.
Sir, आज होने दो.
Everybody will rush out to lunch quickly. So
We will love to sing, but then the
Okay,
hall
I
will become empty.
agree. Parag sir.
चल के तुझे मैं लेके चलूं एक ऐसे गगन के तले
जहाँ गम भी ना हो, आंसू भी ना हो, बस प्यार ही प्यार चले एक ऐसे गगन के तले.
Thank you all of you. Dr. Wakankar, Dr. Sancheti sir, Dr. Panchwak sir and Karne sir for this wonderful googly and of course you all. Thank you.